principle is adults want to know why they did love. The adults put time and energy into learning if they know benefits of learning and cost of not learning. Therefore, to enhance learning, make it case for the value of learning, and provide practical examples that are of direct relevance. The second principle is the adults bring experience to learn. The experience will be a resource for themselves and other learners. But the prior learning also requires. And therefore, to facilitate learning, we must know about their experiences and relate new ideas to the past. The next principle is a principle to take responsibility. A learner prefers to be in charge of their lives. They want to be responsible for their own decisions and as being capable of taking responsibility. To incorporate this principle, we must discuss learning goals that empower them to learn. Conduct clear tests, provide periodic feedback, and help them modify goals. Adult learners like to be respected. Adult learners like to be treated equal. What they are doing and have a role in directly with own learning. It is therefore important to treat them like future colleagues, make them work hard, and involve them in department activities. Adults are also adults like to be able to apply new knowledge. We must incorporate scientific activities, role play activities in bed and dry labs, simulation labs, practice demonstration, and other informal. It is known that the two dimensions of learning are perceiving and processing. As exemplified in this book, learning that. Let's begin in the part 1, where there is diverging first. The adults that move on to assimilating the new knowledge that we provide, if that is put to activities that lead to conversion of this new knowledge. And then they reflect or apply this new knowledge to new activities, then make that relevant. It is therefore important reflect while setting learning goals and also after providing feedback. You can do these using projects and practical exercises. Let us now see how do we incorporate these principles to learning. Whenever you are intending to provide new knowledge, please experience which allow learners to experience personal. Provide them personal meaning for acquiring this. Second, provide them new knowledge to various needs. integrate the experience with continuous analysis of other more concepts of analysis of the code and with personal benefit, practical benefit. After benefits emphasize new knowledge in community relevant institutional problems. And this will make an apply the new knowledge to more complex experiences. And thereby synthesize and new knowledge into practical application. The curriculum and the new knowledge ask the whole related to the experience and development strategy. Video learning concept just journal project and author. Let's participate into projects, simulation, role play, case discussion, technology. And it's with into a new situation. So these titles, the adult will be able to offer the in real time situation. To summarize, adults and children have different level size and needs. And as an educator of adults, we should be able to incorporate different learning styles. Yes, to be happily into one teach practice or a learner and incorporate. What it requires is creativity. Thank you very much for your time. Here are some of the references that you can use on the time.
Thank you, Dr. Prashant. It was a wonderful talk. In fact, rightly pointed out, adult learning is definitely different from children learning, and the benefit they will have with that learning is very important to emphasize. Then only they'll go into it. We, being doctor, we are learning right from so many years. We keep on adding on to it, and we go on to fellowships. In AIOC, we have SSTC, TSTC. All these are planned in a way that they add to our practice, practically oriented they are, and all enroll into them and they learn from them. So we need to take responsibility and keep on learning. And wonderful talk.
Yeah, I think if there are no questions, we'll go to the next talk, Dr. Olika.
Yes. So
Thank you, Dr. Prashant.
So the next talk is also a recorded talk by Dr. Anna Gabriela Palace, who has been a member of ICO and a very integral part of Ophthalmology Foundation. And she's received her doctoral degree, PhD in ophthalmology from Sweden, and is a recipient of several awards and grants. May I have her recorded presentation, please?
Dr. Gabby Palace, right?
My name is Anna Gabriela. I am General Manager and Associate Professor for the Department of Technology, studies the language and studies of and also am the chair of the Ophthalmology Engagement Education Forum. The objectives for this presentation are that by the end of this, we will be able to apply some key evidence-based principles for preparing and delivering. First, let's define what is an what elements define an effectiveness? Is it the fun that people have during the lecture? Is it that it's presented in another format, which is friendly or a format full of information? Is it the level of satisfaction that you show when they leave the room? Level of understanding and attention of the students during the lecture. Work College Clark, which is specialist in instructional design, defines principles for outstanding education as one that incorporates proven methods to help learners build knowledge that is relevant to their job. It is designed to communicate or teach information in facts or concepts and is not intended to build skills. It instructional methods that promote technological processing. It incorporates visuals that promote learning and avoids visuals that defeat learning. Uses techniques to engage convenience with the presenter and or with one another. It incorporates examples that are relevant to the working environment of the attendee, and is green and does not monitor. In this segment, I will cover these three. An effective presentation is engaging when it includes instructional methods that promote the psychological processing of the lecture's content. An engaging presentation is organized to provide learners with a logical structure to incorporate new learning and connect it to what they already know. Like a good three-course menu, an organized lecture starts with an introduction, followed by the body lecture, to end with a conclusion. Start with the introduction. The introduction, like a preview of the presentation, should include goals and objectives of the presentation, the relevant or important content, and an outline of what will be presented. For establishing the goals and objectives, it is crucial that you know your audience. Who are they? First year or third year residents? What do they need? General information or deeper knowledge? What do they know? Is this their first contact with the topic, or is this the last one for a series? The verbs we use to define the objectives should be concrete, specific, and measurable statements about what the students will be able to do thanks to them. For example, instead of saying that students understand the anatomy of the animal, it is better to expect them to sketch the anatomy of the animal. This is an observable action and one that we can easily accept and are open to pure interpretation. Similarly, instead of using learn the treatment options, we could use to list the treatment options, a more observable and measurable action. When thinking about the relevant content, we need to plan how the content will be relevant to the student, not to the teacher, but mainly to the student. Adult learning principles inform us that adults need to know how they will be able to use what they are intending to learn in their real life. So we need to make sure not only to include relevant content, but also to explain this relevant to the student and how they will use the content in their jobs or in their life. And this is also key for gaining your learner's attention. There are different strategies to do this. You may help them know what they don't know through questions on the topic, for example, over a clinical case. You may also help them connect new knowledge with what they already know. This is an effective way of building up knowledge. And as we already mentioned, explaining the importance or the relevance that the topic will have for them in their jobs or in their real life is one more way of getting their attention. After the introduction, we get into the meat or the body of the lecture. You don't need to present everything that has been written and out there on the top. This is Gilbert's cartoon, where you see Gilbert presenting 400 slides. You are there to present the key, difficult to understand or controversial topics. Use cases to increase motivation, so students can integrate part of theory into what happens in real life. Telling them your experience is another way of making theoretical content more real and applicable. Base your statement on high-quality evidence and updated literature. And our lectures end up with a conclusion. The conclusion should be a take-home message for your students. A term that can take the form of a summary or a review of the main points covered during the lecture. Summarizing the structure of the lecture is like a three-act or a three-course menu with an introduction that includes the goals and objectives, the importance of an outline of the presentation, the value of the content is presented that should be relevant, concise, important, and updated, and ends with a meaningful conclusion. The second aspect of authentic presentation that we will cover is that presentation should be visual. A visual presentation is one that incorporates visuals that promote learning and avoids visual fatigue learning. The objectives of this segment are that you select the slide background, color, and text to make your slide easily readable and not distracting, that you replace text by images whenever possible, and that you display data in a way that is easy for your audience to understand. Let's start with selecting slide background, color, and text to make slides easily readable and not distracting. The preferred color for the background is controversial among authors. Dark backgrounds are usually more formal. Aided lighting does not interfere with text is read, and are usually recommended for large layers. Light backgrounds are usually more informal. They tend to illuminate the room, so you need to consider that they may cause glare to some extent and are better for smaller venues. Probably selecting the right color for contrast is even more important than the background per se. In the box on the left, you see that blue over black is not comfortable enough to read, while white provides an excellent contrast. Colors of the same palette are not a good choice for optimum contrast, as you can see gray text over black for the third line. The same principles apply when selecting colors for white or light backgrounds. For typography size, it is recommended that it needs to be of 24 to 28 points. The general rule, think of designing for the last row. Use big fonts. Summarizing, try to be minimalistic and design uncluttered slides. Select clear backgrounds, harmonious colors with good contrast for the text, and big defined fonts of at least 24 to 28 points and sans serif. The second key aspect we need to consider when designing products is the use of vision. And by this we mean images, videos, animations, etc. It is advisable to avoid slides with long lists of bullet text and blocks of words per slide. They will literally kill your presentation. Take a look at this slide about fluorescence and geography for defects in the pigment of the TV. I have purposely written a lot of words and included these two small pictures down here. You will not be able to listen to my explanation, read all this written text, and look at the picture. So how could I improve this slide? Take a look at this new slide. I have enlarged the graphic of the picture, added some explanatory keywords to the graphic, and I will verbally explain to you how fluorescing is seen through a defect in the retinal pigment epithelium and why this phenomenon happens. Think of how you could improve the delivery of my message in this slide. If you answer using a video, that is probably the best option. I will use a video to explain all the clinical features of implants. Finally, we need to discuss how we take data in our presentations. This is something we do quite frequently, to send data from a paper or from our own research. And as you can imagine, it is really difficult for someone who is listening to a lecturer to read all this information in the very short period of time that the slide is on screen. I usually get very frustrated because I can't figure out what the speaker is trying to show with the data before he moves to the next slide. This is a table from a study that reports the difference between self-reported ocular disease in a census conducted to a Latino population and what authors then found in clinical examination. The study showed that self-report was less accurate than clinical examination by physicians, which may lead to a significant underestimation of the disease burden. How easily are you finding it to get that information from this table that I am showing so quickly? Now take a look at this other graph. In orange, you will see the number of patients with self-report having cataract, age-related macular degeneration, glaucoma, or diabetic retinopathy. And in gray, you will see the number of diagnoses of these diseases that authors discovered. See how cases duplicate for cataract are 10 times more for AMD, compared 50 of self-report to 500 for clinical examination, etc. Don't you find it easier to understand the data when it's presented like this? Take a look now to how the study was cited. It isn't likely that someone will read this full citation in this very small print. To get the full article, people only need the name of the first author, journal, year, volume, and pages. So if you display that is that, it is usually enough. Sometimes it will happen that you don't have time to prepare a graphic like the previous one, but at least point clear to the audience, for example, with a circle, at what part of the table they should be focusing, and explain the numbers. I would say here, for example, look the number of cases for cataract, almost 500 self-reported, compared to 1,000 that were diagnosed by clinical examination, duplicating the number of reports. A presentation that leverages social preference is one that uses techniques to engage us indeed with the presenter and or with one another. Social preference arises from communication between the audience and the speaker, as well as among audience members. The presenter should invite social preference by looking and sounding approachable rather than unapathetic. Ideal speakers are approachable, use conversational tone and language, smile, maintain eye contact, reveal their own opinions or experiences relevant to the intent, invite questions and comments, encourages interaction among the TV, and in general makes students feel comfortable with them and among themselves. Making our lectures interactive is key for focusing our students' attention on the topic, considering that attention spans last for barely 10 to 15 minutes. We can use audience response systems with traditional clickers or mobile applications on your phone that allow questions and answers during lecture. Audience response systems increase students' attention, allow teachers to estimate if students are understanding what is being presented, and are aligned. So students that are shy or slower respondents have the opportunity to answer as well. You may have your students split in small groups or peer-to-peer discussions during the lecture. And if these strategies are not possible, for example, when speaking in front of a very large audience, you can pose questions even when you don't expect your answer from the audience. These questions will help your audience keep connected and focused in the content that follows. In conclusion, the take-home message for an outstanding presentation is that they should be engaging, and by this we mean should be organized, a clear introduction, high quality content, and a meaningful conclusion, should be visual, using non-structured images and presenting data in an easy to understand format, and it should be interactive and encourage constant participation of the students with the teacher and among them. Thank you very much for your attention.
You can just stop this for a while.
Yes.
After this,
My name is Ana Gabriela.
no, you keep the next ready, you'll have a small. So good morning. So we thought since it's a recorded presentation, we'll have a small, this is a very important topic. And any teaching, whether it's undergraduate or postgraduate medical teaching, I think it has something to do with the local culture of the country. Whatever she has been told is a more of a generalized outline. And we need to take the relevant points and extrapolate some of the things to our Indian context. So I think since we have a galaxy of teachers here, I think it's important that before you go to the next talk, which is also a recorded talk by Dr. Gabriela, we'll have small interaction. I want to ask you, like, the lectures by the faculty is not the MCI or NMC recommendation. Like in which, I mean, anybody can probably, answer this question. Do you have regular faculty lectures in your institutions? Not for postgraduates. So the postgraduate just 2 years ago was probably an intern or a final year, final MBBS student who had the lectures from morning till night in our medical college. So just after spending 1 or 2 years more, how did he actually become, so independent that he doesn't require a faculty lecture? The Western universities, Stephen Hawking with all his disability used to give a faculty lecture. So that means, where is the role of a faculty lecture? Normally, we harp on the student seminars. The student prepare a PowerPoint of 200 slides, self-made, borrowed or downloaded, with all the animations, all the GIFs, all the nonsense in it, and they come and present it. So it is up to us to really go through that the entire heap of information deluge to find out the relevant points. So basically, ours is more like a facilitator, but a faculty lecture would actually give a vent to your eminence-based medicine, or what you have gathered, your information through your such a vast clinical experience. So what are your thoughts, sir?
We do use, in our institution, we do use faculty lectures. I think once a week we have a lecture for the resident where the faculty gives it actually. In fact, we have 2 forums in our institute where the faculty talks to people. One is the lecture. We call it the basic lecture. And we discuss actually very basic things there. And the other one is a research oriented, and that's called a staff meeting. So the senior staff, they have their research presented, so every week there's a meeting for that. So I think, and that is very useful because, students, they have their own way of kind of dealing with the subjects, and they have read it, no doubt, but I think they would be, mostly their role is mostly, you don't actually emphasis not on the factual knowledge. They know they have access to that knowledge. The important thing is to integrate that knowledge into,
sort it out.
yes, sort it out, to convert into, that they have an information basically, but to convert that information into knowledge,
Usable knowledge.
yes, so that takes a little bit of experience, and that's where I think the role of the faculty.
Because I think they do not know what is the exact, what is the right information.
Yeah,
But
so
all textbook may not be the relevant.
Yes, to get the concepts clear, I think that's where the role of the faculty comes.
Role of a facilitator.
So faculty could be anyway in that, anyone in that sense, like some postgraduates do a good job, no doubt about that. But I think because of the experience, the faculty is more suited for these things. And the other things from the research point of view, they actually generate a lot of new ideas, and they ask you questions which you might not have thought about it. So I think we find these very useful, these 2 forums. So we have regularly 2 interactions with the faculty.
Okay. One more question. Any innovations in lecturing? Okay, yes, ma'am.
Thank you. In Shankar Nethralaya, we did 2 things. One is, before a student presents in any conference, be it the state conference or it's All India conference, you have to present it in the auditorium once for everybody to critique. That was one. The second thing was, we realized asking the faculty to prepare a lecture and present it, sometimes they're a little reluctant. They say they're too busy. So after the conference, we call it the TNOA Express or the AIOC Express. Whatever they presented there, they will present it in the class to the students. So it is already ready, and it's usually succinct, short, 15 minutes presentation.
They've already done it once.
They've already done it once. And so it is not extra work for the faculty. And at the same time, the students benefit because very few would have actually attended that in the conference. This way, everybody benefits, the optometrists benefit, everybody benefits. So this is.
Yeah, I know. I can relate to this. The PGs outside my institution know my lectures than my own PGs.
I think, points were really highlighted. The faculty has to be there as a prominent person in a teaching program. And it is duty of a person, if you are faculty in any teaching institution, he has to deliver to the students whatever new thing is coming or whatever is your routine practice has to be done. As Dr. Pandav rightly told, like faculty does take a classes, but the classes which we take for our postgraduate students are different than the type of presentation we do in our conferences. They're totally different. The conferences presentation are normally 7 minutes, 8 minutes, 10 minutes, 12 minutes, which is not a comprehensive teaching for postgraduate students. It may be highlighting something. For a postgraduate teaching, is actually the skill of a teacher is tested, because he has to make a person understand, because you have a student who may be just a beginner, you have a student who may be third year in their course, and they have a different level of educational expertise or a knowledge. So you have to keep that in mind and structure your lecture in such a manner they benefit all of them. So this is one important point we have to understand whenever you're taking a lecture in a class where you have a different sets of students are there. And it has to be authentic, because most of the presentation we do may not be truly authentic sometimes. It's my experience. I do like this, I do that way. That is not actual teaching for our students. It has to be authentic. You might say, okay, this is the reference and people have reported this and these are various ways to do it. And this is what we do, and you might take it to the best out of this. So I think the responsibility of a teacher is different in a classroom than a presentation in these conferences. And yes, there are some conferences which are truly different. So you have a research type of conferences where you bring out new things. Your research is presented there. That has to be presented in the house also, because that gives you an analysis of a work which is done by your institution and the other institution also. To give an example, we in RP Center, we publish around 300 publications in a year, average. And our students, they don't know what are the presentation or what are the publication being done from your own center, from your own faculty. So this I agree with ma'am there. It has to be presented in house also, like this was the presentation from this particular group, and this was the outcome, and this is how we presented. So we have, since inception, we do have a journal clubs where we make, resident doctor to prepare a 10 or 12 articles for that particular 3 months or 1 year and discuss that. In that, we make a compulsory part that you have to present a work published from the center also. So that gives you analysis. Your center is also working in a certain area, and what is lacking, what is good, and that has to be discussed. Yeah.
One last thing about, lectures can be boring, both for the faculty and so we need to have some innovation, some masala. So just one experiment we did in our institute, we call it as CLOSE, C-L-O-S-E. That means a class with learning objectives and student evaluation. So what did they just put up some, as she said, some 5-6 learning objectives for the class. Then the class goes on and the faculty is asked to prepare 5 or 10 MCQs at the end of the class. The students actually write that, and we evaluate at the end of the class. Like basically those MCQ represent the context. And if the student has really gone through the lecture properly with attention, he will be able to answer that. So that completely changed the whole thing. Then I came to know that our students were just faking it. They were in the class. PowerPoint is semi-lit room. What they were doing, I don't know. They were not on their mobile phones, but definitely they were not mentally inside the class. That completely changed. And because once if they get a low, like 5 out of 10, obviously it's a standing example that probably they're not attentive in the class. So that changed the whole concept. And also, instead of a class, we would actually post a case scenario in the group before coming to the class, like a squint class. No, we'll put up some 2-3 squint scenarios. And that completely, changed the whole thing. We understood that how our PGs can do a reverse engineering. See, the present fallacy of the present system. For example, if Dr. Padma is giving a class on ocular sarcoidosis, he will say etiology, pathogenesis, management, investigation. But no patient comes with a tag of ocular sarcoidosis. We have been always teaching in medical school this way, but a patient actually comes with some blindness of 1 hour duration, blindness of 1 day duration, blindness of 6 months duration. These patient comes with a symptom. So our classes have to be engineered in the reverse way so that the patient they can, because we are asking them to do the reverse engineering themselves, which sometimes they can't. So anybody here can suggest any of the innovation that I have tried, which has changed the outcome. Yes, Dr. Uma, I expected this.
So we use a lot of animations to show, because sometimes concepts are very difficult to understand.
Okay.
For a beginner also, sometimes even topics like visual pathways and reflexes, the neuro-ophthalmological aspects of it, it becomes very easy to teach the postgraduate students using animations. So I use a lot of animations to, like the visual pathway, upper fibers, how do they
You do?
cross, and I do it myself.
Okay.
So that
No,
helps
ours
a
is the
lot.
animated talk, not animation.
So you don't need PowerPoint, sir. We use a PowerPoint as a means to convey the concepts. It becomes very easy. And quizzing also is another one.
I think quiz is an important thing. I think that really provokes them to actually. I think Dr. Prashna has a talk on this, so we don't want to spill the beans too much. But lastly, before we end, the PowerPoint has been a bane. I think over-reliance on PowerPoint and whatever she told, sort of the basic things, using custom animation, using the right background, not making the content too heavy. I think PowerPoint, they don't have to even make it. There are a lot of slide shares they can even download. So that ends up normally talking too much. So this is the whole idea. I think there has to be some occasion or a provision for a student to actually do a blackboard class. You just ask the student to present without a PowerPoint. That probably brings in the real, the effort and the way they can actually, verbalize whatever the context that they have in their mind. Yeah. I think we'll have this last comment and go to the next topic.
You rightly pointed out, they just do downloads and make a mixture and present it. And even you can save which seminar they have copied and pasted, because we also go through while the topics will going on. Yeah. But one thing I worked out in this is, I said you don't present to me, we fix one mentor to one topic. And we said, don't show us the PowerPoint while before presenting the thing. It is better to write it like a full question, long answer question first. And then you present whatever, how many slides you wanted to present. And according to the time, we limit them to the number of slides. So they write, and many of the time, sometimes surprises, I do shut off the slides and present with the chalk and board. That is one of the things that we can assess with really go deeply they are studied or not.
May I add something?
Yeah, you can add.
Actually, I was thinking, and that's what we were taught in the MED, that in general adult learning, we would want to stress more on, rather than pedagogy, more on andragogy and heutagogy, which is facilitated learning or self-learning. So that is the stage I feel when they come into their PG, that after undergraduation is a lot of pedagogy and lecture kind of effect. Here, if we have to give lectures, it should be like transitional with a lot of questioning and involvement. Or like ma'am said, like when the faculty is going to a conference and coming back, that could be the lecture form for the PGs, but not, I technically feel, not for the actual teaching, because that should be the andragogy part where the facilitation comes in, because we are creating that lifelong learner. And how will they study in future? They'll never get lectures unless it's webinars or so. That is one thing I want to tell them, to change their viewpoint. Like we tell them from 12th standard to MBBS, no, you have to change the way you learn. So same thing we try to do from undergraduation to post-graduation. You won't get lectures, you have to learn and present, and we'll help you learn, we'll help you present. And that's how, we possibly want to try it that way.
Empower them to gain the knowledge and put it across.
In different ways, sometimes seminars, sometimes journal clubs, sometimes case presentations, lots of case presentations. We realize that they haven't done a lot of clinical work in undergraduation. In undergraduation, they've just concentrated on MCQs. So sometimes even during the OPD, if I ask them, what is this? It's coming to my mind, it's coming to my mind, it's coming to my mind. I said, should I give you 4 options? And they will answer it. But they want those 4 options. They've become so primed to the MCQs.
That's what NEET does somebody. neatness to
Neat.
students. Okay, can we have, the next talk is also by Dr. Gabriela. I think we'll just have the discussion going on.
Yes. I would just like to add, KP, so you're absolutely right. I have seen your refraction presentations more than any of your post-grad.
Refraction.
Your refraction presentations, I've seen it more than the post-grad.
Like surgery. I think just a disclaimer.
Yes.
Greetings, my name is Gabriela Pali, and this lecture is about teaching in the clinic. Welcome to Medical Teachers Academy Clinic. A happy patient, the attending physician explaining her situation, the residents able to practice and ask questions, an ideal situation, but usually not a real one. Most of the time, we work at the real world hospital, where everybody is in a rush, waiting rooms have lots of patients, and we don't have time for anything and no time for teaching. The objective of this segment will be to identify good practices for teaching in the clinic, to discuss some strategies for teaching in start time, and to correct ineffective or inefficient practice. One of the learning principles that suggests how we should teach in the clinic is a theory called experiential learning. This theory emphasizes the importance of participating actively in educational experiences, reflection and observation of actions and experiences, creation of meaningful concepts and generalizations, and feedback provided by the instructor. Please pause your presentation and list what competencies can residents learn in the clinic. There are many competencies that residents can learn in the clinic, like, for example, history taking, physical examination and other teaching skills, including all of our considered tests, treatment options, clinical reasoning, and also how to educate and how to handle the information we deliver to patients and their families, how to communicate with patients, ethics and professionalism, concepts of management and resource allocation. And they will also learn how to teach, our professional life perspective, and other interpersonal skills. Let's discuss different formats for teaching in the clinic. There are different formats that we use according to the resident's level of training. For junior residents, the sitting in and the breakout model. And for more senior residents, the apprenticeship model or parallel consultation and the report back model. In the sitting-in model, residents or students observe the patient consultation and interact with the clinician and patients, but don't see patients independently. In the breakout model, residents or students observe a whole consultation with the patient, then take the patient to another room to go over parts of the interview or examination, again at their own pace. For more senior residents or students, in the report model, they see patients without supervision and at an appointed time present them to the clinician. Residents have time and space to interview and examine the patient at their own pace, and meanwhile, the clinician is able to see other patients attending the clinic independently. In the apprenticeship or parallel consultation model, residents interview the patient either alone or supervision. This model is still in use in some places. Students are crowded in the consulting room, attempting to observe and hear the consultation. You can see in this 1925 picture Professor Gunnar is performing a retinoscopy. You can imagine the students probably can't see much of what's going on there. Interaction with both patient and clinician is limited, and patients may feel threatened by the large audience. Please pause your presentation and reflect on your preferred model for teaching in the clinic. Do you use any of these models? Do you do something different? Let's discuss now how we can improve our teaching in the clinic and make it more effective and efficient. Teaching in the clinic has to be planned. You need to talk to the learners about their learning needs in any part of the examination. Be a good example, especially of professionalism and communications. Involve the learner as much as possible and observe what they are doing and give them formative feedback. There are different teaching techniques that you can use. The 1-minute perceptual method was introduced in the 19th by John Asher and others and consists of 5 tips. The first step is to get a commitment from the learner, to get them to verbally commit to an aspect of the case. This pushes the learner to move beyond their level of comfort and makes the teaching encounter more active and more personal. This also shows respect for the learner and fosters an adult learning style. An appropriate question from the preceptor might be, what do you think is going on with this patient? This encourages the learner to further process the information they have got. You obtain important information on the learner's clinical reasoning ability, and the learner is given a higher sense of involvement and responsibility in the care of the patient. Additional examples include, what other diagnosis would you consider reflective? What laboratory test do you think we should get? How do you think we should treat this patient? Notice that questions used in getting a commitment do not simply gather further data on the case. The goal is to gain insight into the learner's reasoning. The second step is to explore what the basis for their opinion was. For this, we could ask a question that seeks to understand the rationale for their answer. For example, what factors in the history and examination support your diagnosis? Why would you choose that particular medication? Why do you feel it is important to do that part of the physical in this situation? The benefits of this test are that you will be able to immediately observe the evidence of their knowledge, their clinical reasoning, and their ability to integrate and use clinical data. The third step would be to provide the doctor with an important general principle that can be applied effectively in the future, or brief teaching specifically focused to the encounter, or information on strategies for searching for additional information. For example, cataract surgery is indicated when visual function no longer meets the patient's needs. Criteria for ordering considered tests in UVIT are such and such. Because of time limitations, it is not practical to do a major teaching session at the moment, but a statement or two outlining a relevant and practical teaching point can have a significant impact on the learner. In order for the learner to improve, they must be made aware of what they did well. Comments should include specific behaviors that demonstrate knowledge, skill, or attitudes valued by the preceptor. This way, you reinforce positive behaviors and skills and increase the likelihood that they will be incorporated into further clinical encounters. Finally, it's important to tell our learners what areas need improvement. Comments should be as specific as possible to the situation, identifying specific behaviors that could be improved upon in the future. You may also include guidance on alternative actions, behaviors to guide further learning. We will now do some exercises on some vignettes. We will see examples of teaching in the clinic before, during, and after the session in the clinic. The good aspects are that he brings in. But he makes no assessment of the learner's needs. He is evidently hurried. He doesn't develop a learning plan. He doesn't show an interest in the learning, and the learning environment is poor in general.
Hi, my name's Alan. I'm interested in what to do that. I can't spend a little bit of time on that volunteer vacation. It's a little bit. Things you do to accomplish that. Well, I think going to politics, so I love that. I know that they sometimes doesn't. They're great. Have you had any chance to work with the school now? It's very well. How's this happening? We focus on degree and get that's almost an but skills, so I can give you a chance to go in and see the page of the degree. You work well, you spend some time and focus on this book that. So when I go to a conference, I can do that. These are some of the formal company presenting some and then you go around using the slow back. That sounds great. I'm sure you know a little bit about the slow back and some of the features. The other thing I want to mention is that during the day it gets pretty hectic. Sometimes you don't have as much time as you'd like to talk about each case. But we have any particular interests or questions, go ahead and jot them down, and then at the end of the day, we'll come back to address each one. Okay?
Some of the good aspects of this completely different session are that the attending conduct activity assessment, outline the learning plan, and the environment is good in general. Something that could be improved is that it could have provided more concrete objectives.
He's got a little bit of the he said in the past, he's had control before that topic, but a lot of things about it. If I'm just doing it, you can check. Well, the medical student told me that you were having some new onset of flashes and blurs. Tell me the actions. And up until that time, everything was fine. Have you noticed any change in your vision and your visual field? Okay, well, everything checks out really well. First, I don't see evidence of retinal tear or detachment. This is just a posterior separation. Some of them are normally good news is most people do really well without any risk of blah 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 blah. But I don't think that's something that we can do real well. Do you have any questions on?
The good aspect of this presentation was that he let the students stay in the room to listen to the explanations he gave to the patient. The bad aspects are that he doesn't listen to the student's presentation, he gives no feedback, he does not promote further reasoning, does not evidence support the student's reasoning, and did not include him in the consultation.
Yeah, the public good is so what came on all of a sudden. He said he had no paying fees. He was talking about that as well. There's other things that experience it having quoted, but in the process of life. It's not part of this. It was pretty good class. I measured up this history of significant for others. So it sounds like he was doing very well. What? That they were based on totally what? Maybe what? Which keep on example. On example, people who have to call when they were because complicated really as well. So nothing seems to have very clear. taken through different step. So we have a 56-year-old gentleman here that claims some onset of bias floaters. 50,000 miles with you, for what we call what is heard that causes a lot of kind of worry. Are there any features about its history that contribute to it? Yeah, we're referring to the policy. People who are nearsighted may have increased risk of representation. What's going to get it? It's more sure than it needs some more. Down next 30,000, service. It's okay with you, I saw down, we can make some of this examination skill. You know, everything turned out well. I'm seeing evidence of lack of care. You're going to do well with this. Now, your report over the next 2 weeks, keep an eye on this plan. Anything change, you want to hear from you. Thanks. You have any thoughts about how the major leaders separate the most? Yes, this actually has the regular required towards 6 to that. Exactly right. We have in certain areas, countries that are strong and that countries separates the people care. Real important things, any moment you want to flash two words, you want to have in common for examination right away. And then examination needs to do that.
In this completely different case, the attending listens to what the student explains, makes questions to clarify the findings, asks for differential diagnosis, teaches general concepts. Something he could improve is that he didn't reach the finding and he used technical language in front of the patients.
Appointment with my secretary. I'll be again next week. Okay, talking about the states. There's a really good textbook in the ophthalmology library. I'm just spend some time with that. Very often we explain several patients haven't been about that patient we saw having was kind of curious, you know, how do you exactly tell whether it's a bacteria or hole or it just looks like? It's a good question. We actually differentiate between true hole and straw hole using the silver sample. And our way to do that is to put on this lens volume and then we shine a very narrow beam of light right in the center of the vein. This true light of the hole is going to be at 1 spot and need one. The patient will say that there's space missing in the center of the beam. If it's straw, when you see the penetrant memory, and that beam of light will be continued, you know.
Which one? Dr. Jyoti? Huh? Dr. Moy? Okay. Okay. We have 2 recorded talks by Dr. Mohammed Moin. So this was the 2 talks by Dr. Gabriel on improving lecture skills as well as teaching in the clinics. Now we go to how to set up a wet lab. So how to set up and run a wet lab. The talk is this is a recorded talk by Dr. Mohammed Moin. He will also be joining for any discussion online on Zoom. Can we have the talk?
We'll be covering both the topics, how to set up and run a wet lab and teaching in the OR, that is surgical skills training. Rolika, please play the videos.
I think these are overseas setup. I think we need to customize these things to our, I think these are all things that we see. We have 30 postgraduates to handle. We have a busy OPD and we don't have a one-to-one interaction. So these are all very ideal situations right from a Hollywood movie, but we need to kind of extrapolate the principles to our and customize it to our needs. Reading so far, our going and will be presenting on how to set up wet lab and how to run it. And I'm thankful to the Joshi Institute for organizing this meeting at Pedagogo. And I think setting up a wet lab is a very challenging task initially to set up it, but this is something which is very necessary for all the residents. I'm working at the Agricultural University in Lahore, in Pakistan. It's great to be here to be working with the Ophthalmic Education Foundation. So, what are the first steps? You have there 5 steps. You set up the physical phase, establish appropriate faculty and curriculum, taking the practice eye, then you have stabilizing the practice eye, preparing the eye, and funding the wet lab. So those are the steps which are needed, and we'll go through them one by one. So what is the physical phase we need to have? So first, we need to have a wet lab room, instruments, a coordinator who can be a separate person or resident or chief resident, and cleaning facility of that area. And this is the diagram from Rachel's paper, which you can see what we need is a space for 2 people, for a person who's going to be observing, the person who's going to be doing it. Either you need a microscope with a camera or a TV scope. Ideally, I think with a recording, it would be best to go through for the procedure and step for the person. Then paper machine and tubing are necessary, and they should be so that the trainer can see and the person who's performing it can do it easily. You can see that the table to which the legs go in, and you can do the microscope with the foot pedal and the paper mapping. The instrument is a complete camera set, then you need to have sutures and the nylon wipers, glove, blades, dustbin, refrigerator, microwave, storage cupboard, and air conditioner. These are such things which we are very used to, and new spec, except for the microwave, that is used to make reduce cataract in the roadside or part of the presentation. Then we come on to cataract set, standard set with future poster, McPherson, needle holder, simple camera, and a scissor, and you can see all of them. So the next step is the wet lab curriculum. That is the most important thing. You know, the first year, I think the aim is to know all the instruments of the cataract trade, use similar instruments in the wet lab, and have first year call for the next instrument in the senior resident case. Then we go on to the next step, which is demonstrate placement of tender nylon suture, either a 14 caliber or displayed at the end for resident or attending. So these are the steps you can do with wet lab, and you can have them do in the OR as well. And basically what you try to do is come up with an eye coordination under the microscope. Third one is demonstrate the ability to hold and place an eye, and you can place it in the animal eye, you can place it at the head of the vicinity and the OR. I think that is one of the simplest procedures you can do under guidance when you're doing the OR. And knowing that I can use the OVD, use coincident, first the OVD, you can use that in the coordinated OR experience. And then the demonstrated ability to move PD with IA. I think that is we done in the lab and in the OR experience. If you learn Pedagogo in the reverse in the OR, it is the best. I think the easiest is to do IA when you are inside when you put the IA in, and then that is some of the things you can do a migration to at that time as well. Then you come on to the second year curriculum. Now you want to go on to more complex procedures such as doing the capital directives, the user. For that, you need to use the primitive modified 49, which go through that in later steps. And I think you do it with a needle or this stone, and how you do that with use our process. Second is to demonstrate the ability to place the groove in the needle. It's slowly going to the table.
that is the easiest part. Make the group tracking is become difficult. Then the second part is demonstrate the ability to use the second instrument or the dialer or the chopper or any instrument with which you create that eye. And then, I think that is difficult to do in animal eyes because they are very soft nuclei unless you make them hard. But in synthetic eyes, probably they have come up with different ways of nuclear which you can practice. Then it go on to demonstrate the ability to create a clear corneal vision. So you see, this is something which is coming at a later stage because if you stop, because this is something which we think is easy, but it's not that easy because if it is not good enough at the start, then all the surgery does not go well. Then, the third thing curriculum, we understand the physical parameters, how we work with bottle line, which leaks, and how to control the vacuum and go away. So you can use it when you are in the OR, and surgery. And then the third complexity is that is demonstration of vascular tension rate that can be done in the animal eye. Then you go on how to complete the eye. That's pretty simple. You have one is the treatment center in your home hospital. You have a rejected or unrejected cornea, or the other thing is you use both sides, or you can use forcing eyes as well. And the third is a wax or artificial eye made up of from the material. So fourth step is stabilizing devices. So the has a styrofoam head, which with the eye stabilizes into the styrofoam. The cone is dry, very unstable, the head can talk with the manipulation. So why you actually need the styrofoam head? Because you need to mimic that hand placement during cataract surgery. So this is the simplest procedure. The next one is an oval device, like small funnel bulb over the back of suction. Embedded in the styrofoam head. It can be difficult to achieve authentic eye stability, but it's more stability with a simple styrofoam head. So here is the second step, the oval device. Then you can have a Mandel eye mount, which is a plastic bulb holder, in which you can put that eye. You can see that suction stability there. With that, you can make some suction over there. That tends to make the eye up. The only drawback is that you do not have the head or the American head, so we cannot practice the placement of the head during surgery. And the fourth one is, I think the more complex one is the tablet device. The Corello device is multiple parts, including a plexi bulb holder and a better reflector plate and a PVC base support. Complicated step allows training of all anterior segment complex procedures, reflector plate, and from the optic. This is the thing you can see. This is can also be used to checking for blood pressure in the Perkins or the slit lamp as well. This is something which is very useful. Then you go on to something which is spring action apparatus for fixation of eyeballs. So this is called David is not used initially by Rama Krishnan and for doing basic study. Here you can see you've got a paddle holder, you put the eye, and there is a suction at the bottom part, which makes the eye hard, which you can see. And then there is a mannequin head with which you put that thing and so you can do that surgery immediately over there. So this is a good setup to use for spring action fixation. Then you can have a simple setup. If you do not have anything, then you can have a full roll fixed with bottom rolls. You hold the gold eye and then have mounted on rectangular thermocol that's shown by the doctor and training model for figure classification. Then you go on teaching and training devices. I think all of you are working in India, so the modern innovative possibility that company is doing a great job. And you have the eye stand with a fixation head, or you're going to have phaco bracket eye with a fixation head. So you got this thing, you have eye stand, eye mount stand, and you have a phaco bracket eye. It's available over there, and if you have access to that and the funding is there, then it's always very wonderful to have to do surgery practice on that. Then you go on to separating the eye and fixing the capsule of the animal eye and inducing cataract. So how do you fix the capsule? Anterior capsule of the big is take that and more elastic and feed more oil like a pediatric capsulotomy. So a mixture of 0.3 scale for formaldehyde and 170 scale for mobility. Mixture overnight at room temperature. This mixture is placed in the 14 anterior capsule. The capsule will be markedly different to make more closely resemble the human CI capsule. So methods of inducing a cataract in an animal eye, like we said that 14 eyes, 9 seconds, quick cataract but not very dense. Then you can have chemical reduction, which is a solution of formalin and propanol, or cataracts of different grades can be generated, but this tends to be more costlier. Or you can have a cataract surgery implanted into the capsule, so you remove or sort of vacuum out the capsule, the cortex from the animal eye, and then put the dense cataract, which is removed from the intracap or an extracapsular surgery in a patient and put there, and then you can do Pedagogo with it. That's a good thing. And then the last thing which you need to have the funding for the vaccination for ophthalmic surgical expired products in the operating room and gone to the surgery. So you can see these are the different steps which we go through when we want to set up a wet lab. But I think the most important step is your determination and structuring thing and sort of going on to collaborate with all the departments. This is something we're going to do, and it's a must for all the residents to do during the first year, second year, and they're not going to get ready until they show competency in that. I think that is one way of hosting that use of wet lab. Obviously, I always tell my residents that it is what we want is that we should be the same surgeon. So whenever you do surgery, you do not lose your confidence doing surgery because you're not able to perform good and you remember complication. So you can come up with any complication in a wet lab. So I'm going to have that kind of thing when you're doing live surgery. So training professionally surgery cannot be done by reading textbooks. So the next step you need to have hands-on training for the real operating or simulated physical environment, and virtual reality simulators are in training for future surgeons. And we all know it's a very expensive machine, but they are very good at giving you different tasks, different challenges for practice surgery. But until they are not available to each and all the training centers, wet lab remains an important part of cataract surgery at this time. Thank you very much for listening, and I wish you all the best for this course.
Can we have the second talk also? Yeah.
And after that, I think we have a talk by Dr. Jyoti Bhuyan. I hope Madam has already uploaded her presentation. And then we have Dr. Ragini Madam later.
Hi, welcome back, and I'm on the point again from Pakistan, and I'm going to do the second part of the presentation, in which we're going to how we teach in the operating group. And I'm grateful for the Joshi Eye Institute again for arranging this session, and this is going to be on operating in the OR as I said earlier, and I'm working at King Edward Medical University. And this is something, the objectives of the course are to define the principles and then develop guidelines for doing this thing. And the principles are, number one is patient safety, and then everything revolves around it. So to start off with patient safety, to say that you need to optimize your resources, you need to control your processes, give feedback and your results, and you go and look back, and the main objective is make it better all the time. And so we go on to the first part, patient safety. So the instructor's main objective is to prevent complications and not to fix them, and choose the right technique best for the patient and not for the surgeon. I think this is a very difficult part to explain to the residents because they always want to do the complete procedure themselves all the time. But we need to tell them that if there is any problem, you need to sit back and let the other person take over, then do step, and then come back again. So instruction main objective to prevent complications is to anticipating complications. So you all of this is going, something is going to go wrong. At that time, I hold that person hand. If you're sitting in front of a microscope with a type B, and change places and show him that the residents in family and change and needed. I think that is some example. Don't let the capital residents get too near to the border of the people. Don't let the residents go spear fishing pieces of the nucleus into the capsular bag. So those are two examples, but there are multiple examples which happen. But I think the other thing which is more important is whenever you're doing it, you ask the residents not to make any abnormal gesture, or if you are supervising it, don't go and say, oh, what did you do? That's very wrong. Patient is listening, most of the surgery is being done under local anesthetic and it is not under anesthesia. So choose the right technique which is best for the patient and not for the surgeon. So obviously a corneal incision is faster, but the corneal incision is slower because this is the stigmatism. Corneal incision has white eye or the corneal has a red eye. So I was the other day sitting by my resident and he said, I work corneal. I said, well, I still prefer a corneal because my results are better. And the astigmatism is more with the corneal and less with the corneal. Obviously, the endophthalmitis is more with the cornea compared less to the cornea. So the right choice, have to filter that into your residence. The next is to optimize the resources which you have. So if you look at which are our main resources, number one is your operating time. Number two is the patients, and the third is the instructor time. We don't realize the operating room is running with an economic cost, and there are also patients in line next to come in. So we need to have that room rotating. You can't stop that room. So in order to do that, which we need to realize, we have to sort of sit with the resident and explain to them this is something which is very important. How can you optimize that? Practice in the wet lab. We already discussed how to set a wet lab, but this is so important to the resident, and they are always very hesitant to go to the wet lab. They always say, why not online patient? And those net residents will step in the operating room until they are proficient in the wet lab. And we already went through the different curriculum of wet lab, which can be done through the first 3 years of the training. So how can you optimize patients? Assign wisely, match resident ability in the eye. A right-handed, right eye, left-handed, left eye. Very important in the start because this makes them very easy. They are in their comfort zone and they can do things very easily. Then you come up with a hard nucleus or a soft nucleus. You already get an immediate nucleus is usually best for residents. Very soft nucleus are added on. Pupil dilation is very important and not easy to do on small pupils. So I would encourage not to do that. And even family guys, if you want to do them, I think the best way is to do a reachable drop to bring the eye up in and get it at a slightly crossed over, then you can do it. But obviously, these are things which you need to avoid so that you can optimize the patient. And then choose the set. Don't need to complete the study. This is something which I always have. Fast steps to perform the resident ability. If you can do that step, then give him those steps next time as well. Dry steps that cannot be practiced adequately. And combining resident, if you have a first year and a third year resident, a fourth year and a second year, you can say that if you do these steps, you can do the other step. So both of them get a chance to learn, and both of them are able to do the step. Need to end up with a safe outcome. The patient safety is the most important. Trying to move one surgery in a row. So how can it be optimized in some system which is very precious because he's doing engaged in multiple other things that are happening. So who should teach a senior resident or staff instructor? Combine residents with their ability has something to do during the test act. I think recording of the procedure is very important. And sometimes we have to take a rubric. The students can come up and the residents, they can show the video and they can improve on that. But obviously, when they're doing on their own, you need to have senior-junior relationship working with them. But the senior instructor needs to be there most of the time. So the next step is to contact the processes to control backlog activity, surgery assignment, surgery step, and performance during surgery. What processes should be controlled? The backlog activity, daily achievement should be recorded, and their consistency should be demonstrated, which is very important for that. The surgery assignment, prior to school residents, same number of surgery, PQI 2 versus PQI 2. Then giving a feedback is very important. I think doing a talk with them, I think very important. Have them do the surgery, record the surgery, and because when they're doing it, sometimes they don't know what they're doing. Come back and you can sit with them, review it immediately after surgery, because they need to reflect what they did wrong, and they need to know that this is the way they're going to do next time. That is, I think, one of the very important things. And then we cannot expect someone to do exactly what we want until we tell them exactly what we expect. How should we tell them? Define what is required, define the objective, show that the confidence has been achieved, and describe the process to attain the objective and use the rubric. It goes to that, the paper rubric designed by IQ, Pedagogo, and Gabriel Talent, and model it in all the work of that. That's a wonderful tool because they know all the steps which they need and they know what is expected in their confidence. This is a behaviorally accurate assessment tool in which you've got on one side in the left column the steps which you need. On the top, you've got the different steps in which you tell which is the proficiency, and then for each proficiency, for each step, you've got the different behaviorally accurate sort of steps to tell you this is what is needed from the resident to be confident. And the last thing is measure their results. The number of surgeries makes the person perfect. So this is a real final which tells you that the surgery you're doing is the surgery of that you show how that while you're doing surgery and the OR, it is the health part, the more critical part, and it's the highest level of assessment. So the proof of that confidence is demonstrate you can do it. So I think you're telling that the topics are there for after the small snake after surgery and peripheral, and that will come there, even more usually there's one on previous surgery as well. All this will come and surgery, so all that is our management concept. Then the next step is downhill, then follow the lead of the resident regarding the refinement of things while the resident accomplishes the next step of the procedure which is efficiency and recognizes critical transition point. And the last step, which is no help, so the attending surgeon provides no unsolicited advice, monitor the progress, ensure patient safety. If there's anything needed, he always does that. And the resident performs the procedure with an experienced person and safely complete the procedure, recover from most errors, and recognize when to ask for help. So these are the 4 steps of the learning of the resident, for the British model for training and assessment. Goes on to the no help part, means that he's confident at that level, and that is exactly what we want. We need to take into all the 4 steps of do and tell, hard help, down help, and cold help. Very important for the resident to recognize that help is something which is always there and needs to take it at the right time to come out with easily from all the difficult situations. Communicating in humor, as I always talked earlier, sign language is the most important. Low voice, tell patient will talk to the nurse. Take the paper, speak slow, help me keep the nuclear center.
Thank you. Thank you so much, Dr. Mohammad Moin. I think he's online. Can we project his screen? Any questions do we have for Dr. Mohammad Moin? Dr. Mohammad Moin, you're there?
Yeah, I am here. Thank you very much for excellent meeting.
Thank you. Thank you.
Thank you.
So Yeah, we heard both your talks on how to set up and run a wet lab. So there's one question from Dr. Dastikop here. Where is there anything where do we get most of these wet lab equipments at one shop, or do we have to?
I think if you mean the wet lab equipment, I just showed you in between from India. There's a company which does that. I think Madhu or something. That company does all the microscope and the other things are okay. Otherwise, anything specific you're asking about?
Pardon?
Anything specific apart? Was it the things which needed which you
No,
were
the
concerned
simulator
with
machines and everything. Yeah.
The IC, that is the simulator, the virtual simulator is in Germany, I think, and that is an expensive machine, like might be like $100,000 or something.
Yeah. Yeah, I think yesterday we were discussing. It's in Tanjavur also. They have put up a simulator where they have both the FACO simulator as well as the VR simulator. In Jipper also you have. Yeah.
Yes.
Okay.
In Pakistan, we have it in Aga Khan, in Karachi.
In
And
Mumbai
in
also,
that you
Help
can
Me
sort
See
of,
is doing the same.
Yeah. Yes, Dr. Moin, you're telling something?
I think we have one in Pakistan as well in Aga Khan. That you can simulate different parts that you can simulate and it's very sort of exciting.
Okay. Thank you so much, Dr. Moin. We'll connect with you sometime again in future meetings. Thank you once again. And
thank you for the invitation.
And happy Ramadan to you.
No, it's actually Eid today, so it's the finishing of Ramadan. So
Okay.
Yeah, thank
Eid,
you.
happy Eid. Okay. Thank you so much. Thanks for joining.
Yeah. Okay.
Yeah. So can we have the next presenter, Dr. Jyoti Buyan, madam? So she'll be speaking to us on how to train to be a good comprehensive ophthalmologist. Can we put her slides, please? I request all the speakers, because today we have a jam-packed program and we have promised that we leave. Madam? 7 o'clock, I said. 6 o'clock. So we have promised that we should end it up at 6 o'clock, and so that all of us can go to beach. Sir? 5:30? Sir, bidding शुरू हो जाएगा. कुछ लोग 5 बोलना शुरू कर देंगे. Okay, we'll try to finish early. So I request all the speakers to please stick to time. Thank you very much.
Respected distinguished faculties, a very good morning to everyone. Before I start, I'd like to thank Dr. Honovar, Dr. Joshi, and Dr. Krishna Prasad for organizing such a wonderful interactive academic event. So my introduction, I just want to give my introduction. I am working as a director, HOD of Regional Institute of Ophthalmology in Guwahati. I have joined service long back in 1988. Still then, today I am serving. So I have completed almost 35 years of my teaching career. So during that period, long period, I am producing a lot of comprehensive ophthalmologists. Today I am going to talk on how to train to be a good comprehensive ophthalmologist. I'm happy to talk about on this topic because I'm a generalist or a comprehensive ophthalmologist. And now I'm happy to say that Dr. Anna Gabriela, she is also a comprehensive ophthalmologist. So how to train to be a good comprehensive ophthalmologist? So on introduction, a comprehensive ophthalmologist is also known as general ophthalmologist. who can provide a broad spectrum of eye care like vision care, diagnosis, and treat all eye diseases, perform eye surgeries, and prescribe and fit eyeglasses and contact lenses. Even they can manage emergency situation and expose to community ophthalmology. General ophthalmologists are basically they are MD or MS, but after MD or MS, one sometimes required in comprehensive ophthalmology again because some of the students they are slow learners. For those students, they need at least one more training in that field. Now, residency training is one of the crucial phases in making of a sound comprehensive ophthalmologist. It transforms a theoretical generalist, that is your MBBS, to a practical specialist to gear up to take care of the responsibility of caring for the patients. Acquisition of knowledge and necessary clinical and surgical skills is the prerequisite for providing optimal care to the patients. Now, ophthalmologists, they spend 2 years of residency and it is a hospital-based training. During residency, ophthalmologists, they receive a special training in all the aspects of eye care, including all the areas like vision care, prevention, diagnosis, medical, surgical treatment of eye conditions and diseases. Often an ophthalmologist spends an additional 1 or 2 year training in a subspecialty that is a specific areas of the eye care like glaucoma, pediatric ophthalmology, etc. Now, comprehensive ophthalmology is a lot to offer to residents who want to develop a broad set of skills. While practice patterns do vary between individuals, a comprehensive ophthalmologist may care for patients in all stages of life, from refractive correction to medical and surgical care. It was quoted by Dr. Alan D. Early from the Cincinnati Eye Institute. According to her, it's like a little bit of everything. A comprehensive ophthalmology just might be the right fit for you. Now, what are the qualities of an ideal ophthalmologist? It's a lifelong pursuit of perfection, passion for excellence, astute observer, likes one-on-one interaction with patients, action-oriented, genuine compassion for patients and their predicament, and willing to adapt to this rapidly advancing field. Now, what are the academic skill they should acquire by that is by lectures, it may be in-house faculties or by guest faculties, by holding seminars, case presentation or case discussions, then journal club, and with a good library, one can acquire both usable and practical knowledge. Now, clinical skills involves daily effort, hard work, making a habit, comprehensive eye examination, starting from simple visual acuity to plus 90 diopter examination, IDO and gonioscopy in selected cases, discussion regarding lacunar restricted examination and possible investigation, and the management that follows the presentation is most rewarding. The surgical skill, the beauty of ophthalmology is a sight restorative surgery. It requires lots of patience and eye coordination and dexterity. Now, weight lift training, just about the weight lift setup. So, it's a building block of a surgeon's skill, and it is an indispensable component in the armamentarium of a teaching hospital, and it helps a training to develop skill in a risk-free environment. Even in my institute also, without attending or without practicing in weight lift, we do not allow a student to touch a human eye. The weight lift practices, what they practice in the weight lift, suturing with tangerine either in thermocol or animal eyes, practicing sclerocorneal tunnel, practicing capsulorhexis, using wax or animal eyes for doing phacoemulsification, placing a rigid or foldable iron in the animal eyes, practicing automatic anterior vitrectomy after breaching the capsule in the animal eyes, but presently ophthalmic surgical simulator is the best training method for the residents. But we all are not fortunate to have this surgical simulator. And in my institution, sorry. So in my institution, that practicing in automatic vitrectomy as well as phaco emulsification is not possible because we will not be able to afford the machines in the wet lab. The machines which are available, they are using in the OT. So complications during training. We know best of the surgeon have made mistakes while training. Whenever a mistake is made, reading and discussing about it so that it is not repeated. It is all right to make few mistakes, but however unacceptable not to learn from them. Recording steps of surgery and reviewing those videos are very useful, and safety always comes first, then speed while training. Then comes soft skill training. The students should know about the nowadays about the ethics, behavioral sciences, health economics, communication, compassion, leadership, and professionalism. Now, CB has presented again ATCOM, which you all know that ATCOM is attitude, ethics, and communication. And the students as well as faculty must have a broad knowledge on ethics. So, an article has been published where it was found that 99% of faculty they agreed that learning communication skill can be helpful in personal and professional life. But 74% of the faculty they found an increase in the incidence of complaints arising due to patient dissatisfaction because of poor communication with them. So now to be a good, competent, comprehensive ophthalmologist, do not forget to be a successful surgeon. You must have the eyes of a hawk, the heart of a lion, and the hands of the lady. Thank you. Thank you for patient hearing.
Thank you so much, madam. I think it was a very insightful thoughts that you provided. I think we'll have more discussion in the panel discussion time.
I think you may have a question might arise whether this comprehensive ophthalmology it will survive in future or not. Because the whole world is changing, world becomes more and more complex, and each area of ophthalmology is so wide and extensive. It is very difficult to master even in one area of the ophthalmology.
Yeah, before Ragini madam puts up any comment from any of the members here, should a comprehensive ophthalmology should continue, or it should be more like the fellowship kind of training, and then now MCH now coming into the pictures, and many people are vouching for MCH degrees to be recognized by the universities. So if that is happening, then again it's going to be probably 3 years of the fellowship training. Yes, madam, you had some point.
Comprehensive is the way to go for PG training. It will, that is going to continue and it will be there. The 3 years of PG training should include everything. So, and then the subspecialty training is a separate thing. So that has, so somebody who's interested in doing a subspecialty training will have to go for the fellowship. So the comprehensive ophthalmology is not going to die. And comprehensive ophthalmology is much better than actually during residency, residents, when they are put on rotation every month to various subspecialty clinics, they learn nothing. So they think it's not for them. And so unless they, it's better to be a comprehensive ophthalmologist during PG training.
Thank you. I think we can have more discussions later. Now I introduce our next speaker, Dr. Ragini Parekh, madam. I think she doesn't need any introduction. She's already the star.
So we'll
the head of the department at Regional Institute of Ophthalmology and JJ Group of Hospitals. So she'll be teaching today on how to train to be a good cataract surgeon. So it's a very interesting topic because that's the bread and butter for each and every one of us.
Thank you, Srinivas. So I congratulate Dr. Srinivas, Dr. Krishna Prasad and Dr. Santosh for, I think, the first of his kind program for bringing all the teachers together. And congratulations and thank you for the invitation. My teachers, Padma Shri Dr. T.P. Lane sir, Padma Shri Dr. Tityal sir, Dr. Pandav sir, Dr. Prajana sir. I think there are 3 generations of teachers, because then Rolika would be the youngest. So thank you and all the teachers, all my senior teachers and friends present here today. I think for the last few talks, my talk will be an amalgamation of everything that has been discussed. So, I think this is the summary of the last few talks that have been going on. It is very important to have hand-eye coordination because we are looking through the microscope, operating downstairs, and we have to hear if you're doing phacoemulsification. I'm a lefty, and sir had to learn to use his left hand to teach me capsulorhexis. And then I learned to be, I am ambidextrous. I can write with my right hand also, but I had a difficult time to do phacoemulsification. We have to learn to be very, very gentle because I did 6 months of general surgery where I was assisting liver surgeries and hernia hydroseals. And luckily, I did a lot of embroidery and my hand. So I have to tell some of my male residents to be really gentle. You need to have foot switch control. Not only that, knowing to be a surgeon also involves a lot of things. So we know residents, they want to learn only cataract surgery. And sometimes sir tells them that, do you want a degree in ophthalmology or cataractology? That is all that they come for. But that we have investigated so many cases of endophthalmitis. So we have sent residents to set up the OT, and sir has sent residents to prepare the OT for a surgical camp because that is more important in view of all these things. Preoperative is very, very important. Everything in the checklist, from starting from isolating infected patients, putting a shield and everything, and the anesthesia, the drugs and everything. So it is, besides the cataract surgery, so many things are important. And every surgeon in the OT should be a very, very good physician. So that is important. Stepwise training, like we've been discussing, adequate wet lab training. I would like to answer your question about the wet lab. That Appaswamy or some people have given us a few microscopes. We use, and some companies have Marty's head. And if you, in Mumbai, we stay in Bindi Bazaar area, so the availability of goat size is very high. They are very cheap. And whatever little discarded instruments or little rusted instruments you have, or something that you don't like to use, or you can buy spare sets for students, attach it to a TV and you can teach them. So it's very easy, not very costly to teach them. Very important that the cases are selected as we have seen, because if there's a deep set eye and all, they have problems, and if they have a complication, then they go back 2 steps. Surgical audit, it is not only the surgical audit, but discussion of each and every case. The resident has to be present during rounds in their post-op to see where they have gone wrong and how they can improve. Not only residents, I think sir and I, we do 150 surgeries, but we also evaluate ourselves as to how we can do better. One day we had very dry corneas, the next day the pupils are dilated. So we were wondering whether it is iridocyclitis. Even at a camp, we saw the patients on slit lamp and we realized there was something wrong with the betadine wash. So everybody needs to have an audit, not only the residents. It's extremely important. And see and learn. The residents will observe what you do and do exactly what you do. So it is very important that you come on time in the ward, you take pre-op rounds, you behave with the patient. So what you do is what they will do. So that is extremely important. Everybody has to work on their weak aspects, and you have to convert a trainee into trainers. That we've already seen that the seniors can teach. Adequate wet lab training is very important, but this is not something that the students like. They don't want to do the wet lab training. They want to directly operate on human eyes. And this is where the resistance is very, very high, very high. That is what our observation is, that we plan all this, but to actually make them do it is extremely difficult. In Mumbai, we do have a simulation setup and we do send our residents for simulation training. So you have to choose a cataract properly, surgical audit weekly, working on the weak aspects. Like, you can make out that they don't know how to do the tunnel. They are getting stuck in the rexes. or I was always getting stuck in the rexes, and that is how sir started doing left-handed surgery. So you have to know what is their weak point. Luckily, I'm a left-handed surgeon, and we every year we have a left-handed student, so it helps. So these are the points. Simulators are very, very important. Since the simulators came in, our residents are telling us that definitely it has made a difference. The trainers are very helpful, and it has made a difference to their lives in learning. So even today, if I have a PC rent, I'm quite upset. And so are the residents, because they so sometimes, if they get a PCR, they are more upset than if they have corneal edema the next day. And then I have to tell them that the corneal edema is a worse thing. So you have to handle the cornea much better. So, PCR is something that everybody dreads. And the second time, like I was assisting a resident because my lecturer was not there and the tunnel was bad. And she came to talk to me. I was very careful that I encouraged her and I told her it's okay, because otherwise, if I had fired her, I think she would have gone back 10 steps. So you have to be very careful as to what you talk to them. And post-ops or evaluating is very, very important. So when I was learning, sir and everybody taught me that treat the cornea like God, which is extremely important, extremely important. Sir was a phaco trainer when he first came to Mumbai, and they were being charged money to learn phaco. And sir was teaching, and this person said that, no, I won't give up the case because I've paid so and so money. From that day, he stopped teaching as these money phaco workshops, because it is very important for the child to know that the patient is most important. And what happens is that they are not guinea pigs. In our area, if one patient is messed up, that whole area, the whole community stops coming to you. So you have to tell the residents that it's okay to give you cases, but then at the end of 6 months, there won't be any cases left for you if the patients don't come. So then what will you do? So you have to explain to them. Surgery is not a race against time. I was a slow learner. Now I can do 120 surgeries in a day, and I can be happy about it. But I was extremely slow because I used to feel that the patient is important. I was left-handed, and my friends were much faster than me in learning SICS and phaco. But at the end of the day, it is the patient who's very, very important. So it's not that today you start surgery and you call up your friends and they did 20 cataracts. So you start the scleral tunnel today and you have to finish the surgery today itself. It's a very, very specialized branch, and you cannot learn cataract surgery in a day. So we have to tell them that you have your whole life for cataract surgery. You learn it step by step, and the patient is extremely important. Real goals are very important. I have to be very, very careful, in my mind, not to compare, not to talk about them and counsel them individually, because sometimes when you are taking rounds and all, even I make a mistake of comparing. So I try not to say very good for the best case and very bad for the worst case. If 5 or 6 residents have operated, it does affect them. So the conclusion is that each of us have a very different learning curve. Teaching is all about motivation. A good surgeon is a good and humble human being, and adequate training and converting trainee into trainer is what a teacher's goal is. I don't know how good a teacher I am, but I can say that Lahani sir was a very good teacher to me, that I learned everything from him. And I'm still learning, and I'm so happy about these teachers conclave, because it is not about what good we do, but at night so many times we feel incomplete, and we always, now that they have given us more and more students, it's more stressful because we always worry whether we are doing justice to them, we are making them good surgeons. So I think that it is not only their learning, but our learning in life also, which is very, very important. Thank you for the opportunity to be here and be amongst teachers and friends, and for the first time, and I hope such a thing goes on all the time. Thank you so much.
Thank you, Dr. Ragini. It was a wonderful talk. We all are learning, and we'll keep learning, and we'll keep teaching and motivating our students. So next talk is by Dr. Guru Prasad. He'll be speaking on how to incorporate essentials of medical retina and basic surgical retina.
In the meantime, I would like to call the panelists, Dr. Navneet Saxena, Dr. Mahesh Babu, Dr. Vivek Nayak, Dr. Kamath Prashant, Dr. Shrikant Joshi, if they are here, to please join in the front. So
Dr.
now, request Dr. Guruprasad sir. He is one of the senior most vitreoretinal surgeons of this part of North Karnataka and Goa and even southern Maharashtra. He started the first practice of vitreoretina at MM Joshi Eye Institute, and he is one of the senior most vitreoretinal surgeon and the director of clinical services at MM Joshi Eye Institute. So, sir will be speaking to us today on how to incorporate the essentials of medical retina and the basics of the surgical retina. Over to you, sir.
Please ignore this slide. Yeah. So thank you for this opportunity. And in the words of Dr. G.N. Rao, mentoring is all about shaping the 3 T's: talent, that is inherent with every person; technology usage, guidance; and tenderness exercising. What is the ideal layout of a fellowship program is what I'm going to talk to you in the next 9 or 10 minutes. And I'm going to share with you the model which we practice at the MM Joshi Eye Institute. So when it comes to vitreoretina fellowship, vitreoretina is certainly different from all other specialties because of various reasons, obvious reasons. It is not taught like other specialties in residency, which we have discussed yesterday and maybe today also in the morning, and usually needs to be taught from basics during fellowship. It needs weeks of practice to master basic examination techniques, for example, the IDO and the 90-day examinations. Maybe similar to the gonioscopy that is taught in the anti-segment. The findings in the vitreous and retina are so subtle, similar, and diverse that it takes long to familiarize with even the common signs. For example, yellow spots, the reticular pseudodrusen versus the drusen, the confluent drusen, the hard exudates, and the exudates in the choroidal diseases might all appear similar to a beginner. And the level of hemorrhage, a subhyaloid hemorrhage, may not be easily differentiated by a novice from a submacular hemorrhage. So the safety margin for certain steps of surgery is so little that it is only in the later part of the residency that the resident can be allowed to do certain steps under supervision or independently. And the diagnostics and surgical equipment are prohibitively expensive for a vitreoretina setup, and it is difficult for most of the residents to start a full-fledged solo practice. So mass work in a medical college, again, yesterday we had discussion on this, is in one way amazing. How this can see 2,000 patients in half a day is something. For example, in GNEC, I was told that they can see 2,000 patients, of course, with a team, versus the style of working of private institutes offering fellowship. And because of this, most fellows are in for a cultural shock when they come to the fellowship institutes. The OPD etiquette and the OT etiquette are something that is different in different institutes. Every institute has its own SOP. Timekeeping and punctuality, addressing patients with respect, which is very difficult in mass work, ensuring privacy and confidentiality, giving a patient listening with empathy, and then OT etiquette, that's a different ballgame altogether. All this amounts to the discipline. In one word, discipline of every institute is different and one has to get adjusted to it. What I do is in the first month of fellowship, I put them on the camera. I ask them to take pictures and I ask them to read the pictures and take the help of the seniors or the consultants to help them to find out what the signs mean to them. So studying images and familiarizing with findings and signs is the first 1 month that all residents will do. Emphasizing the importance of slit lamp examination. Somehow or the other, residents who come to the retina department think that they want to learn only retina and they ignore signs in the anti-segment. For example, a trap bleb might be missed, a buckle which is outside the fornix or in the fornix, which needs a little eye movement on the part of the patient, is sometimes missed on the slit lamp. So spending time is very, very important and nothing is to be missed. And a nebular cornealoplasty, for example, which might be a cause for low visual outcome after cataract surgery, is something that can be missed easily. So methodical slit lamp examination, one has to ensure that the resident knows well the slit lamp examination. And one most important thing which I tell my residents is never miss the no cost, most useful test in ophthalmology, and that is RAPD. And I penalize them for not checking RAPD in a patient who has less vision in one eye and good vision in the other eye. If RAPD has not been mentioned, they're done, they're thrown out of the OT for 1 week. And one thing about retina is that learning to include anterior vitreous examination on the slit lamp, or that is the anterior vitreous cells, is very important. 2 examination techniques to master during a vitreoretina fellowship is IDO, indirect ophthalmoscopy, and the 90-day examination. And one has to spend hours, days, weeks, and months sometimes to master it. And they have to learn to make drawings, color coding with drawings, especially when it comes to procedures that are done. For example, a pneumatic retinopexy patient or a scleral buckling patient has to have a good drawing to begin with. And a drawing check is important. The consultant has to check whether the drawing is correct or not. This is very, very important, and this we have gone through during our residency. Orthodox methods are best. Priming for exams, it also helps the priming for exams, both the method of examination, like taking the history, complaints, history of present illness, systemic history, drug history, personal history, general and ocular examination, everything what is mentioned in the book and what we are supposed to do in exam has to be done for every patient in the workup. Because without this, they will not have the habit of doing it, and habit is what makes them perfect. And this has to be presented to a senior or during a case presentation session in a classroom. So they have to be also encouraged to be good technicians, learning to capture fundus images, perform angiograms, learn scanning, and realizing the importance of a kinetic testing by scanning, learn to acquire the OCT image, OCTA image, and learn about electrophysiology as well. So by making them do it and inculcating in them the questioning, practice of why, how, and what, it has to be exercised at every step. And this is what they learn. The concepts they learn well, then they retain it for long. For example, why is air travel forbidden when gas is injected in the eye? So these things have to be explained to them so that they understand and retain it for long. So teaching in the OPD, I think I'll skip this slide. So discussing is very important. So a rare case, one has to call and show. The consultant sees a rare case, for example, a viral post-fever retinitis. They have to call the resident to see, every resident to see. A bleeding CNVM to a junior fellow, or a ILM draping sign in Mactel again to a junior fellow. This was something that I examined and passed it off as a drusen of the optic nerve head. But I told the consultant, I told the fellows to go and read up, and they came back saying that it is actually an optic nerve hematoma, and that is what it turned out to be. On autofluorescence, you can see the hematoma. Tailoring investigations based on clinical diagnosis. There should be no senseless list of tests. Just because HIV tests and hepatitis B antigen tests are part of a template which we use for other procedures, for example, cataract surgery, doesn't mean that it has to be practiced even for a patient with fluctuating refractive error. And without BP testing, never send a patient for MRI imaging. These are the two examples which I usually tell all my patients, and that is how we train them to save the money of the patient. Prescriptions have to be neat and legible. Nowadays, it is all printed, but if it is written, it carries more. We develop a better rapport with the patient, and there should be no overwriting. There should be clear-cut instructions. I'm sorry. Some water, please. And writing a letter to a referring doctor, replying to a referring doctor in the own handwriting of the doctor makes a lot of difference to the referring doctor. Learning injections, usually after 3 months in my institute. This is done under supervision, after observation, and then they do painting, draping, and injection. And after every injection, they're taught to check the vision of the patient so that there is no fear of central retina occlusion. Learning lasers, I think this is just an example of how a novice cannot burn the fovea in a patient like this. Subhilar hemorrhage covering the macula, the fellow cannot burn the fovea, and therefore these are the best cases to start with. A senior can teach the junior, teaching this junior how to hold the lens. In the second year, they're given a little authority, freedom and independent responsibility, sent for peripheral postings to the secondary centers, and involved in discussion with the consultants themselves and take their opinions. So, and one thing that we do is to encourage the seniors to teach the juniors. Community work must be mandatory because there's an opportunity to exercise skills, and that large number of patients, there's a good chance of the volumes are helping them. Surgery also helps them a lot. And they inculcate compassion and empathy. About surgery, I think the first and most important is, as we have seen in the morning, patient safety should not be jeopardized. The fellows enjoy this the most. Surgery is one thing that they enjoy, that gives them a kick, a sort of kick, or a booster, a morale booster, and hands-on gives them the maximum satisfaction. So one thing I want to tell in this context is that cataract surgery has to be done in plenty by these aspiring vitreoretinal fellows, because cataract surgery is one thing that it is one of the simplest looking surgeries, but the most complicated surgeries. A good cataract surgeon can mature into a good surgeon in any specialty. And I prefer a person, before he takes a fellowship for vitreoretina, to have done at least 100 surgeries, 100 cataract surgeries, and Dr. Ragini probably will agree with me. Tools for explaining to residents, we have the Ingenuity, so they can actually flock in large numbers, which we don't usually allow. This is just for the photograph that I've taken this. And the initial steps of surgery should include OT etiquettes, scrubbing, gowning, gloving, and all these things. I think that's a different talk altogether. And done in a phased manner without jeopardizing the safety of the patient. And some examples of, I think I'll skip these videos. Localizing during a sterile buckling is something that is to be taught, because this is a very crucial step in sterile buckling surgery. This is something that we have to check after the fellow has done it to know whether he knows what to localize during a sterile buckling surgery. And the buckle, of course, I will skip these because for want of time. And some initial steps of surgery, like actually this can be taught by the senior colleagues, senior residents to the juniors. PVD is something that they all enjoy doing, which is not very difficult. At the same time, gives them a real ecstatic moment when they do it. I think I'll stop at this. And ILM peeling is something that they feel is ultimate. Actually, it is not any deft-handed person can do it. This is not very difficult. But somehow our residents seem to enjoy doing ILM peeling. Complex surgeries at the end, of course. Video editing is one point which I would definitely like to say that it helps a lot in learning, understanding the initial steps, and they get a sense of involvement in the surgery. And of course, there is Google now, YouTube now to help them to learn surgery. So again, in the words of Dr. G. N. Rao, we empower them with the 3 H: hands, head, and heart. 80 to 100 surgeries is what they normally end up doing in 2 years in our fellowship programs, which includes 10 complex surgeries, and by which time they'll be very confident. So before I end, I would like to say that the resident should really love their specialty. So if they don't love it, you can't flog an unwilling horse, but good mentors can make them fall in love. Thank you very much.
Thank you, Dr. Guru Prasad. for such an enlightening talk. I would now like to call upon Dr. J.S. Titial sir for his talk on magic recipe. How does RPC train its resident? We all know Dr. Jeevan Titial. He is currently chief and professor at RB Center, AIMS, New Delhi, and is credited with performing first live corneal transplant surgery and has innumerable awards publication to his credit. We welcome you, sir.
And he has also operated on many presidents and prime ministers of India. So we have the pleasure of having Padma Shri Dr. Titial sir here with us today.
Can I have my presentation? Good morning, friends, the teachers, gurus, all of you, deserve my pranam because you are the building block of this country in terms of training a right person to handle the masses, the people who are suffering. And thankful to organizers, especially Srinivas and our dear friend Krishna Prasad sitting there, and Santosh for a kind invitation. I think we had a very nice presentation on training of students. And actually, these students are actually going to be trainers themselves. Actually, they are the teachers for future. And I've been a part of RP Center for quite a long time and very, very fortunate person to be there in this premier institute to enjoy the status and the establishment of this country's premier ophthalmic patient care teaching research area as such. No financial disclosure from my side. You all know it's been there for more than 5.5 decades, serving the country in all regards, not only for a teaching, for making the planning for a blindness control program with this country, institution of many programs which will highlight the deficiency of this country in making the availability of resources to every part, every corner, and establishing the 3-tier system in ophthalmic care in visit. It was Professor L.P. Agarwal who established this institution and had the concept and the future vision of establishing something which will be workable for everybody, and looked into a ophthalmic scenario, not only a small department. At that moment, thought of making a multi-specialty institution. I think the institution word came from RP Center. Otherwise, it was a department, which was a small department in the medical college, sometimes clubbed with the ENT department most of the time, and OTs which we shared with either with ENT or gynecology. So that was the status before this thing came out. And he started at that time only 1967. There were 18 specialties at that time itself. So he called as a sub-specialties, and it was true that it had a different meaning. Today, we all know the meaning of these subspecialty of our concern area, but it was meant for a patient care, meant for getting the data out of these areas of clinical importance, and most importantly, they are meant for a teaching. Because all patient coming to OPD, that is outpatient department, where every patient coming, you have no time to look into those important aspects of getting an important clinical clue from a patient and making a differential diagnosis and making management plan. Therefore, these patients were pulled into these clinics and made into subspecialty clinics where the resident doctors will work up them, maybe take half an hour, 1 hour for each patient, then discuss these cases to the faculty and decide the subsequent treatment. That was the genesis for looking for eye as a multi-specialty organ. So these are now current students with us, a huge amount of talent coming to us, and that gives them more responsibility to the institution, to the teachers to look into that. Today we have 51 faculty members in the center, 55 senior residents, and more than 100 residents training at a time, and almost 100 optometry students and 15 PhD students doing their work. And along with that, we have around 50 plus optometry staff and other 400, 500, 600 other staffs to support the institutional work and looking into the entire structure of a medical college and institution is a young generation which supports the functioning. In that way, our resident doctors are the actual backbone of the RP Center and making the effectivity of a care which we provide to them, to the patients. So what sets RP Center apart in terms of highlighting the institutional importance, which we call a national importance of institute? We do attract the best mind, best students coming to RP Center. That gives you a chance that you can train them better. Maybe you can make them much better, future individuals to take country's aspiration forward. So we have technology. I think if I see my own journey last 40 years, 30, 40 years in RP Center AIMS, the technology has changed every 5 years. So you have to upgrade yourself. The institution should upgrade to a status where you can have the access to every technology, not only in a clinical diagnosis, in the management part also, so that your students don't have to look anything beyond your institution for training. So that is what we could do in the last 4 or 5 decades. Establish the institutional infrastructure to cater to every aspect of newer evolving future of ophthalmology, and have the teachers of that quality where they can give to their students. Therefore, it's not only the student who have to learn, it is the teachers who have to learn much more and get more access to a not only national scenario, international scenario, get into various areas of teaching research so that they can be a good teachers. So it is teacher and student relationship which will make the best outcome coming forward. So what this part we have discussed, the clinical areas also, surgical skill, being a good teacher, be a team player, and ultimately, most importantly, be a good human being. Because if we can inculcate these 5 things to our students, definitely he'll become a good future ophthalmologist. For that, as I talked about, good clinician that have to have more knowledge, clinical knowledge, surgical knowledge, and be a good counselor, a good team person, and a good teacher. To be all these 5 things together, you have to have an absolutely good communicator. And today, I think the communication is the one part which has to be, not only to our students, to our teachers also, is the one area which we call communication. If I have to say, which is going to be a most important part of teaching, that is a communication skill, communication, and communication, which will make things appreciable by everybody. We have few important things in our teaching program, which has been there right since inception. One is a bedside teaching. I think this is one area which is still there in the medical colleges, good institutions, where you have a large number of patients getting admitted. RP Center has more than 300-bedded hospital. We do have every specialty admitting their patients, where we can have access of our resident to have more time with the interaction of working up these patients, investigating them, planning for surgery, then have a good discussion along with them in a group. The group means it has to be supervised by the senior person, that may be a senior resident, or it may be a junior faculty. Subsequently, next day, again, you have a morning round with the entire team, with the entire group of faculty of that unit and the senior resident and a junior resident. In our time, it used to be a 10-15 group. Now it is a group of almost 40 people. Sometimes very difficult to approach each student, and sometimes they get hidden behind those groups. But a good teacher will pinpoint all of them and get into that area also. So we all know there has been a decline in this form of a teaching in recent times, mainly because the daycare services has become a major part of our ophthalmic services. Surgeries are daycare. We have no idea what has happened to one patient, how the surgery went, what was the outcome, because patient came and went. Only thing we have are some records of patient, but we actually don't know what has happened in terms of teaching wise. So teaching requires the actual interaction with the patient, because patients are the best resources for a teaching, and have to have a data to assess all these things, have a discussion and plan, formulate your discussion with your senior resident and faculty so that you learn. Learning is a very, very comprehensive program where everybody exchanges the thoughts, and then you can analyze these cases subsequently also. So I would say we heard various speakers also. Good clinical history is also important. Physical examination, the reasoning, and actually looking for what are the bedside procedural skill you have to develop. One thing Guru Prasad talked about, RAPD. So these are things people stop learning. So these are important things which we can be pinpointing them and make them a comprehensive students and learn everything areas. These are few points I'm not going to detail. People can see this slide subsequently. Also, one of the important things which I initiate is a motivating a learning environment, because environment has to be congenial for everybody, not only for a students who come just join. Because if you have a institution like RP Center, people come from various areas of this country. If I have a 10 student, they may be from 10 different states. So everybody will have a difficult task to get used to atmosphere of Delhi, which is a difficult metropolis city. Therefore, we have to make an environment where it is a motivational to student to work further. So that is a pressure which nowadays getting into our resident doctors, because some of them are working more than 12 to 16 hours a day. So that part we have to look into, decrease the stress and look for other mental and physical health also in these areas. What are challenges we are going to face? We are facing now is, one is number of students, because there's a large number of students to satisfy their mainly the surgical load is going to be difficult for all of us, because number of patients coming to the institutional area will decrease, and to give us surgical training also is difficult. Other is people don't have the skill to also, the teachers have also changed in these generations. They become more like a younger generation. Their skills have also changed. The skills of teaching also had changed, and that has to be looked into. Now we are talking about the electronic media. We are talking about artificial intelligence into that. So things would be really challenging to give them a physical time with the patient. That is also important. This was one important thing which we had in the RP Center, group discussions. Group discussion of a group of resident doctors together. So we had the different age group or different semester people together, and they'll discuss the each presentation. Every resident has to go through the presentation. That may be a case presentation, that may be a general club presentation, that may be symposium and other presentation. And before each presentation, Krishna Prasad knows that they had to present this in the group first and get every skill cleared, every question cleared, then come to the house next day. And that made the person in terms of making presentation much more better and more confident. And that is what we produce, a more confident student from RP Center. In every forum, they can stand and speak of these things. So this is what group discussion has looked into, changed. Now you have, if don't have to go through the books also, now you have everything in your hand. You can check the, question, if that is correct or wrong. You can discuss with your internet access you have in areas. The RP Center library used to have a books. We still have books, but now we have at least 30 stations of internet where people can sit and do every work together. Clinical teaching is also very important. As I talked about, we have a system where patients are pulled into clinic and you have a better teaching resources. Similarly, a faculty would have a responsibility to teach them or to access the what resident doctor actually is writing, what her or his findings are, and that can be checked again. This is one important thing institution have an advantage. So you have a various other departments with you where you can have a club of sort of interaction in terms of conferences, discussion. We have a many of such. We have a radio diagnosis conference of patients of oncology, patients of ophthalmoplasty. We do have with other departments, similarly pathology, microbiology, neurosurgery, neurology. We have a once in a week meeting in RP Center where our residents have access of everything in a comprehensive way, and you can plan better teaching in these cases. Surgical area, I think this I talked about communication, little bit on patient's point of view so that we generate better surgeons. We talked about wet lab. We in RP Center, we started the dry lab also. You'll say, what is dry lab? Dry lab has the access not only for resident doctors, it is also for a paramedical student, that is optometric student. So we have a wet lab for a refraction, dry lab for refraction, dry lab for indirect ophthalmoscopy, direct ophthalmoscopy and gonioscopy, and other skills also. And that is also very important area to be established in a teaching institution. Surgical people have covered very nicely. We do have I think one of the world's best surgical skill development area where we have 6 infinite our time was ICAMs. In ICAM, the faculty, senior resident, junior resident, they used to learn how comprehensively they have to build up a teamwork, how comprehensively they have to build up the surgical area, how to manage the OT, how to manage the patients. Unfortunately, that is no longer there. Now every patient has to be pulled to the your OT as such. These are other aspects of looking to other areas. Future things would be we are looking for accreditation of training facilities. That is very, very important for us. Making the infrastructure at least uniformity in every institution. That is should be to make sure that in uniform infrastructure is there and the strength of faculty members should be enough to provide the teaching to these areas. And that should also incorporate the other ancillary staff also. I think recently I have recommended if we take out one faculty, two optometrists, one OTA, one your staff person, one data entry on faculty. That's how you can sufficiently provide the area in these cases. The world in the country, we have our people and they're doing not only the work in those areas, they are leaders of those areas also. I hope that similar institution will come up. We have PGI Chandigarh, they have taken the lead. They are coming with the MCS programs, which RP Center is also going to have in various areas. The first slide I showed, I'll repeat them again, is not the subspecialty. Now we are looking for super specialty areas for training in these 16 or 18 areas. And fortunately, the private sector has taken the lead in this. All super specialty trainings are mostly happening in the private sector. So they do have more responsibility today than the government sector to bring out the best people, best training of these areas, because it's not a demand of our students. It's a demand of a population, society, and patients. Now, patient now demand who is the doctor who can do macular hole surgery, where is the institution, and which is the doctor who can do a DMAC procedure. So that is the requirement of a community. Therefore, we have to look into those aspects also, apart from the general ophthalmology, which is also important part of our area also. Thank you for listening. Hope that we'll keep building.
Thank you, sir. I think the dream of Dr. L.P. Agarwal, in which I'm also a beneficiary, I think can't agree more, sir, with you. The kind of work the RP Center is doing in creating world-class ophthalmologists who are going to take this flag forwards. Thank you very much, sir. Now it's time to listen to another Dan in ophthalmology, none other than Padma Shri Dr. T.P. Lahane, sir. Dr. T.P. Lahane, sir, probably needs no introduction. He was the head of the ophthalmology department. Dean of College hospitals. He is also the DMER Maharashtra State, and he has probably the record of doing the highest number of cataract reach programs and probably the man of every Indian ophthalmologist. Over to you, sir.
In expectation.
Yes, I MP. Anand one. So basic thing is the here it is a real area, or you can see the more patients and the surgeons are less there in the rural area. In the urban, you will see the more surgeons and the less patient. That is what is happening because nobody is going in the rural area. Now the because of that, whenever you will see the population in Mumbai is, you can say it is near about uh, 2.5 crore and there are approximately 2000. Now it is 2500 surgeons, and in Maharashtra it is 10.5 crore and the surgeons are 3000. It means that is what is a population ophthalmic surgeon ratio. Now patient is our first teacher. Now no patient, or you can say less patient, it is a theoretical doctor. And you see at so many places, the doctors are theoretical only. Need of outreach program is a, you can see it is a mutual benefit to the patient also and to the doctors also. Now here there are I see two options: large OPD screening to know the backlog of places. Then another thing is contact and update from the local ophthalmic officer. We always take that. Awareness about the treatable and preventable blindness. Then affiliation to the existing civil hospital with civil surgeon, and then the building up a small sub centers of our hospital with OPD and OT that can help. Appointing a consultant or assistant professor with a graduate students can be sent there. Set up a protocol which case can be managed and which case cannot be managed in that center, so that we can send it to the higher centers, and all this to be documented. Other thing is the regular surgical camps in the district area, that is in civil hospitals, medical colleges, where the ophthalmic theater is available, because the camps are not there, only permitted where the ophthalmic hospitals are there. 3 to 4 days visit to the civil hospitals or the ophthalmic hospital in the interior area, where we can examine and operate the cases. So do pre-operative workup properly and operate, evaluate these patients also post-operatively, and visit this patient minimum 3 times post-operatively. Simple cases can be allocated to the postgraduate students with the one trainer. The important thing is when you are teaching to the student, they should be responsible doctors. Large screening OPD camps at districts, and this is the registered treatable cataracts and patient. Today, if you know, in India, there are 1 crore 3 lakhs cataract patients which are there to be operated because of backlog of COVID. And Government of India has sanctioned 3,000 crore for that. It means there is a pick up and drop patients. This type of camp can be done where you can bring the patient from the local bodies, and then patients can be admitted in the hospital and the institutional surgery can be performed. Now this is the surgical treatment and the post-operative care in the institute is easy. The second is the particular day in a month. See, if you are going in the outreach, then the day should be there and that day patient will come. So that should be a particular day in a month, and so that the patient will come there. Now the regular centers, you can have a costly to set up such centers, needs vigilance and the maintenance. Adequate manpower is required for that. The another thing is useful to the long run, because 24/7, if you are helping them, the patient will come and can be very well monitored and useful for the training also. Now the surgical camp carry lot of surgical luggage, then low work at a primary center during the camps because not much work. We are going for 4 days.
less time and more work is to be done. Then the boon to the patients who cannot travel, they are blind patients, so that can be useful. Travel of the patient is involved here in the pickup, but yes, it is less costly than the camps, and standard of care is there than more good than primary center. So that is always start with the screening camps, then the affiliation with the civil hospitals where certified operation theater is there, and then the initial 3 years post, you can say starting yearly, then 6 monthly, and then reassess, and then you can go ahead with that. Then the number of patients are more and backlog is still there, consider possible. You can say this is a, you can say the institutes of the LVPI. There are so many institutes together so that they can go and ask the patient for the training. So that is also possible. In JJ also we have got the centers at Nandurbar, also Anandvan, Melghat. So 7 places we are going every year, but the dates are fixed. On those dates we are going. In the summary, consider the outreach program are of the utmost importance and lead to mutual benefit to the patient and institute. So whenever the doctors are going there in 3 months, so they will be well trained for the SICS, and then they can be trained for the FIP. So this program is always useful, and now the government of India has already told us to send these residents to the civil hospitals for 3 months in the second year. From 1st of May, the first batch is going. The second is care should be taken that even outreach complicated cases are referred to a primary center and alerted to the senior surgeon. Once one patient goes in one village, and if he has not got the vision, that all villagers will not come to your camp. So always see that whenever you are selecting the patient, he will get the vision. Those who are not, you can say prognosis is not good, those patient can be shipped to the your institute, and there you can operate. Otherwise, if you are operating the bad prognosis cases there, the one case will give us a bad reputation in that village. But if you operate good cases, our this vehicle was punctured, we enter in one village where we do near about camps everywhere. In every village, we went to the 36 people's place for the tea because everybody was asking us, sir, chai leke hi jao. That is what happens if you have got the good reputation and if you give the good result to the patient. So I think that is a standard of care. We should not compromise, and always we have operated near about, in the outreach camp, we have operated near about 1,30,000 cataract. But in this 1,30,000, complications may be there, but maximum good result. And yes, the resident training will be better in this situation when we go out. And other early teaching institute should be affiliated to a peripheral civil hospitals, and the post residents regularly such centers, and that will help us for the teaching the residents. Thank you very much. Thank you.
Thank you, sir. Thank you very much. Since you finished before time, I'll just take 1 or 2 questions if anybody from the audience. So first question, Arvind, I think has done a study. If I'm not wrong, Prachna sir can correct me, where when you go to the outreach program and fix the patients and bringing them to the base hospital, there is 30% of loss. So is there anything that we can do to increase that 30% and see maximal output is there? Second point,
30% whenever he is very correct. 30% loss means the patient, their relative, they will not permit the patient to go to the base hospital. So that is the problem. And so we'll have to choose the season. In which season there you can say the son and daughter is in the house. They are not gone to the work. In that season, the patient will come.
And second question is, when we do this, most of the camps for free. So we know that patients who are even affordable, and if they get to know that Lahane Saab is doing a fantastic surgery, then they can come into this free surgery bracket.
That is
is it ethical to counsel these patients and bring them into a paying bracket?
That is the problem. Whenever I am going for the, you can say big places, cities, The people who are upholding, they are coming on my name. Just now I did camp in Solapur. The upholding, not only upholding, very rich patient, they come to the camp. And it is very difficult. But what we avoid, the person with a good cloth, we say, your cataract is immature. Normally, the patient which is not having the good cloth, we say, yes, you are admitted. So, but yes, we can also tell them, यहाँ तो जो अब सर्जरी है उससे अच्छा फेको सर्जरी अच्छा होता है, इंस्टीट्यूट में आए तो दो उसमें वहां अच्छा सर्जरी होगा, यू कैन कम टू द इंस्टीट्यूट, ऐसा करने में कोई हर्ज नहीं है. Do it.
Opinion from other members that publicize, make it more of free, affordable, and he wants to go in for a pay surgeons, then why to divide that chance?
I think, what, Professor Lane said, absolutely correct. There's some other peripheral urban areas to the villages also, so that we can cater a large number of patients who are suffering. And those patients who can pay, they would normally have access to these knowledges, and they would come to the hospital whenever they require surgeries. And normally these patients come early also. With a little bit of problem, they come for cataract surgery. But today we have, backlog, which is almost 2 crore patients waiting for surgery, which are less than 3/60. And that is a major challenge with the government also. And very soon the new direction might come to everybody, to the private sector also, to do these surgeries also. Because otherwise we can't do a 2 crore surgery in 1 or 2 years. Because you are doing around 50 to 60 lakh surgery in a year in the country. Now today the demand is 1 crore surgery in a year. With the same resources, so same number of surgical hands. So I'm pretty sure the private sector will also be roped in for a patient to be done. And the new concept which I have suggested is the reverse camp. So we can have the camp happening in the remote areas. ASA workers are being roped in this area. They'll be given a incentive of ₹500 for each cataract patient which is to be operated. And these patients will be brought to the hospitals. That may be district hospital, that may be government medical colleges, private medical colleges, or a private institutions, and surgery has to be done. And the fixed amount of money which is going to come will be given to those institutions.
Asha workers, yes, very true. What sir is saying, because see, it is a if it is a 2 lakhs backlog, then Asha worker is not bring the patient because she is involved in so many other activities. So the suggestion to the government was, you must pay something to the Asha worker so that they will bring you the patients. To today also, the backlog in the city, we are not knowing the backlog. But if you go in the in the interior now, we did the 7 camps now, and I will tell you the patient's number. In Yavatmal we went. In Yavatmal, patient number was matured cataract number was 3,000. And we were 2 surgeons. How many we can operate? We operated 1,121 cases. But it is not possible to operate all matured cataract. Yes, bilateral we are. And so I think sir is advisor, and what sir has told is very good, that they will give some initiative to ASHA workers. Patient will come to the primary center, then to the ophthalmic center, and even the private practitioner should help for this backlog. And after that, I think once the patient has came to you for one eye, other eye he will pay you. There should not be any problem. Thank you.
Thank you, sir. Yeah, Alok sir, another institution which is doing lakhs and lakhs of free eye surgeries. Dr. Alok Sen from
Chitrakoot. So if the question was whether it is ethical to counsel patients in camp, in the camp setting where we have advertised pre-camp surgery, right? So I think as Dr. Titial was saying in the morning in the session itself, that the patients now are demanding, like the patients will come and say that I want to get phaco. So this has changed a scenario. Like I have been working in Chitrakoot for last 18 years. Initially, through camps, we will hardly get patients for phacos. Now we are at least 10 to 15% of patients through camps, they are for phaco emulsification. And that has helped in sustaining our services. So that is very important that we do give them that options, whether you want to go for a free surgery or a phaco with some payment or get some better facility in the base hospital. So that is something that we do regularly, and it has helped us sustain our systems. So that is great.
That is for pickup camp. For the pickup camp, yes, definitely what he's saying, 15 to 20% patients are asking for phaco, but here the charges, so they are not affordable for our charges. Here we'll have to give on the subsidized, and I think that will help the institute. That is definitely happening. Thank you.
Thank you, sir. Thank you very much. Now we can have Dr. Prajna, sir, connect.
Sir,
us.
I want to make a comment, sir.
Yeah, one second, sir. I think I like to ask Prajna, sir, also the same question. When you bring these patients to from the camp and bring him to the base hospital, you know that they have been told it's a free camp. Now, after coming here, is it ethical to counsel them? Because you have already told that it's a free camp. And once the bus comes, and do we have to counsel them? Because there are 2 points. One, ethics. We don't know the exact definition of ethics here. And if the patient wants to go ahead for the high-end surgery, though you have told it as a free, do you think it is rationally possible, and should we do it?
I think I agree with what Professor Lahane was mentioning. If the decision has to be taken, it has to be taken at the campsite. Because if at the campsite we have told that the patient will be given free surgery, and then we bring to the hospital and then we try to convert, patients might not appreciate that. If that decision has to be taken, I think, as Sir said, that immature thing was very interesting for me also to follow. I think that would have been the correct step. Because the patients would just say, then why did you? The whole argument changes from gaining vision to starting a debate, which now many people are interested in anyway.
Go on, sir.
I think I wanted to make a comment because now these camps are basically for poor people who are unable to afford and who are unable to walk, unable to go to the big hospital. If a person is coming to the camp because of name that the big surgeon is coming and they want to be operated, but at that time they can be counseled that, listen, look, these camps are basically for the poor people who cannot afford. If you can afford, you can go to the hospital and get the things done there. Another thing is that in Haryana state, in every district, there are eye surgeons, 2 to 3 eye surgeons in every district hospital, well-equipped hospital with phacoemulsification machines and microscope, everything. But still, people, NGO want camps to be done there. And we were asking that we cannot do camp there because there are already eye surgeons are working there, they can operate. And they are equipped and they are trained also. But they want that the operation should be done by the medical college people. So actually, if we are going to the places where already expert and ophthalmologists are available, and we try to do surgery there in their hospital or in their next shift arrangement is not allowed now. It should be done only in a certified operating room. So I think that can be told.
Thank you, sir. Thank you very much. And I think now we'll listen to another doyen, Dr. Venkatesh Prajna, sir, one of the main pillars of Arvind Eye Care System, what we see here today. And so thank you, sir. Thanks for coming. And so today he'll be speaking to us on innovative teaching and training, the Arvind experience.
Thank you very much, Dr. Srinivas, Dr. Krishna Prasad, and Santosh, for this innovative experience, I should say, for the past 2 days. I have learned a lot in these 2 days, and I hope to implement some of the things which I have learned in the Arvind residency model. Today, I thought I'll just concentrate on one aspect of what we have done over the past 4 years, the flipped classroom model, which we started in 2018. Before that, for any teaching program to succeed, we need certain responsibilities for certain cadre of people. Academic director has to have a responsibility. The speaker who holds the class has to have a responsibility. And the audience who's comprising of the students, they have to have the responsibility. In my experience, I have found out that sometimes it is very difficult for the academic director to take care of the students because the speaker is not well prepared for that class, And that sometimes is on the face of the academic director. So the academic director has to be professional. The experience which I have, I've been holding this position for almost 2 decades now. Champion the cause of the students. This is very, very important because in many of the places, the student, the teaching gets the second priority while the patient treatment gets the first priority. There's no doubt the patient thing should get the first priority. But this is also very, very important. And a person who really champions the cause should hold this position of the academic director. And they should have a passion for teaching. Keep abreast of contemporary teaching techniques. I've learned the last 2 days, I've learned some of them, which I hope to go and incorporate. Give very, very clear instructions. And that is very, very important. The green things in this slide is the most important thing. Get multiple feedback. Don't get feedback from one source. Don't get feedback only from the teachers. Don't get feedback only from a section of students. Try to get multiple feedback as to see whether our system is working or not. And then be ready to change. Nothing is etched in stone. So many things are changing, and beware of the current student population. They have a very innocent face, but inside that they are evaluating you. It is not you who are evaluating them. They are evaluating you inch by inch. And you need to be very, very careful, cognizant at least of that fact, and be responsive to what they actually talk. The speaker, and then I work along with the speaker. It may be the faculty or it may be a senior resident. And then I always tell them only one thing: don't talk, communicate. Make sure whether what you're talking is being received well by the students. So have a very, very clear this thing. See the face of the student. The student's face, sometimes, they'll be in the highest spiritual plane of total silence. But at the same time, if you really look at it very deeply enough, you can find out whether it is in a meditative stance or whether they're truly interested. So be very careful, but use all gadgets and techniques. I always teach, that is why it's called PowerPoint. You should be powerfully making a point using all the skills which you have at a disposal and not completely dependent on just your slides to make that positioning. The audience responsibilities: come prepared, be participative, and polish it with learning skills. So we have done this in 3 models. The current model which we do is the DigiNerve based, which I would be talking to you a little bit in detail. But we started off in 2018 by doing a regular class, flipped class model, where we had 2 things: the pre-class and the class. And let me tell you, the pre-class is more important than the class in a flipped classroom model. Very clearly, a communication goes from me. It is intentional. We just say that this is a corneal lecture series on peripheral ulcerative keratitis. But if you really see, we attach the reading material in that email. This is how we started off initially. This is not the way which we do now, but I just wanted to let you know the history. And then we've also very clearly say that in the class, we'll keep you across according to groups. Questions will be asked in between presentations, maybe subjective, objective, one-liners, and the winning group will be given an exciting prize. The whole idea is to keep these guys interested, to keep these guys in focus, to keep these guys listening to the podium and learn something out of it. This was what we started off with. This is how our usual classroom looks like. They're formed in groups, and the people who are actually manning the class are the senior residents. And I'll tell you how we use the DigiNerve app to do this. In the class, we're very clear: no monologue. Nobody talks for more than 10 minutes at a stretch. It is very intentionally created. Like we tell them, okay, 2 to 2:10 you talk, 2:10 will be your first question, 2:10 to 2:15 will be the response, 2:15 you start off with this. Since you said 2 to 2:10 you will be talking with PowerPoint slides, now it will be with tables. So that kind of so many rehearsals, we get to go with all these kinds of things. The second thing which we do in a flipped classroom model is the skill transfer course, which we do it for all investigations, only 2 residents per session. Again, they are given this aims and then they are given all these things. So this is what you are supposed to see before you actually come. And there will only be 2 residents at one point of time when they come to this skill learning session. This is apart from the posting when they will go to the glaucoma class or this thing. And then very clear instructions from 2 to 6 p.m. And this will be followed in this thing. And then I get a feedback by email, how from the person who delivers it and from the person who receives it. So we have a active 2-way communications to all these things. So now we do a complete DigiNow based flipped classroom model. And I personally believe that this has revolutionized teaching and the learning which has happened to the Aravind residents in Madurai. So what is DigiNow? DigiNow is an app where I'm the editor-in-chief. It's an app made by JP, and it has around 200 hours of video lectures. This self-assessment question is increasing. In fact, we add close to around 250 to 300 questions every week. We add in this. We have some benchmark trials in this, lecture notes in this, and regular chat shows with Menta. Let me tell you an interesting story on why I went to look at this DigiNow. So my son was studying his final year MBBS in the Government Medical College in Madurai. And every day when I used to come down from my bedroom, he used to be with an iPad sitting in the dining room. I tried to avoid. I was thinking he was trying to irritate me, by keeping an iPad every day. And I was just keeping quiet for at least a period of 15 days. Then I had to blurt out. As a parent, I said, why don't you read a book? Why are you just seeing only this all the time? And he just told me one thing. We are studying for Marrow. And this whole generation is studying in Marrow. And if you are not ready, when we guys come to you as postgraduate students, you would be hopelessly outnumbered by our expectations. Now that struck a chord in me that the whole generation has shifted, especially in the transition time between the UG and the PG time, where they're completely relying based on this kind of an app-based tutorial. Now, this tutorial is standardized content by experts across the country. There are many Aravind contributors, but there are many, many people who are outside Aravind who have contributed to this. And then the best advantage is you recap this standardized text. I was having a discussion. I was following up this discussion on which is the best method, a lecture method or a case method or this thing. It all depends whether the person who's coming to deliver that is well prepared. That's the whole issue. Whether it may be I may not be in my best thing every Friday, but if I'm recorded and kept in a standard thing, then it can be done at their own pace by the students. So it is a paid app. The subscription fee is this 11,000 and 26,000. But what I'm very, very proud is none of the speakers, including myself, take even 1 rupee as royalty. So we can really, really feel proud. The entire proceeds go towards charity. It goes directly towards patient care. We pay for the bus fare for the patients with corneal ulcers so that they can come for follow-up. We pay for the medicines for corneal ulcers. We give complete care, free care for patients with ocular trauma. We have decided to use this proceeds only for people with emergency conditions, not like cataract, where at least they can muster up 1,000 rupees over a period of 3 months. But if it's an emergency, like corneal ulcer, something which is very, very close to me. And so for every patient, till they come for follow-up, the patients are being paid bus fare and other things. So entire proceeds for this goes towards this. I'm very, very proud of my faculty. Many of them are here. Santosh has contributed to this. Dr. Krishna Prasad has contributed. Rolika was mentioning about Dr. Krishna Prasad's art in making refraction simple. I had to request him at least 10 times because that is the very difficult concept to sell. I always find myself, I'm like, we have a party called DMK in our party. I'm sure many of your parties will know.
the district secretary of the DMK party will know exactly what the community, what their needs are, what their this. Whether he's going to do it or not, that's a different issue, but he knows the needs. So I keep myself on what the students expect. And I was really scouting for the best teachers in this field. So we have Dr. Krishna Prasad teaching refraction, Santosh teaching ocular oncology, Tanush Dada teaching glaucoma, Savitri Madam teaching ocular microbiology. In fact, that set up a little bit of a problem in my house because my wife also is an ocular microbiologist. But then I had to, I didn't tell her that we want the best in the field to talk on ocular microbiology. We said, we will give her, she's not here, sir. Dr. Mahesh Shanmugam, sir, is talking on retina. Dr. Vijayalakshmi Madam, Dr. Milin Naik from LVP, and Dr. Naveen Jaikumar from neuro-ophthalmology from Chennai. And Dr. Meenakshi Swaminathan, who I eminently admire for her communication skills. I requested her time and again for getting them on board. Dr. Ashmin Gandhi, Dr. Geeta Iyer, Dr. Meenu Mathin, Dr. Usha, Dr. Muna Bande, Dr. Murali Ariga. So what it means is we have a standardized content in place and they were coached on what the students needed to be told. You know, it's very difficult for all these top-notch people to get into a student training mold, but then we did it. What is very surprising is it was launched in AOS last year, and there is 1,200 subscriptions in the past 11 months. So that means a business worth of around 1.65 crores of rupees has been bought by the students. So I would suspect that some of your students who are in your program already have this because we have only 1,500 PGs being recruited every year. So even if you take 1 year out, because the final year students or the first year student would not have bought it, out of 3,000 students, 1,200 students have bought it on their own means. We have fed something which is of interest to them, especially when Santosh and all the others have really put up so much of free things in the web. People want a curated version. One of my Sanskrit teachers told me in my he said, in your generation, if a banana is going to sell for 1 rupee and a peeled banana is going to be sold for 10 rupee, people will buy the peeled banana because they don't want to waste their time peeling the banana. So here you have a curated version which they can use it in their passion and then use it. So this is across all zones. JP has very good marketing. And so this is across all zones. It is already there. So what do we do with that one? Now, that is one thing. This is just a content. We have a standardized content, which takes the pressure out of the a teacher to teach or to prepare for the class and go. But what we do is we send an email about the plan, and I'll just show you a model of that email. We will tell them exactly what the digital content has to be learned. We ask the residents to create 50 MCQs on their own. So we flip the whole responsibility. The postgraduates, when they do the 50 MCQ selection, they really understand the content very well and to discuss, and then we do a standardized MCQ administration. Can you please take the hyperlink there? Can you click the hyperlink, please? Yeah, just press on that. So can you just scroll it down a little bit? So if you really see, we tell them exactly, this was last month. Can you just, yeah. So we tell them the watch duration is 90 minutes. The class coordinators will be this. 13th. The whole thing is you will have 2 or 3 things. The only thing which is missing is the link, the chain link. And so when they are told that exactly this is what is going to happen for this entire month, and it is your duty, the class coordinator's duty, Meghna and Prabhu Pandyan's duty will be to make 50 MCQs in that topic with the help of the retina consultant. And this is given like 1.5 to 2 months in advance. There is a lot of merit
in the students becoming teachers and in the students becoming evaluators. They understand how the question taking part goes in the whole scheme of things. Can I come back to the slide, please? Yeah, come out of the hyperlink. Next slide. Okay, so this is assigned to 2 PGs for one lecture, and then they create 50 this thing. And the class is handled completely by the 2 PGs. There is a content expert there. There is a retina consultant sitting there. But then the students become the class administrators and teach. And then what it also does is it goes through, we tell the students that these are the 4 things around which you should take a class, around which you should take a question. And for example, one on knowledge. And the thing is, they have to give an explanation on why this is right or wrong. And every student is given a responder, and then they vote for the answer. And A, B, C, D, and then we put that display on the board so that we sort of discuss in this. And then we also do on comprehension. How do you match? And then a person is asked, when the answer is 2, the person is asked, how will you change the question to make the answer 1 right? That is the level at which we teach the residents. It is not just comprehension of the current scenario. If you are given the authority, how do you teach, how do you make the question different in order to get the option 1 right? So this is how we do it on application and on analysis and synthesis. So every student who is in the class has this device in them, and we also know who has pressed what. So they can't deny, but then they can defend. They can defend as to why they did this thing. And they may either say your questioning is wrong because your question is not very clear, or they may say my comprehension of that question was wrong. This was never happening at Aravind 2 or 3 years back. We have never seen any sort of communication in that class. It was always a very, very quiet class. Now it's a noisy class, but a nice, noisy class. So that is what we really want you to have. This is a resident, and you can see 2 residents holding the fort, and you can see they have already voted, and they are looking at option A, and then they are trying to discuss what is so good about option A. And then they sort of ask, especially when you have a democratic answering thing, something like this, that sets up a very good a pattern of A being right, B being right, C being right, and D being right. And how do you sort of mesh it up? So this is the sort of questioning which happens. How many percentage of people got it right? And we don't do this. This is not a marquee event anymore. Twice a week, 1.5 hours per session is DigiNow based app session. And the first year resident, before even going into retina, knows a standard way of understanding OCT angiography to the depth. And I believe this is very, very good app, especially when you don't have a teaching faculty for all specialties. This is a great app to have. And as I can show you on the numbers, don't worry, many of your residents already have it. And this is my last slide. And I think I really stand by my the last line in this last slide. It has actually revolutionized the learning. I'm in this business of teaching for almost 20 to 25 years, but I've never ever seen the students so interactive. I was always so upset with them. I was always saying the teachers are putting so much of effort. Why are people not understanding? Now I've come to a conclusion that we have not effectively administered the osmosis process. And I think this is a better way. This is a new generation which is not going to go back to the books, whether you like it or not. And it's better that we change rather than expecting them to change. Thank you very much for your patient hearing.
Thank you very much, sir. So how do other students can participate in this DigiNer? is there any a platform where the other institution students also can be a part of that? Or Srinivas, I really would like this to be customized with the institution. I would recommend this be used as a template because this is not just the Aravind teachers teaching. As I told you, this is like 40% Aravind teachers teaching and 60% all faculty from across India teaching. You can use that as a template, but I would really advise you to have the question taking, the discussion and everything done at your hospital itself, because that facilitates the questioning part and all the things, because you shouldn't just be allowing them to be passive listeners all throughout. Because some of the medical colleges or the government medical college might not have all the subspecialties. When yesterday there was a thing, I have the highest regard for the government medical college teachers sitting here, because I can only speak in cornea, they can speak in all the subspecialties. I think with this background and with their knowledge, the only thing is believe in them. The students have the potential to do it. The only thing is the teachers also need not be burdened by creating a class for every session. And the only thing, academic director or a person who gels it should ensure that the circuit is complete. The circuit should be complete in order for the current to pass. Otherwise, it's not going to work.
No, I think I would like to place on record the effort, the phenomenal effort by Dr. Venkatesh Prajna in this real breakthrough in, I think, the medical teaching. I think gelling with technology and trying to find out what exactly is the right recipe for the present students. Because since I was involved in the process of making these videos, these are very different. If you have not really gone into it, you please try to look into this. These videos are extremely validated, vetted, and as I said, very curated information. It's like a typical classroom. The student really, really feels very cozy when you actually go through that entire process. And a lot of curated information. Unlike most of the other internet stuff, it's a very curated information and very well validated and exactly what is a postgraduate really requires. I think when they go through the entire set of lectures, probably it's a real parallel digital classroom. That can solve all the problems and take care of the gaps.
Thank you, Dr. Prajna. It was fun being part of your initiative. Of course, I did Skunt, which is one of the dreaded topics for the postgraduates. And he again and again interacted with us and coached us on how to not give it as a lecture, but actually pretend you're teaching the class. So you go back and show the slide again. You pretend the student in front of you, ensure that this point is understood, and we were actually video recorded, so we could teach in an animated fashion. That was our style. So that way it was different. We were not just sitting in a podium, but it was actually like being in a class. So that way it was special.
That is very true, because we had actually a group called 3 Idiots out of Delhi, which is a company which makes cereals. So these are the people who professionally went to all locations and recorded. And so if you are not gesturing, they would just say, stop. You have to gesture. So I had to make all, like a director, to make all these professional people teach. Because the ultimate consumer today is a very, very savvy consumer. Very savvy consumer, but an easy consumer to floor them if you are able to give them what they require.
Thank you. Thank you, sir. And now we'll more last session before lunch, and we are well within time. I request a senior professor, Dr. Kamaljeet sir. He has been a teacher of teachers and he has taught many, many thousands of students. And he has come all the way from Prayagraj. So he'll be speaking to us on how to train to be a good doctor. We have just last 4 more topics, and sir will be starting. Unfortunately, his mobile, which he had loaded the presentation,
got wet.
Got wet in the beach of Goa.
No, so
and all blame is to be to the Betal Batim beach. So it's not to Kamaljeet sir. We have to forgive him. So he'll be speaking extemporally and within 10 minutes and request Kamaljit sir to.
Thank you, Srinivas. I was listening to Dr. Prajna, Dr. Tetial, Dr. Lahane, and Dr. Agni. And you see, these days the teaching has become so difficult. When we join as MBBS students, we are taught innumerable subjects. And then we start learning by MCQs. And when they complete their MBBS and join as interns, they start preparing for PG. Hardly few students come to the hospital. And when they join after getting selected after 2 or 3 years, they have forgotten whatever they have learned during MBBS. When they join as PG candidate in ophthalmology, they know nothing about ophthalmology. They don't know what is cornea, what is sclera, what is conjunctiva. They cannot see anything. So for us, as we are talking about PG candidates, we cannot talk of super specialty. Our job is to teach them comprehensive ophthalmology. They must know a little bit about a squint, a little bit about retina. They should know about corneal ulcers. And of course, cataract and glaucoma is bread and butter. These days, with the super specialty coming, it depends on where you are working. Are you working as an individual practitioner, or you are going to a hospital, government hospital, or you are working in a corporate setup, or you are working in a high volume centers like Arvind, Chitrakoot, and Shankar Netralaya or LV Prasad. So it depends on where you are working. If you are an individual practitioner, please tell them to talk to the patient. The patient enters their OPD, what happens? They will not even ask their questions. They will keep on looking at the reports, the lifafa that he has in his hand. A big envelope with lots of investigations and no complaint. Nobody knows what the patient is having the problem. He's having the watering and redness, and he comes with a OCT and fluorescein angiography and whatnot. So that sort of problem has occurred today. So you have to, as a doctor, a student should know how to talk. And the local language is so important. Like in our setup, when a patient comes to us, he will say कि हमार पेट गुड़गुड़ात बा. हमार पेट में गुड़गुड़ात बा, इसका मतलब आप क्या समझते हैं? तो गुड़गुड़ात बा मतलब थोड़ी आवाज होती है, गुड़गुड़ाता है, थोड़ा डिस्टेंशन है और गैस बन रही है पेट में. और फिर then he will say कि पेट चलक बा. पेट चलक बा मतलब डायरिया हो रहा है. And when a patient comes to me, हमार सर फटत बा. So you have to know, and a North Indian, when he comes to Arvind Eye Hospital, my students, so many students have come to Arvind. When they go there, they don't understand the South language. So then it becomes a problem. So the language is very, very important, and local language is like as a doctor, I would talk to my patient in local language. kaho ka alba. Or if a Punjabi comes out and says, ki hal hai Maharaj, tohada sab theek thak hai, sat sri akal ji. You have to talk to your patient and ask him about his complaints. And based on that, you have to do diagnosis. And half of the time, our teacher used to tell us that the diagnosis is told by the patient. You don't need to keep on investigating him for each and every entry that the patient has and extract whatever maximum money you can extract from him. So you have to tailor your investigations. A patient has come for a headache. You have to look for asthenopia. You have to look for whether the latent squint is there or there is muscle imbalance or not, whether the refraction is good or not, or you should. The problem is that this patient goes to the optometrist first, he does his vision, and the complaint is not known to them. When that patient enters into a doctor's or in my clinic, then I'll be sitting with a computer here on this side, an investigative slit lamp, and then the OCT and whatever you have in your clinic to show that you have so many machines with you. And then when he enters, you are looking at them. Apart from that, you are looking at your mobile and not at the patient. So the patient does not, you cannot even meet the eyes with the patient. मतलब आपने देखा नहीं उसको और देखने के बाद कहा कि साहब जो है आपको ये जांचें करानी है. मतलब patient enters and so many investigations are written. So this is another thing that. Third is, these days I find that doctors don't write the diagnosis. We as a students were told that please write probable diagnosis. What is the probable diagnosis? Maybe you are not correct all the time. You have to write your probable diagnosis and based on that your investigation. So go ahead. So this is a big problem. And then 15 investigations in OPD slip. All the investigations that are possible for a patient entering into your clinic, whatever investigations are available in the hospital, those lists are given to him and he goes there. Then when he comes back, you tell them to go for another investigation. So a approach of a good doctor would be to do a tailored investigation. Mutton fat KPs are there. You don't need to do all investigations of HLA, B27 and all that. When he comes back, he does not have the money to buy the medicine. All the investigations, pathologists and histologists and whatnot, they take away their money, whatever is there. So you have to do a tailored investigation. That would be a good doctor. Rather than, then comes the treatment part. The treatment part is written. I would say, frankly, it's our companies are sitting there, but industry has driven us so badly that we write the moxifloxacin for a refractive error. So the hospital should, the teaching method should be such that they don't write such nonsense medicines. Moxifloxacin for a refractive error. And I keep on scolding them, but ultimately that medicine has to be, is always there on the prescription without bothering whether this much of resistance that we are causing is creating a problem to the patient and to the public at large. Then there is learning and unlearning has already done. And then many times you have to understand, as these big institutions are telling us, there is the economics lies at the base of the prism. You can have a very good setup. Initially, you go as you think that you are a good doctor, your senior is having so many machines, I will also buy so many machines. In the good old days, we used to have one ophthalmoscope, a refraction box, and we used to do good refraction, and the diagnosis was always made by the lens and loop. So as a good doctor, you have to think about the patient's pocket also. You can refer, and there should be no fear in referring your patients. You cannot be the last word. Like you refer, a cornea specialist would refer without any fear to a retina specialist. A retina specialist would send the patient to the neuro-ophthalmology clinic without any problem. So similarly, you should be a comprehensive ophthalmologist, and 90% of the diseases can be treated by a good doctor. So these are some of the points that I wanted to highlight. And please be careful as a good doctor that you will write minimum possible medicines, you will write your diagnosis, and ultimately the patients would be benefited. Thank you so much.
Kamal kar diya, sir, Kamalji. So thank you very much. He spoke extempore without the slides. Thank you very much, sir. So we'll have more discussion during the panel discussion post these two talks. Now, I request another doyen from Shankar Nethalayana, Dr. Meenakshi Swaminathan. So she'll be speaking about good communication skills, I think, which is very, very important nowadays. And please believe me, whatever vandalism, violence, anything which is happening in today's world, I think it is mainly related to the disruptive communication. The non-communication is what making doctors feel put them in a bad picture. So I think this is one topic which I think Madam will be speaking on that. And after that, I'll be little bit giving examples of how media are covering these examples. I'll be showing it in my slide next presentation, how important it is to have a good, effective communication with the patients. And for that, we have one of the best communicator, Dr. Meenakshi Swaminathan, Madam. So she'll be speaking to us today. Thank you, Madam. Thanks for coming and addressing us.
Thank you, Srinivas. You're very kind as always. Thank you, Srinivas, KP, and Santosh for a wonderful program and for having me here. And Santosh was almost calling me sort of the grandmother of educational initiatives or initiatives in education. It's also doubly thrilling for me to present in front of Dr. Pandav. He was an SR when I was a JR way back in PGI. And I'm also happy to represent physically the Ophthalmology Foundation today. You heard a lot of fantastic speakers earlier, and you're going to hear more from Eduardo and Gabby and Carl. So without much ado, I will talk about teaching. I renamed the topic Importance of Teaching Communication, because throughout from yesterday, if you've heard one common thread, it is that aside from clinical and surgical skills, really what your residents need to learn is good communication. So we're going to talk a little bit about communication and how to teach and how to assess. The goals and objectives of this talk are to understand the importance of communication skills in medicine, list the models of communication and the process, list the methods of teaching communication skills, and how to assess. What is not covered today is communication with students, team members, trade representatives, representatives of the government, law, etc. So why is communication such a big deal? Because it leads to better compliance, better health outcomes, decreased litigation, and increased satisfaction for both the doctor and the patient. So I'm going to give you a mock scenario. So Mrs. G has come to see Dr. D. Dr. D is running late in the clinic. He walks in, smiles, introduces himself, and shakes her hand. And so this is obviously, perhaps a Western audience. Here we'll say namaste. And Dr. D says, "What brings you in to see me today?" And Mrs. G says, "Doctor, yesterday when I woke up, there is a commotion outside in the corridor." And Dr. D excuses himself and opens the door and finds a patient is crying and refusing to sign a consent form. He has a quick word with the nurse and goes back to speak to Mrs. G. G, what you were saying? So when I woke up, I felt my vision was blurred in my right eye. And then Dr. D's phone can be heard vibrating loudly. He takes it out to see who it is quickly and cuts the call. And then he says, sorry, you were saying? She says, "I also heard a buzzing sound in my ears." Meanwhile, the medical student was rotating. He says, Dr. D, does that mean that is what is called tinnitus? And now he's irritated. Yeah. And turns back to Mrs. G and says, "Excuse me." And now she's starting to look sad. So really, what are the common barriers to good communication? I'm sure this is a scenario a lot of us can relate to with multiple interruptions. So one important barrier is use of medical jargon, inability to communicate with the patient in a simple language, sometimes a little bit of arrogance, lack of enough time dedicated for the encounter, that is us, day in and day out, and frequent interruptions during patient narration. But you always should start off by establishing rapport with non-verbal aspects, body language, eye contact, facial expression, gestures, touch in some cultures, or in little kids, interpersonal distance. All these are important. So we've all decided that communication skills are important. I'm not saying, I'm not preaching to the choir. All of you know this. But do communication skills really need to be taught? Yes, they need to be taught formally, but perhaps integrated with other teaching. And there are models that you can follow. And I'm not going to talk about these models, so you can, be happy. But this is the list of models that are available. But we will pause and look at the Kalamazoo consensus statement. This goes through the actual process of an encounter. So you start off by opening the discussion, allow the patient to complete his or her opening statement, elicit the full set of concerns, and establish a personal connection. And then comes the gathering information. Use open-ended and close-ended questions appropriately, structure, clarify, and summarize. Listen actively using both verbal and non-verbal techniques. Understand the patient's perspective, that is, family, culture, gender, contextual factors. Explore some beliefs. Your patients will say, in Tamil Nadu, it's common to attribute it to the heat and the cold, and my eyes watering because I ate such and such a food yesterday, and so on. I'm sure it's there in other parts of the country. So you have to explore these beliefs, acknowledge and respond to patients' ideas, feelings, values without criticizing them or debating with them at that point. And then share the information by using language that the patient can understand. So this is something you do after your examination and your conclusion. And then you ask the patient, do you have any questions? Do you understand what I'm saying? Do you understand the importance of what I'm saying? And then you finally reach agreement on the problems and plans. So you understand you have advanced glaucoma and that you need to be starting off with drops which you have never used. But will you be able to use them? Because I've noticed that you may have a little tremor. Do you live by yourself? Do you live with a family? So it's very important to understand and check with them whether they have support. All this is part of the communication. And finally, you provide closure, which means you also indicate the follow-up. And at this time, you can indicate a body language to say, the session is over. So thank you for coming in. I hope to see you in 3 months, etc. So there are a lot of more things about communication, and because of paucity of time, I'm not going to go into the details. But yesterday, someone talked about listening, and the listening is again broken down into various parts: sensing, processing, and responding. I'm sorry, I'm rushing through the presentation because I have allotted 10 minutes, but I can tell you where a lot of this is available in greater detail. So what do we mean by facilitation? It basically is helping the patient open up, and that can come from a reassuring posture, nodding the head, facing the patient, and both verbal and also offering verbal cues. For example, if you can see me there sitting and staring at the electronic medical record, which is, unfortunately, something that we all have now. It is great. It's a boon, but it can also be a bane. So I literally have my back to the patient while I'm taking history as I'm trying to clarify and enter findings. There are also protocols for how to break bad news. And one such protocol is called the Spikes protocol. So we all have now, concluded communication skills are essential part of a doctor's training. But how do you teach communication skills to your residents? How about seminars and lectures? Not really ideal, because communication is a practical thing. Experiential methods are better. Either video recordings, simulated patients, role plays, observing and shadowing clinicians, and having your postgraduates reflect on their experience. That's an excellent way of checking for understanding. So simulated patients and role play are great, but it needs a lot of preparation. And really in ophthalmology, you can only simulate symptoms, right? So this is a very good example. For instance, there's a role play going on where one resident is pretending to be a patient and giving complaints. The other one is eliciting history, and they are recording the whole encounter. And then she plays the encounter for me on her phone, and we sit together and discuss what was okay and what was not okay. So again, talking of nonverbal communication, which I just told you, I'm showing my back. So it's important that training in non-verbal communication goes hand in hand with verbal communication. So you convey the appropriate non-verbal cues through body language, Be sensitive to pick up on the patient's body language. Again, it can be context and region specific and can be taught by role play. And these are all things that you have to incorporate when you teach communication. But finally, they go out in the real world when they shadow clinicians, they learn, they watch communication happening, and then they're encouraged to reflect. So these were two excellent examples. This is a publication where they incorporated communication skills training in MBBS course. And this was, again, I saw an excellent article from, I think, BJ Medical College, where they did it in the form of a workshop. So great, you've taught. Now, how are you going to assess? Make sure your assessment conforms to the Miller's pyramid. We published the OCEX version 2. And if you see in the OCEX version 2, there is something other than history taking and clinical examination. There's a portion that talks about patient comfort, empathy, and respectfulness, understandability, explanation of the findings, diagnosis, and so on and so forth in the form of a rubric. This can be used to check for communication skills training assessment. Or you can have a CS skilled trainer sitting in an OSCE station and marking the resident off. Anybody can do the training and assessment and communication skills. If your department has senior secretaries, has got a senior optometrist, take their help as well. But assessors also need to be trained. Okay, I'm going to move on to this very important next 3 slides because I realized over the course of our last 1.5 days, no one has really talked about the OFECC, Ophthalmology Foundation Education Consortium Campus, ofecc.org. And if you go into this and you can make an account, it is all free. And in that, you have what is called the Teaching Skills Series. The Teaching Skills Series, as you can see, has modules on many things that were covered today. Applying adult learning principles, giving effective feedback, assessment drives learning, teaching and assessing in the clinic, and so on and so forth. And I'm going to talk about the module that we did, which is module number 10 on professionalism and communication skills, teaching and assessing, with 3 of us, Catherine Green from Australia, Kathy Cow from Canada, and myself. And if you take this model, you have access to all the lectures on professionalism and communication skills in much, much greater detail. You can think of this as what I talked to you as a little trailer for maybe PS2 that is coming. But really great, in-depth, detailed things are available in these modules. And so once again, thank you for your attention and thank you so much for this kind of invitation.
Thank you, madam. One question. All the resources that we have online are basically the Western oriented thing. So we need, these are a need to extrapolate or to actually calibrate it to our Indian ophthalmic education situations.
See, to answer that question, I would actually take a cue from what Dr. Prajna said. You have to customize these things. When you present itself, if you present only things based on region, there is no end to it. You have to present the ideal scenario. You have to say what is the best possible, and then take what is possible for your institute. I don't know if you heard what I said. I think you have to customize to your institute. Having said that, a lot of the lectures, a lot of the content, even a lot of the publications involve people from all over the world. For example, the OCEX1 said you shake hands. So I objected. I said, in our culture, we don't necessarily shake hands. So then it says, greet the patient appropriately according to culture. So that is one of the things.
Should we prepare our own Desi version, all of us?
Like I said, you don't even need the Desi version. You could, M.M. Joshi version. Yeah, like the Joshi version could become the Desi version. All right. Thank you.
Taken, ma'am. Thank you.
Ma'am, just a small question. See, most of the institutes are now, especially I speak for super specialty institutes where there's a lot of referrals happening. How do you, propose to incorporate your communication skills where you have people with different dialects approaching you in your institution? So do you need to have, interpreters? How do you go about it? And with such a busy practice, Will it really be a viable option to, do the consultants really have that much of time to, practice this communication skills? Do you feel it is a viable thing?
So as I had mentioned, communication skills doesn't mean you do elaborate sitting in the session and chatting and talking away with the patient. It's right from how you greet. There are so many non-verbal cues. You basically have to show that you are an empathetic listener. And you can use many things other than just verbal cues. I can tell you, I trained in PGI, so I had to learn Hindi. Believe me, I didn't know Hindi. I came from deep south, so Hindi and to an extent Punjabi. Don't quiz me on it. And now in Shankar Netralaya, I had to learn Bengali. So it is possible to pick up important language. But what I'm trying to say that communication skills training is beyond language. Patients can very quickly tell whether you're interested in their case, whether you're empathetic to their case, whether you are a well-wisher for them. They can say that is well beyond words. I know because I primarily teach children, and that's where you really learn the importance of establishing rapport. So if you can establish rapport with kids, you can establish rapport with adults. So communication skills training is a lot, communication skills itself is a lot about non-verbal as well as verbal. But the most important thing with a trainer is that, as we talked about yesterday, you have to walk the talk. So you have to be vigilant that you are on camera the whole time, because there is a resident watching you and learning from you. And especially communication skills training is something they take from you. So
even with the ADCOM now being a part of the CBME, the undergraduate students are also, taught about communication skills. So that is a welcome thing that has happened with the new CBME.
Yes.
Okay. Thank you so much, Dr. Meenakshi. And now I call upon Dr. Srinivas to give his next lecture. This will be on professionalism in clinical practice. Also, I'd like to invite the chairpersons for this particular session, Dr. Hanmant Karad, Dr. Rajesh P. Gotekar, Dr. Shushmita M., Dr. Sudeep N.S., Dr. Jaya Madhuri, and Dr. Sudhakar N.A.
Yeah, either side, sir. Both sides is for you. So request the panelists to please join. Thank you very much. Once again, I would like to thank all the main two organizers, Dr. Santosh Honavar, sir, who is the brain behind this program, and Dr. KP. And I would like to give all the credit to them. And if any fallacies, I would like to take it on me. So please pardon me if there are any mistakes in conducting this program.
That's a good professionalism. Good professionalism.
Okay, I think KP is okay. So the practice of medicine is an art, not a trade or a business. It's calling in which your heart will be exercised equally. So it's now agreed that professionalism must also be taught besides being caught. So what is the expectation? Doctors are expected to consistently exhibit professional attitude, behavior, values, ethics. The concept of professionalism has changed over the time. Previously, doctors were granted the autonomy. They used to hold the pulse and they used to say, and they used to give some tablets and everything used to go fine. However, in contemporary, the society, this autonomy has been challenged by the altered public perception. This behavior is now being more and more scrutinized. So what does the society expect? The physicians will be competent, skillful, ethical, humanistic, altruistic, trustworthy. In exchange, the society allows the medical profession to be autonomous. The relationship between the medical profession and the society is what we call as a social contract. So look at this video which happened in Bombay.
You're looking at visuals that are coming to us inside a civil hospital in Mumbai. Start seeing celebration inside the OPD, was believe it or not, the outlaws are dancing and all this happening right inside the hospital. Herman has more details of this. I mean, is this real? I mean, this thing really happening inside the hospital in Chennai. It's a celebration about them. How is it possible that the patients will not be disturbed? I mean, something elements were lost there. Cannot perhaps put up to this kind of noise, right?
So the changing trends in the healthcare profession is complete autonomy to altered public perception, and now we are into constant scrutiny and the loss. Studies from the West have shown that students who demonstrate unprofessional behavior during the undergraduate or the postgraduate education are likely to found guilty of unprofessional actions. So now I think NMC, I don't know whether it has included the professionalism as one of the subject, because in the Western world, in the residency program, the professionalism is a subject. So I think the teachers here, you must be knowing more about it. So what does the professionalism talks? It's only about the good communication skills? No. It's about accountability, altruism, excellence, humanism, sound understanding of ethics, good communication skills, and clinical competence. So when I say accountability, take the responsibility of his or her behavior. The doctor has to take their own responsibility. Look into the patient's interest and not the self-interest, what's called altruism. Excellence, maintain continuous maintenance of knowledge, of skills, lifelong learning, compassion, empathy, integrity. So this totality of the framework of the capstone is called as the professionalism. So how should professionalism be taught? One is a self-motivation. That motivation has to be from inside. One of my pathology teacher used to say, Srinivas, the fire has to come from inside. You have to have the fire in the stomach. I can't teach everything to you. You should be self-motivated. So the fire has to be inside for all the students. Next, extrinsic motivation. Yes, definitely the teachers have to do reward, appreciation related to the behavior. Assessment works by the way of feedback as well as by providing extrinsic motivation. So again, interactive learning, case scenarios, case vignettes, Prajna sir explained very well, the DigiNerve, feedbacks, and the coming to the role model. So I keep telling my students, have role model in your life. Tell them that you should have some role model. When I started my PG course, I think KP sir and Santosh sir were consistently lecturing, kept on. It's probably in their blood to teach to the students. So that's how I consider both of them as my role model. And I keep telling my students to have role models, have your teachers, because sometimes, you know, the people that are working with Dr. Titiyal, they sometimes start being like Dr. Titiyal. So it's good, but they should also know the limits of it. So it's definitely important because the seniors teach the juniors. As Titiyal sir rightly said in his lectures, the seniors always teaches the juniors. So why should we assess the professionalism? Is because the health learner, they don't respect what you expect. They respect what you inspect. So it is the health learners will attempt to master the subject if they know that they will be assessed regarding it. Otherwise, they won't. So assessment drives learning. Right? So coming to the next, why start early? Lakoff et al. Argued the communication skills to be an integral part of one's cognition, which develop early in life and not through medical studies alone. So he is the master of the professionalism is George Miller. Miller's assistant pyramid. It starts with a novice surgeon, knows, then understand, shows, and does. That comes to the expert level. So when to assessment during the medical admission, that is just before the medical admission. So let's go into point one. There are many professionalism excerpts available yesterday online. I think few of the professors have already spoken about it. Is PMEX, that is professionalism mini evaluation exercise. And the most important thing which is said, we tend to judge the candidate many a times based on his or her behavior. Please remind that first impression might not always be the best impression. And we always tend to succumb to the first impression. If the student is not impressive, then for all those 3 years, we try to see that he is not impressive at all. So that might not be. Even the studies have shown that. So these are the competency, ability to handle stress, that is personal organization, that is level 1 novice, level 2 is advanced beginner, competent, proficient, and expert. So these are the various definitions which has been given. And who is an expert? able to prioritize tasks for self and others. He takes himself and also prioritizes, delegates the work to others. So this is the DeFries model of skill acquisition. I think you can go through it. It starts with a novice, advanced beginner, that is consciously incompetent, then consciously competent. That means you know that what you have to do, and then unconsciously competent, you know how to do something, you do it perfectly. So during the medical education and training, that is undergraduate or postgraduate, there are three important steps. One is the self-assessment. So what is self-assessment? Self-assessment is what happened, what was supposed to happen, why were the outcomes different, and what did we learn? So we have to assess ourselves. Why patient shouted at me today? Why the students were yelling at me today or they were disappointed? We have to go and try to assess ourselves. That is the first thing, is the self-assessment or the self-reflection. Most practicing physician observes each other's behavior only in the hallways or in the conferences. Effort should be made to gather the data regarding the medical learners and the practicing physicians' behaviors when they are actually working with patients. From other learners, colleagues, nurses, allied health staff, etc. Then comes the peer colleague based assessment. This is a little bit weak form of assessment, is because one colleague might not say anything bad about their friend or other colleague. So this is called as the multi-source feedback 360-degree review. And observers should include peers, nurses, and other healthcare. So these are the various, this is called as the UC Davis professionalism excerpt, right? So whether the tardiness, availability, whether the doctor is arriving late or the student is arriving late, is he available on all the occasion? Is he following the deadlines? Is he acting like a team player? Difficulty in recognizing his limitation, lack of respect, confidentiality, whether he's maintaining, whether he's compassionate, civility, prejudice. So these all things I think is very important to be looked into it. So these are the other things which I said. This is called as the mini CX, that is the WPBA. Again, the history taking, physical examination, professionalism, clinical judgment, and the communication skills. Now coming to the next, new approaches to the assessment. And this is a very dangerous tool, which is a double-edged sword, I must say, not a dangerous, but a double-edged sword. So assessment of social media use in medicine, right? So reveal the author identities, negative language describing the patients, violation of patient confidentiality. Let me show this video. Said that this is our way of de-stressing, but unfortunately, you know that public will not agree with that. And all of them lost the job. And you know, in the Western culture, if you lose the job once, to get another job is very, very difficult. So this unfortunate, small thing, which they could have done it by themselves, unfortunately, putting it up in the social media costed them very heavily. So again, assessment during the practice of medicine. The last point is the patient's feedback, because it is called as the most powerful. It's the Fitzpatrick. Level 1 is the valuation, level 2 is the learning, level 3 is intended behavior, and 80% showed improved outcomes. And it says that the most of the physicians change their behavior is only by patient's feedback. 80%, according to the US Commission. Not by the peers, not by the colleagues, not by the HODs, or not by the directors. It's by the patient's feedback. It shows that most unruly doctors change their behaviors. So this is how was the physician's performance? Was he telling you everything, greeting you warmly, treating you like the same level, letting you tell your story? But importantly, we have to cut the stories also of the patient sometimes. If they keep on continuing, it might be difficult. But how nicely you cut without criticize them is an art. And then showing interest in you, warning you during physical examination, asking your opinion. So these are the various options available. Now look at this. last. Right? Now look at this. This was again it happened in US. Sitting outside. And he went back. So what happened next? She put it up in the Facebook, right? And that got registered as a police case. And the FIRs, all those things started happening. The whole story is here. You can just put, you can search the witness statements, police report, and everything. So these are the things probably which we can avoid, and how we can face this is very important. And these are the various literature on professionalism. That is the mini val exercise, Wake Forest trust scale, ABIM music, Barry challenges, NDME. So these are the various literature available for how to assessing the professionalism. So they said that effective communication is associated with improved patient outcomes. And you can see here, more than 1,600, when they did the survey, 95% reported that they had routinely dealt with unprofessional, disruptive, including insults, yelling, disrespect, abuse, and refusal to carry out the duties. And these behaviors involve the patients, the nurses, physicians, and even the administrators. So this patient shows that unprofessional, disruptive leads to reduced patient satisfaction, increased patient complaints, and increased risk of litigation. So the Joint Commission of the United States estimate that 60% of avoidable adverse events are mainly due to communication errors. And this is how we follow at Joshua Institute the modification of UC Davis professionalism excerpt. We have made a Likert scale and we have given it to the floor area managers and the HODs and then coming to the directors. That is tardiness, as I said, arriving late. If the doctor or the PG is arriving late, and the ability or the occasion of being unavailable, and whether he's meeting the deadlines, he's acting like a team player. So all these things, I think it has to be evaluated constantly so that we also improve and our students also will definitely improve. So thank you very much for your patient listening. Thank you once again. Go to the, any questions you would like to take?
Thank you, Dr. Srinivas. Anybody would like to ask any question? Very important issue.
I think this is very important for all of us. I think our students learn professionalism looking at us. I think instead of we teaching them, I think we need to probably wear it on our sleeve all the time.
You can go to the next talk and then we can have panel discussion.
Thank you. Next topic is web-based resources by Dr. Santosh.
Good afternoon. I'll be speaking about internet resources in ophthalmology. This may not be directly useful to teachers, but you can definitely guide your residents after having sampled this and having appreciated the content. You can guide your residents to use this because internet is a double-edged sword. Whatever that we put in, if garbage goes in, garbage comes out, and curated knowledge is what is important. Acquiring knowledge from non-human sources such as internet, it goes against the Oslerian principle. He said that he who studies medicine without books sails an uncharted sea, but he who studies medicine without patience does not go to the sea at all. That is totally contradictory to the current principles of learning, where we don't have a patient in front of us when we acquire knowledge. So there is a difference between learning and training. Learning is an individual effort, can occur anytime, anywhere, whereas training is a bilateral effort. There has to be a trainer and a trainee. So if you're talking about learning as one of the components of training, or knowledge is a component of training or learning, then knowledge can be acquired online readily. It's just an extension of books. knowledge is everywhere. So internet has currently become inseparable from our lives. Everything that we do is connected to internet. It provides seamless 24/7 knowledge, but it's a double-edged sword, as I said, because whatever that is put in will come out depending on what you search and where you search for it. Garbage in, garbage out. And good knowledge is necessarily equal to a good source. So you have to go to a well-moderated and a reviewed source, preferably by an organization of repute. So what are the ways to get knowledge from the internet? One is a random search. If you type, say, diabetic retinopathy on Google, you'll get innumerable pages of information. But you'll be lost in that because these are from various sources, right from blogs to patient experiences, and it may not give you encapsulated, ready knowledge. Then there are individual run educational portals. These are by organizations or individuals who run curated portals where they put up information which they think is important for whoever, resident or teachers. Next is organized education portals for online learning, which are in the next level, where they are meant for this purpose. Others are organized internet-based resources such as journal websites, but that is kind of confined to what the journal offers. Specialized search engines such as PubMed will give you a lot of information about scientific publications, need not be in a very organized format. And then there are ebooks. Ekalavya was the first documented e-learner, right? He observed and learned, and so E in Ekalavya possibly goes for electronic learning or e-learning. So what about the diagnostic skills? If you have a first-year resident who comes to you and does not know how to use retinoscopy, he does not appreciate how the glow would look and how it moves, then we can advise him or her to use this retinoscopy simulator. This is online. You can simply change the power and you can know the point of neutralization. You can see how crisp the reflex would be at what refractive error and how the glow changes depending on the extent of refractive error. All this can be easily known even before that person goes to the patient. RAPD. Mild, moderate, severe RAPD can be visualized online. And this is easily available. These are tools that are available. These were earlier private sources. Now it has been integrated with American Academy of Ophthalmology interactive tool, retinoscopy simulator. If you go to AO.org and look for interactive tools, you have many interactive tools, including a retinoscopy simulator, which will make life very comfortable for a junior resident because he goes to the patient and then starts fumbling. Instead of that, he knows what exactly to look for and then goes to the patient. That is AO.org, RAPD. And then this is AO.org glaucoma module, where there is gonioscopy as well. This gonioscopy.org is another website that is completely devoted to gonioscopy. In fact, it shows you all the forms of gonioscopy and the kind of images that you would see on gonioscopy, and diseases as well as normal anatomy is all there. I would cut the video short because of lack of time, but this is a very comprehensive website that will show you exactly what you look for in the angle before you put the gonioscope on. Then there are ophthalmology knowledge portals. We all are familiar with Wikipedia. Wikipedia gives you some kind of semi-curated information. Contributors are general public to experts. But iWiki is special because here the contributors are ophthalmologists themselves, but they may be at various stages of learning. In fact, iWiki holds an annual competition for residents in training where they can write on anything that is already there on iWiki or some on a new topic. And the best of these get a prize. That is, they get to attend AO conference free of charge. So this is some kind of a content which is curated. Now, what all is there on iWiki is mind-boggling. Everything that you would expect in a textbook is all there in iWiki. But the best part of iWiki is that it is dynamic. It is constantly updated. It takes about 10 years for new knowledge to get into books, and it never comes out. So books, unless they have a new edition, can never be updated. If you're stuck with a book, you're stuck with a book because that is the information that is already printed, and these are not dynamic, whereas iWiki is dynamic by the day. If there is some new information that is published that week on a given topic that may change your practice pattern or your diagnostic ability, then that can be put into iWiki readily. And the next week when you refer to it, you have new information already. So it is dynamic content, and that is what we should appreciate about internet resources, is that It's very dynamic content. Then if your resident has a case presentation or a seminar or a symposium and you're not able to give him or her the pictures, you can go to Atlas of Ophthalmology. This is free content, pictures, collection of pictures, the beautiful ones from all over, but copyright free. But of course, you have to acknowledge the source that you have taken it from Atlas of Ophthalmology. That is important. These are very nice representative teaching pictures you can easily download and use. Now, universities also run special website. Moran University of Utah has a very nice website. It's called Moran Core, where there is core course, grand rounds, resident lectures, surgery videos, and information for students and residents. This is somewhat of a curated website, and they have grand rounds online. So every University of Utah grand rounds by the third year resident is online. You can actually see how they present and how the faculty mentors them and how do they interact. There is a lot of learning for everybody here. Apart from that, they have curated or archived grand rounds right from 2013 to 2021. So if a resident were to go through this at leisure, you'd find hundreds of cases that are already presented. So they will learn the art of presenting in a grand round. They'll also learn the art of answering a particular question or tackling an uncomfortable question if that is asked. Then there is one more website that is called irounds.org, which is devoted to grand rounds or grand round kind of presentation. It has case reports, tutorial, atlases, and video. I'm running through this very rapidly because I can't show you on hyperlink. You can explore for yourself because this takes time for you to explore. Columbia has a beautiful digital reference of ophthalmology. So basically what you're seeing is that each major university has their own website, which they think is important for the kind of population that they cater to, their own residents and their own alumni and faculty. So that is absolutely customized for the kind of uses that they expect out of their information. This is University of Michigan, has Eyes Have It as the website. It's used to be a very popular website. Again, they have everything, eye symptoms and signs, and quiz, anatomy, etc. They also have systemic conditions website, which is very useful. Now, iGuru.org is a collaborative effort between UCLA, Doheny, Arvind, Wilsa, and Massa India. So all the big names are there. Not very active currently, but it gives you high yield pearls, especially there's a system of examination in the US called OCAP, Ophthalmology Knowledge Assessment Program. All residents give it. And this is some kind of a high yield kind of a situation where they get curated, ready knowledge at will. So this is something that most of the residents in the US would refer to. Now, Orbis has what is called cybersite.org. Orbis is the flying hospital. They have a beautiful website which is aimed at residents. They have a lot of lectures which are full 1 hour lectures. They're not hurried 10-minute or 5-minute lectures. They give a lot of time for the lecturers to present their material. In fact, when I gave the Orbit talk, it was 1.5 hours. So you can leisurely teach the residents and they record all of it. At the end of it, there will be an interaction. Even that is recorded and put on the website. And they have a library of all the old lectures. That is University of Utah that also runs a website. And then going on to special information, ophthalmic pathology, which is kind of a lost art. Many of the ophthalmologists don't know much about pathology, and pathologists don't want to practice ophthalmic pathology. So there is an issue with pathology, and this website gives you a lot of information about ophthalmic pathology specifically, and this is about the neuro-ophthalmology website. Now, closer home, we have e-Ophtha. It was actually started by a resident himself, Pratim Datta Majumdar. He is currently a faculty at Shankar Netralaya. He started this website as a blog. Now it has all exam-oriented information, including old papers of DNB, old papers of many universities, question papers of final exams, which is all classified. By AIOs, we have the journal website, IGO and IGO case reports. We have AIO's proceedings that Arup keeps sending you every day, but it is also stored on a website. So you can go back to the website if you miss the email and look at the entire proceedings of all the conferences, current and the past. If you're not able to attend a conference, don't bother, simply go to AIO's proceedings and you have all the presentations, including free papers that were presented in a conference, instruction courses, etc., readily available. Then ARC also stores all its information on the AIO's website. So ARC keeps having webinars twice a week, right? Yeah, so they have very webinar intensive kind of a situation, and they store all that online. Then there is AIO's discussion forum and case of the month, etc., which are not very active. This is the IGO website, which has all the issues of IGO right from 1950s. Right from the first issue, we have PDF of all the issues, and we currently launched the IGO app as well for you to have these access on your mobile phone. So you have all the issues of IGO readily available on the IGO website. Simply select the year in this drop-down box, and you have all the issues that are freely available in a very nice searchable format. IGO case reports is also on the website. Now we have IGO videos as well. IGO videos is published as part of IGO. This is indexed from the first month itself, and these are all stored on a YouTube channel, which are readily accessible. Now, American Academy of Ophthalmology has ONE network. ONE network is beautiful because every AIOS member gets access to ONE network free of charge. You don't have to be a member of American Academy of Ophthalmology, get access to the ONE network. The best part about ONE network is the journals. You can see every journal that you want to see is here, right from ophthalmology to AGO to survey of ophthalmology. Of course, IGO is also there, and then you have GAO. Most of the major journals that you want to see are all there in the ONE network. So it gives you a very nice free resource for accessing journals. It's like an e-library right in your hand. Apart from that, ONE is very organized. They provide you a lot of video content, case reports. The most important, I feel, apart from the journals, is that they have what is called preferred practice pattern. Now, International Council of Ophthalmology also has a portal mainly aimed at teachers and also have member society symposia stored. ICU also provides some journals. So many of these international societies provide journals. Now, this is iplanet.com. This is run by a pharmaceutical company in India. This has free access to some of the journals and books as well. So this is by Sun Pharma, I believe, and they run this portal free of charge. You can become a member and get access to many of the specialty journals which are otherwise not accessible to you by subscription, free of charge, and ebooks as well. Then there is structured, scheduled, formal online training. We are maybe familiar with iFocus. This used to attract about 400 residents at a time. Because of COVID, we could not hold iFocus for a couple of years. Then we thought about having iFocus online. Now, this happens every Wednesday and Friday, every week, all through the year, except that for AIOS conference, we take a break. Otherwise, it happens all through the year, regularly from 8 to 9 p.m. every Wednesday and Friday. Sometimes the schedule may change depending on the availability of the teacher. You can see that this has 19,200 subscribers and 335 videos. This is a screenshot that I took today morning. And it has lectures from everyone that you may be familiar with, everyone that you may have heard and seen who are real international and national authorities in teaching. All these are topics that are taught for 1 full hour, followed by an interaction. So this is not a hurried 15-minute or a 20-minute lecture. They actually go into the depth of each topic. And the beauty of it is that it is actually synced to the AIOS curriculum. So what I have done is I've taken the AIOS curriculum. Each topic has been allotted to a speaker. And ultimately, we plan to have the AIOS curriculum online. And when you hyperlink it, when you click on one particular topic, it goes to that particular lecture. And we plan to add lecture notes as well. So how many people have access to it? Of course, there are paid versions of other products as well, but then free is often not disregarded. You can see that there is 15,07,021 views right from June 1, 2020. Now we are in April 2023. That's for less than 3 years, we have 15 lakh views. These are officially recorded views by the YouTube, with 19,200 subscribers, majority of them from India and Asia, and many of them from international sources as well. Auro Shiksha also has a similar website that's mainly for technicians and ophthalmic personnel. And we have LVPI grand rounds that are now live for access by anybody. So 7 to 8 a.m. in the morning, if your residents have time, they can become a member of this and access LVPI grand rounds and LVPI teaching. We used to have RPC rounds as well. I'm not sure whether it is still working or not. This used to be there during COVID times. whatever that was presented in RPC by the residents was available to everyone. Podcasts are something that you can listen. It's not visually intensive. So even when you're driving or if you're just lying and resting, you can put in your earpods and listen to podcasts. Podcasts are very nice source of information because you can close your eyes and listen. So that's not so visually intensive. So your hearing is what is attached here. And these are some of the podcast sources that we have. iTube also has videos, and SN Snippets is currently becoming popular. SN is by Shankar Netralaya. This is a purely podcast medium. They have lectures like such as accommodative isotropia and lens for myopia control, etc. Now, apps are also there. My Eye Anatomy, iTube, iGrader, Opto Questions, and AO are some of the apps that are available on both iOS and Android. About surgical skills, we have a nice channel that's called iTube. Just like YouTube, it is iTube. This is also by the American Academy of Ophthalmology in collaboration with them. There are a lot of videos here, thousands of videos by experts, but these are not like descriptive videos. These are mainly surgical videos speaking on a particular technique or part of a particular technique. But look at the beauty of the videos, how clear these videos are. These are professionally recorded. Surgeries are done really well. These surgeries don't get into iTube unless the quality is very good. And the person who is doing it is an authority in this topic. We have personal collections as well. Then there is Uday Devgan's Cataract Coach. YouTube has a lot of ophthalmology focused channels. And there are virtual simulators. This is called Cataract Master by Mass and Ear, where you can actually select an action and the video that is attending will show you exactly how to do that. So resident can practice some of these surgical skills online. And if they do it wrong, then there is a prompt that you did it wrong. So go back to the original video, look at it, and come back to the simulator to further practice their skills. There's also a theory component. This is called Get Help. I can't click on the hyperlink, but what just happened is a question. So if they do it wrong, when they click on this will explain to them exactly what did they do wrong. Was the angulation wrong? For example, make a paracentric incision with a blade parallel to iris stroma. But if they angulated it, the website will tell them that you angulated it. That's why your direction is wrong. So what went wrong and what should I do next? How would I have done it properly? So these are AI sensitive websites. They are actually sensitive to what you do online. They pick up your mistake and will guide you further. This is nothing to replace human resources or wet lab situation, but this is something that can add to all that. And simulated intraocular surgery is something that is also there now, and also remote mentoring, cataract surgery video channels, which are all nicely mentored. And there is a nice website by American Academy of Ophthalmology again on simulation in resident education, which are some of the simulated videos which are commercial and non-commercial are all available. About publications, we all know about the importance of PubMed. I'll skip on that. But about presentation and teaching schools tools, we have many now. Actually, COVID opened windows to a lot of presentation tools, including Zoom, Skype, Microsoft Teams, Google Meet, etc. But Socrative is something that is recommended by Ophthalmology Foundation. This is an app which can be used for flipped classroom. There's a teacher and a student module. This is a mobile phone app both on Android and iOS that can be used. This is free version and there is a paid version as well. And so in conclusion, I would say that internet resources are unlimited and boundless, but we have to limit to time-tested and curated resources so that we get reliable information without wasting of time rather than random surfing. So information management is like having your mouth to a fire hose. So you get a lot of water, but what is important is that you should know what to swallow and what not to swallow. Thank you so much.
Any questions for Dr. Santosh? Yes, Santosh.
I'd like to make a comment. Thank you. So as I had alluded to before, the Ophthalmology Foundation, OFECC, they have a monthly newsletter. So once you sign up for this newsletter, we are a bunch of about 6 or 7 of us who are on the editorial board. So our job is every month to search the internet for new resources that are coming up in ophthalmology, particularly resources for teaching and assessment. So not only ophthalmology, even for example, it may be general surgical education, but sometimes they'll have good ideas that you can incorporate. So we search and we recommend it to the editor, who then adds those resources to the newsletter. So if you sign up for this free newsletter, you will have a dynamic list of new resources that you have access to every month.
Thank you. About Santosh topic, I would like to suggest to everybody that unless we spare some time for the internet resources, we are not a complete teacher. That is what the message is from the Santosh.
No, I think we have to put our mouth into the fire hose first and see, and then probably, in fact, show them the place or show them the exact context where probably to look for a particular.
Yeah, that was the idea. I mean, as Prajna put it very nicely, things have changed, and most of the residents, when they come in, they have already tasted preparation modules for NEET and NEXT, etc. So the way they prepare for exams, way they study has totally changed. It's gone the marrow way, so to say. So unless we are familiar ourselves with internet resources, we will not be able to create such resources for them, and also not be able to recommend correct resources for them. Otherwise, they will go and refer to something that may not have accurate information or may not provide them with information that is adequate. That is the entire idea of us, for having us to sample these resources first and then recommend it to our residents.
So I thank Santosh. And now the next topic is how to set up an ethics committee by Dr. Uma.
Dr. Uma Kulkarni is a professor of ophthalmology in NFIA Medical College, Mangalore. She is known for her zeal and passion for teaching, and she has a lot of innovations to her credit in teaching undergraduates and postgraduates. And she's also a part of our NABH team as well as the ethics committee. She's the main part of the university, NFIA University. Over to you, Uma.
Thank you, sir. First of all, I would think that this topic is a little outlier compared to what we are talking from yesterday. But research being a very important component of the curriculum for postgraduate and even undergraduate students, I think this finds its own importance. So thank you, the organizers, for giving me this opportunity to talk on how to set an ethics committee. And I'm Dr. Uma Kulkarni. I'm the member secretary of NFIA Ethics Committee 1, situated in Mangalore. So do we need an ethics committee? So the question is, do we really need an ethics committee? Yes. If we are conducting research on involving human participants, then we definitely need an ethics committee, particularly when you are conducting a research either directly or indirectly involving the human participants. That means you may directly give an intervention to the participants, or you may just be observing them, or you may do a retrospective study. For example, on fundus images, FFA images, OCT images, or any other histopathological slides or leftover blood samples. So all this requires an ethics committee approval. The study can be interventional or can be observational. You may actually be giving an intervention in the form of a drug, or a device may be used on the eye, but it requires EC approval. So why do we require an ethics committee approval? The reason is the history. Our research experience in the past has not been so good because there were no guidelines. So we all know about what happened to the Second World War, post-Second World War, and the Nazi experiments were conducted without any respect to the prisoners of war. And brutal experiments were conducted, and that's why guidelines came up. Even after the guidelines came up, research was not conducted in an ethical manner. So we know the famous story of the Tuskegee syphilis trial, in which syphilis patients were observed without giving the penicillin. They were just observed and seen how they move from primary state to secondary stage to tertiary stage, and how they developed complications and died. So to stop all this kind of a history from repeating again and again, we need an oversight, and this oversight is provided for research in the form of an ethics committee. And that will ensure the safety and well-being of the research participants. What if we don't have an ethics committee? So if we don't have an ethics committee, we can still do research, but that research can be restricted only to literature review, which is already available in the public domain, or you could do an in vitro study on cell culture, cell lines or so. But that's not always what we want, because we want a wide spectrum of research also. And therefore, it's essential to set up an ethics committee. Suppose we don't have an ethics committee in our institution or the clinic, then we can approach an ethics committee which is located 50 kilometers within that radius. So, and no ophthal pictures. So I use this ophthal picture to give a touch of ophthalmology to my topic. So how to constitute an ethics committee? First of all, go to the guidelines, because guidelines also keep changing. The requirement for committee members also keeps changing, and therefore need to go to the guidelines, select the members as per the rules, and then get a letter notified by the head of the institution. Later, we have to register the ethics committee with the ethics bodies, that is with the regulatory authorities in this case. So what are the mandatory requirements for an ethics committee? First one, if the ethics committee is reviewing clinical trials which are sponsored by pharmaceutical companies, then the ethics committee has to be registered with the CDESCO and the DCGI. So that is mandatory, without which an ethics committee cannot review or approve clinical trials, and a clinical trial cannot be conducted in a when EC is not registered with this. So it's mandatory. The second thing is, if postgraduate students or even faculty members are conducting academic research, which does not involve a sponsor, in that case, the ethics committee has to be registered with the Ministry of Health and Family Welfare's Department of Health Research, that is DHR. So our ethics committee is registered with both, because we get both research involving sponsored clinical trials as well as the academic research. Thirdly, if the researcher is getting funding from the US, from the NIH, you need additional registration with the OHRP. So what are the site requirements? To start an ethics committee, we require a secure office. And this office has to be secure in the sense with biometric system in place, so that only authorized person can enter that ethics committee. They also require a research room where informed consent is conducted, and all the documents related to research are stored. The access is not to be given to anybody else other than the research team members. So this is the first requirement. Second, we need ethics committee requires a very good secretarial support to handle the files, emails, communications, documents, and etc. It also requires an archival room, a strong room in which all the documents are stored. And again, this is biometric system which is required. And the documents are to be stored for 3 years after this research is completed. And in case of clinical trials, the documents have to be stored for 5 years. So this requirement is essential from all the regulatory point of view. Next is we require good SOPs. And these SOPs I have just classified into 3 components. The first one, a standard operating procedures required for how you will constitute an ethics committee, how will you choose members, how will you train them, what happens when somebody resigns, what is the quorum requirement, conflict of interest, and confidentiality. All these, there are SOPs. So we have around 26 SOPs in our ethics committee, each one defining and describing one process. The second one is the protocol review process. When a protocol comes, how is it categorized based on the risk to the participants as per ICMR guidelines? Then you have a expedited review, full review, or sometimes even exemption from review. How the review process is conducted, who should review, post-approval processes like site monitoring, and sometimes when you have a serious adverse event, how it should be handled, like including how to assess the causality and relatedness to the drug. And lastly, documentation. There has to be a good SOP for how you document it, how you archive it, auditing, training, and maintaining the standards as required by national and international levels. So, composition of the ethics committee. the most important person, I would say, is the chairperson of the ethics committee, who is not supposed to be from the same institution. It has to be a non-affiliated person so that the independence of the ethics committees is maintained. So the ethics committee is not under pressure to approve certain protocol because it comes from the dean or the director of the HOD or somebody very influential. So happens to be that it's better to have a medical person as a chairperson of the ethics committee. And one of the important roles of the chairperson is to ensure that meetings are conducted in a nice manner, correct manner, following the procedure SOPs, assures the quorum, and sometimes, whenever required, even gives the casting mode. So chairperson is a very important person, which makes the ethics committee independent and strong. Next is the member secretary, who is like this, multiple roles in the ethics committee, and an internal member who's mostly full-timer in the institution, dedicated and available whenever it is required, because sometimes you get emergency calls saying that there's an SAE, kindly come conduct a meeting. So it's like a driver of the ethics committee and takes part in A to Z of the EC work. At least 2 to 3 hours in a day is required on part of the ethics committee, member secretary in the ethics committee work. Next is clinician. Clinicians are required in order to look at the scientific medical aspects of the protocol. You can have 2 to 3 or 4 members in the ethics committee. Apart from ophthalmologists, you need to have a physician, a surgeon, you can have a pediatrician, because many researches are conducted on pediatric ophthalmology. So clinicians play a major role again in the medical and scientific review of the protocols, as well as in serious adverse events, to find out whether the adverse event occurred because of the drug which was being investigated. Next is a basic scientist. This is one of the most important persons in the ethics committee. Usually when clinical trials are conducted, you require a pharmacologist. Otherwise, you can have any other basic scientist. Pharmacologist is preferred because he or she is the one who will look into the investigational product, the pharmacogenetics, pharmacodynamics and all that, and also review the scientific aspects of the protocol. Again, pharmacologist plays a very major role in serious adverse event decision making. The next is a social scientist. Social scientist is also required in an ethics committee, and as you can see, it's a very interdisciplinary committee. This social scientist or an ethicist or a theologist or NGO, that's how they describe this role. And this can be internal or external role, and looks into the social, cultural, and religious aspects of the project. Next is a legal expert who will look into the legal aspects, including the clinical trial agreement, MOUs, insurance documents, and the compensation issues in case of serious adverse events. A very important role in the ethics committee. Layperson, the name looks little unimportant, but it's very important role in the ethics committee, because this layperson is actually going to represent the community from where the participants are coming. This is particularly important for community-based studies and for review of all the informed consent, whether the language is appropriate or not, whether this will be understood by the participants or not, will be looked at by the layperson. So we have these 5 members who are very important, the highlighted ones who are very important in the ethics committee, and they have to be there, and only then the quorum can be confirmed for review of any clinical trial. Without them, it cannot be discussed or deliberated or decided upon. Also, the regulators say that the ethics committee has to be multidisciplinary, women members have to be there, and 50% of the members have to be external. Guidelines to follow, and just 2 minutes. Guidelines to follow for all studies involving human participants is the ICMR's National Ethical Guidelines 2017, which need to be followed by the researchers and the ethics committee. And for sponsored clinical trials is the new clinical trial drugs, NDCTR, new drugs and clinical trial rules. This is gazetted in India. And the other rules are the COVID guidelines, pediatrics research guidelines, stem cell guidelines, and many other guidelines which are available. For member training, research ethics training, GCP training, this is mandatory to become an EC member. And lastly, training on SOPs and also updated information on research ethics as and when required. So there are many accreditations which are required. One you can do as internal audit. Next is the NABH accreditation, which is still not mandatory, but very likely to become mandatory soon. And the last one is the international recognition by FERCAP. So our ethics committee is doing all these three, and these are some of the accreditations that we have got. And because of this, we are ensuring that our patients and our participants are safe, and we are maintaining national and international guidelines, standards of protocol review. And it also helps in professional and institutional development and visibility. So with that, I thank everyone for giving me this opportunity to speak on ethics committees.
Thank you, Dr. Uma. Can you just have a show of hands? How many of you have your own institutional ethics committee? Oh, Uma, that's great.
No, but still this topic was very important, and she has stressed it very nicely, all the points with the common man. And that we need to keep it over a period of time, because the coming time is going to be definitely tough for us.
Yes.
Every time the legislation and everything.
I think, ethics committee is a very important part of, educational system, research areas. Now, for our students, we have a separate ethics committee. That is the, student thesis academic thing, because that requires a little different thing. Then you have a separate animal ethics committee, which is much more difficult than any other committee. And to go through that is one of the most challenging thing, where you need to have a different guidelines and different members also, and all three has to be there.
Yes, Dr. Ravindra, can you use the mic?
There was a mention in the website that there can be chairman and joint chairman and secretary joint chair.
So when the workload is more and there's a possibility that chairperson is not able to come all the meetings, you can also, our ethics committee has a chairperson, as a co-chairperson, has a member secretary and a joint secretary.
So co-chairman can
yes, but he will have the same responsibility as a chairperson, will be the chairperson, acting chairperson only when the main chairperson is on leave.
Okay.
And again, he's an external person. He or she is an external person.
Hello. I want to comment on this communication. Just we were not here at that time. You are not called. So as a doctor, one has to do information, education and communication. You are listening to the story of a patient. Many times you are hearing to the story. So you are not listening. So I will just give an example that a small story, how hearing and how listening is important. So 30-40 years back, there was an interview. At that time, it was a Morse code. So there was they called for an interview. Applications were there for the person who knows how to send the message by the Morse code. So although there were 40 applicants and they were sitting in the room, they were eager that somebody will call them for an interview. After half an hour, everybody started chatting and said that there was a noise everywhere. Another 5 minutes gone, one of the applicant goes inside the room. He came within 5 minutes with a manager, and the manager told that interview is over and we have given this applicant the seat, what we call for this interview. So everybody started grumbling. There was no call. Nobody has called us. And how the interview is over. So the person, he told, when we were chatting, there was an announcement, kadakatta, kadakatta, you can say like this. So whosoever is listening to this message, kindly come inside and take the appointment later. So he said, you heard, I listened. तुम्ही आवाजातला गोंधळ ऐकला, मी गोंधळातला आवाज ऐकला. So when you are listening to the story of any patient, you have to give ear, because it is an art of science that deals with the commerce. So history taking with ears is very much important. Class.
Thank you, sir. I think we had 3 lectures, professionalism by Dr. Srinivas, the way of, flipped classrooms by Dr. Prachna, communication by Dr. Meenakshi. I think all these have one common thread that we need to actually involve our students more with, role playing as well as with case-based scenarios. We just giving a dry lecture would not be enough. You create a scene, ask them to imagine that, and you understand how they actually, participate, or how they come out with a solution. So you just give them a scenario, probably that will be the way to go about. Like, for example, for example, like you give a scene that you are taking a two-wheeler and going, and there's a bus stop. There's a bus strike that they don't know. There are 3 people waiting. There's an old lady who's waiting. Your close childhood friend is waiting. And then beautiful lady is waiting. You have only a two-wheeler. To which of these 3 you'll give a lift? So this can be a situation for a student. Okay. So if you ask me, I will give the two-wheeler to my friend, ask him to give a lift to the old lady and wait in the bus stand with the pretty lady. So with that, we finish this session before pre-lunch session, and we'll break for lunch now, and we'll come back soon because we have a session at 2:00.
Session on symptoms and signs of a problem resident. I think it's going to go live at 2:00. I know it's just 20 minutes from now, so we can have quick lunch and then we can be back. So that we'll finish the session soon today as per promise.
I asked my. तुझा बाजूचा संघर्ष तुझं एक काढून जाऊन दे ना तुझं आपण नको सिंगल सिंगलच काढ चालू करू अटेंड केल्याची आठवण नाही लवकर का जेवण 15 मिनिटात जेवण चप्पल का काढतेस तुझी कोणते आले मी काढते ना सिंगल जाऊन आपल्या अवलंबून सोबत रेडी बाय बाय झाले ते कंपनी वाले होता बस नको ते काढलं कशाला मग
Don't go according to plan.
ಅಷ್ಟೇನೆ ಕ್ವಶನ್ ಆನ್ಸರ್ ಟೈಮಲ್ಲಿ ಬೇಕಾಗತ್ತೆ ಅಷ್ಟೇ. ಹಾ ಆನ್ ಮಾಡ್ಬಿಡಿ.
You can
ಆ
put
ಕಡೆ
the screen, put the screen on record.
ಇದು ಬರೀ LED ರೆಕಾರ್ಡ್ ಆಗೋದು. ಇದು ಲ್ಯಾಪ್ಟಾಪ್ ಚೇಂಜ್ ಮಾಡಿದ್ರಾ? ಲ್ಯಾಪ್ಟಾಪ್ ವಿಡಿಯೋ ಅಂತ ಇದೆ.
Not the stream. The screen only, not Zoom.
Want that? The same.
The Pedagogo. You will be displaying your play that video and put that online on screen.
It's live.
Mute. Okay. Start my video.
To us on the two important topics. And the important topics that she will be covering will be the principles of precedent assessment and the tools for assessment. So over to you, Dr. Philippi.
Thank you so very much.
Just 1 second, Dr. Philippi. We are unable to hear you. Just 1 second. Could you try talking once just for voice check?
Hello? Hello?
Just 1 second. Still unable to hear you.
Hello? Can you hear me now? Hello?
Can you hear us, Dr. Helena, once again?
Yes, I can hear you very
No,
well.
I'm still unable to hear you. Just let me sort this issue that we are facing. Try talking once again, Dr. Philippi.
Hello? Hello, can you hear me?
No, it's still not working. Let me fix this, Dr. Philippi. There's some issue. Could you please do me one favor? Could you please log in to the Zoom portal once again? Because you are online and the video is perfectly fine. However, we are not able to hear you. And till then, I can play the next talk by Dr. Eduardo in favor of time, and we'll get back to you.
Okay.
Maybe by the system. Start the same.
Hello, I will present the ophthalmic.
So we do know Dr. Gaby Palace. She's given her lecture earlier. So we move on to her video first, and that is on OSEX. You have been hearing about OCEX for a long time in multiple conversations and multiple speeches. So let's have an overview about OSEX from Dr. Gaby Palace.
Ophthalmic clinical evaluation exercise. My name is Gabriela Palis. I am a general ophthalmologist, associate professor at the Department of Ophthalmology, Hospital Italiano de Buenos Aires in Argentina. And I'm also co-chair of the Ophthalmology Foundation Education Programs Committee. The objectives of this presentation are to describe the use of the OCX for observing and assessing resident skill and performance, and to give them formative feedback with this tool. We usually assess residents with the more traditional assessment tools like written exams, orals, or essays. But one of the principles that assessments need to follow is that they should be authentic, meaning that they can determine if student knowledge can be applied outside of the classroom. In the health professions, this would mean related to patient care in the operating room, in the clinic, working in a team, etc. Multiple choice questions, essays, and orals assess the lower or more basic aspects of professional competence. But to assess higher levels of competence, we need other tools, and we need to observe residents in their daily life. Some examples of workplace-based assessments are mini clinical evaluation exercises, or the mini CX, from which derived the OCX, the multi-source feedback or 360-degree assessments, directly observed procedural skills or DOPS, audits, significant events. The ophthalmic clinical evaluation exercise was first published by Gornick, Goldenhar, and others in 2004, and its reliability was determined 1 year later in a subsequent study of 94 academic programs in the United States. The tool consists of the observation by an instructor of a clinical encounter between a resident and a patient. The instructor evaluates different aspects of professional competence, like interview skills, examination, interpersonal skills, and professionalism, and case presentation, using the ophthalmic consultation, and grades the resident's performance, guided by a rubric with behavioral descriptors. This is how the tool looks like. It has a checklist of slightly more than 1 page, in which the assessor must determine, by observing the resident during the consultation with the patient, if the resident does not meet the expectations, meets some, all, or exceeds them in terms of interview skills, exam, interpersonal skills, and professionalism. The checklist has a behavioral rubric that describes the expected behavior that helps to decide if they do not meet some, all, or exceeds expectations. Observe this video where the resident is checking the patient's pupils and try to decide how he is performing. You have the scoring grade and the rubric up here in the slide. And take a look at it and then try to decide how he is performing. It's controversial, isn't it? Some may say it meets some expectations, some may say that it meets them all, or some may say that they don't meet them. 15 years after the publication of the OCX, we thought that it was necessary to review it and to revise it, as well as to validate it for an international audience of ophthalmologists. We used the OCX developed by Gornick and Goldenhar and kept the same set of skills as the original instrument. We reclassified the original skills and behavioral descriptors into a modified Dreyfus and Dreyfus scale of stages of competence. We changed the categories of the original scoring rubric, does not meet, meets some, meets all, or exceeds expectations, to novice, beginner, and competent, each of them with its corresponding behavioral descriptors. The first version of the OCX that was developed 15 years ago has been widely and long used in the United States and other countries. In a survey of 56 out of 118 residency programs in the United States, faculty and collaborators reported the use of the instrument by more than Chinese, Mongolian, Portuguese, and Spanish. We have disseminated the tool and practical instructions, including example videos on how to use it in our faculty development programs for directors and educators around the world. And one of the advantages of this tool, unlike the mini CX that inspired its authors, is that it has aspects of the consultation and behavioral descriptors that are specific for ophthalmology. One of the reasons the tool has been criticized was the fact of the variable interpretation that observers give to the grading scale anchors, which makes difficult to achieve inter-rater reliability. We thought it was therefore appropriate to modify the original tool's grading scale to a scale based on stages of behaviors, such as the Dreyfus scale that puts more emphasis on performance and progression of competence acquisition. We recommend the use of this instrument primarily for the provision of feedback. We think the simplification of the scale will facilitate its use in training programs. We were able to incorporate suggestions and modifications that will expand the possibility of using the tool in programs around the world. We believe that these recommendations increase the phase and content validity and feasibility of the tool, since they collect opinions from international ophthalmologists and educators different from the US authors that developed the original OCX, especially for professionalism and interpersonal and communication skills that may be culturally variable. The value of these observed assessments lies fundamentally in the feedback provided by the observer to the resident and in the possibility of developing with the trainee an improvement plan. It is advisable to assess several of these encounters to ensure a diversity of cases, situations, and contexts throughout the years of training and by different examiners. Residency program directors should follow up these improvement plans, which should be brief but significant, so that learning and professional development can be truly verified. The advantages of the OCX is that it's a practical and fast tool. Each consultation should take a maximum of half an hour. Its validity and reliability has been determined in 2 studies. It is economical since it is done in the office with the patient. It is systematic since the same domain is always observed. And it also has the advantage that it remains written to allow monitoring and follow-up. Among the limitations, the instrument was criticized because it does not contemplate every possible situation that may arise in the clinical consultation. Although we have tried to improve some aspects, this granularity escapes the purpose of the instrument. The observer may add comments if situations such as these show up. Also, not every step of the examination or the interview will be compulsory in every consultation. For example, a visual field may probably not be needed for a patient who has a corneal foreign body, so the box "not applicable" will be useful in these cases. Some also criticize its authenticity, considering the resident will behave different knowing they are being observed. However, it creates a unique opportunity to observe residents and give them quality formative feedback. In our program, we use it for the formative assessment of residents, so the resident must receive feedback on their performance. It is done in the middle of the rotation to allow them time to improve in the remainder of the rotation. We do it with first-time patients in consultations of no more than 15 to 20 minutes, and we do 2 per resident. In conclusion, the OCX continues to be the only tool for workplace-based assessment specific for ophthalmology residents and the ophthalmic consultation. The ICO OCX improved and simplified version will facilitate its use in the observed assessment of residents' competence and delivery of feedback. The international experts' opinion of its relevance and applicability will facilitate its implementation to diverse programs around the world. Thank you for your attention, and the paper has been published in the Indian Journal of Ophthalmology. You have the citation here. Thank you very much.
So we thank Dr. Gaby Palace for this wonderful talk, and we move on to Dr. Helena Philip. I think she's ready now. Dr. Helena, can you hear us?
Can you hear me? Hello? Hello?
Just for 2 seconds.
I can hear you.
Keep speaking.
could you say just a sound check?
Yes.
Yeah.
Hello?
Yeah, we can hear you now. Perfect.
Oh, thank goodness. So I'm going to share my screen. Greetings, everyone from Brussels. It's a pleasure and a joy to be joining and participating in Pedagogo. Thank you so very much for the Ophthalmology Foundation for the opportunity. Thank you, Professor Karl Golnik. Thank you so very much as well, and congratulations to Professor Santosh for the initiative of this amazing venture on medical education. So in the next few minutes, we will be thinking and sharing some thoughts about principles of resident assessment. And if we look at the etymology origin of the word assessment, it is based on assidere, or to sit beside. And this should be some principle that we should keep always in mind when we are thinking about assessment. So by the completion of this lecture, we will be better able to explain assessment concepts, principles, and methods. And attached to this goal, the learning objectives would be to appraise the relevance of assessment in learning, list 3 methods of assessing learners, faculty, and program, describe how to use these assessment methods to enhance learning. So teaching is not learning. When we think that by explaining our best, something that we would like our group of learners to demonstrate as they have actually learned by the end of the interaction, we might sometimes find some surprises in what we thought it was taught and learned and wasn't exactly what we expected. So teaching is different from learning. And this is also something that we should keep in mind when we are educating, when we are acting as clinical educators. So when having this in mind, moving the focus of teaching to learning would be much better for us to be concerned about the needs of our learners and how they will best learn what we would like them to demonstrate as they have learned by the end of the learning experience. We also know that assessment is the engine which drives student learning. It's not by being anxious about being assessed. The idea is about confirming or infirming if we have actually learned what we need or not. So assessment, and beginning by self-assessment, is very important for ourselves as educators and also as learners to really know if we have learned what we need to apply in practice. So this presentation will be based on the 5 principles, based on the 10 principles of Williams of a good assessment. And this is the 5 principles is a modification by Professor Karl Golnik, which is also published at the publication that you can see at the bottom of this slide. And those are to test knowledge, to teach and test knowledge application rather than knowledge by itself alone, to be situation and case specific in our aims for assessment, to use multiple tools, times, and observers, to teach and assess at the same time, and also to give feedback, good feedback that should be also have a component of summative feedback, but also not forgot by no means the component of formative feedback. So for the first principle, test application of knowledge rather than assess the knowledge of simple facts, that usually in this pyramid, as we can see here, and was developed by Miller, it's the pyramid of competence development that we usually undergo when we are learning, and our learners as well, is so the first stage is about declarative knowledge. When we recall, remind what we have learned and can recite what we have learned. But then again, a little bit higher is to explain how this happens and might be related to procedural knowledge. If, for instance, we are thinking about procedural in terms of surgery or whatever examinations that we can and need to develop when we are practicing as ophthalmologists. But then again, how can we know that our learner knows what it's entailed, knows how it happens, but showing how it happens and how he or she will do within the learning environment? It's called competence, showing competence in showing how. And then this has to be translated into the clinical setting, into practice. And this is about performance in how learners, we and our learners are performing at our clinical settings. And for all these, and this is a further stage that has been proposed in 2016 by Cruz and Associates, which is connected with demonstrating consistently the attitudes, the values, the behaviors expected of one who has come to think, act, and feel like a physician. So this is kind of developing the professional identity that can also be at the top of this Miller pyramid of demonstrating learning development. The second principle is connected with being situation in case specificity. Not all of us have this facility, ability, natural ability to do everything. Some of us have more, are more capable, for instance, for surgery immediately, or for having for appointments to connect with the patients. And this is something that we have to keep in mind when we are assessing learners. So good performance in one situation doesn't mean that the person will be the same in all situations. So human performance is highly situation and case specific. And this is not to detect what is wrong, or it is to detect what is wrong, but it's to build upon that a plan to be better and develop the skills on something, some competency that is not fully developed and can be much developed and worked on to be better at. Use multiple tools, times, and observers. So we can go back to the pyramid that we have been that we have seen earlier, the pyramid of Miller. And for instance, for declarative knowledge, we can use multiple choice questions. But for instance, for procedural knowledge, multiple choice questions, perhaps it's not the best way, and a short answer question or an essay could be a preferred way. To show competence, for instance, so that we can know that a resident is able to do with self-confidence capsulorhexis, for instance. It's not enough to have a multiple choice question or to explain how it is done. It is important, those are earlier stages, but to show how it is done will be a much better way to show that this competence is really there. And we can use, as we have seen earlier, rubrics, so tools that can be very clear in terms of the expectations or is expected to be demonstrated by each level of performance for each task that is a component of, for instance, a cataract surgery, as we will see in a few slides. But then again, we have to translate this from the learning environment, the safe learning environment that we have created, into the practice setting. And this is about performance. This is about how the residents, about the learners are doing at their daily clinical job. And once again, as we have heard previously by Professor Paul is explaining about the OSEX and the importance how of these tools can have not only in assessment, but also in teaching, in sharing the expectations, what is expected to be demonstrated for each of the steps of a clinical examination, a cataract surgery, and also share what is expected to be found at each level of performance. So this is a much complex way and need to assess actual performance. And finally, the 360 degrees tool for assessing the toppest stage of the professional identity, which involves being assessed by all those around whom we worked with. For residents, the nurses, the faculty, peers, patients, etc. So this is a rubric and ties with why I was saying previously, so that we can be very specific and as much as clear as possible for each of the step of a more complex competency. In this case is about a cataract surgery, and also describe exactly or as close as possible in terms of clarity and objectivity for each level of performance. So when we do this and share previously at the offset of a rotation, for instance, with our residents, with our learners, this also is very clear about the expectations. And this is something that we can say that we are using as a learning tool, not only for assessment, but also to guide the learners and ourselves and make a trustful and supportive way, a learning environment for everyone to learn as best and develop as best their competencies. And these are called rubrics. We have the dimensions, the tasks that we have defined. In this case is about cataract surgery. So the steps of cataract surgery, and then the levels of performance at the top, and then the exact or as close as possible in terms of objectivity, the descriptors for every level of performance in each dimension, in each task, in each criterion, whatever the rubric is about. Our feedback is the oil which lubricates this engine that drives learning, this assessment. So feedback or formative feedback is very important. It's about teaching. So providing clear and good quality feedback will be of utmost importance for learners. So feedback should be based on multiple sources of the evidence, should be a process involving skillful interaction. We can develop our skills of providing feedback and adapt that feedback, personalize that feedback to the person, to the learner we are giving that feedback. It should be timely and it should be frequent. We should be close to our learners so that we can provide a tailored development plan according to their needs, because people are different, as we have seen before, and people can find more challenges in this or that aspect that is different from others. And if we can provide this tailored feedback, that will be very important for these learners to know and be appraised of what they have already developed, and they are fully self-confident in doing expertly. But for the other parts, the other portions of learning that they develop, we should need to know what their difficulties, their challenges, and provide them a focused plan so that they can develop and be more at ease with those competencies they are struggling a little bit with. So this feedback should be welcomed by the learner, and this is only possible if we can create this trustful and supportive relationship with the learners. Otherwise, we will not be able to know. And it's like teaching and in learning. We will not be able to exactly know what is that our learners will be accepting with our feedback, and how they will be accepting the plan that we should develop, both of us, the learner and the educator, and they will be putting into practice. So this is the relationship that is built between or among the educator and learners is very important, so that this feedback will be very accepted by learners, so he or she can or they can develop their competencies. So should be reciprocal. The educators should be also willing to receive feedback from their learners as well. So where is feedback in the assessment cycle? Feedback can be done before the learning experience, during the learning experience, and after the learning experience. So it can be diagnostic, formative, when it is done during the learning experience, that timely, frequent, contextualized, and personalized feedback that we developing a close relationship with our professional relationship with our learners. And this is feedback for learning, as opposed as feedback of learning that occurs after learning. And that will be for the summative feedback. It's important because it ensures that the learners have attained a certain level of competence and they are ready for the next stage. But to attain that phase, it is very important to have developed that formative feedback and give quality feedback, so that they can be the most successful at their summative feedback. So in conclusion, we have seen 5 principles of assessment: test knowledge, and not only the application of knowledge and not only knowledge. So the progression of that Miller's pyramid in terms of development clinical competence, as we've seen earlier, and the several and different tools that we should be using, and being aware of the situation and case specificity for each learner, because we are all different and learn in different ways and have different baggage of previous experience when we come together. So we have to be aware of that halo effect when something, for instance, for a resident or a learner shows an extraordinary mastery of something that we have proposed to be developed in terms of learning, and others don't. Probably the others will develop this and have other competencies that they will be master, but we should be very aware of this situation in case specificity. Use multiple tools, times, and observers in accordance with what we are assessing, as we have seen earlier. Teach and assess, use tools that can allow us to teach and assess simultaneously. So when we share tools like rubrics with the community of learners, within the community of learning, we can be very clear and about what is expected from them to demonstrate by the end of the learning assessment, and also guide us and the whole community in terms of providing feedback and developing personalized plans, constructive plans for the future for each learner, which is exactly the last assessment principle that we have here: provide quality feedback. So thank you so very much for your attention. I am very happy to receive any comments or questions that you might have. These are the main references of this presentation, or if you prefer, we can go right away for the second presentation, which ties with this one.
Dr. Helena, thank you so much for that first talk. And I think in the next 10 minutes, you will be talking us on tools for assessment. So we can straight away go with the second talk and we can finish in 10 minutes and then we can take the questions.
Okay, so let me just share again my screen so that I can, let me see, this one, I'm sorry. Let me see. Just.
And after that, we are going to have the next talk by Dr. Santosh Honavar on the interesting topic, why publish in IJO, an overview of OCAT. So what is OCAT? He'll be telling us in detail about it. So over to Dr. Helena, please.
Thank you so very much. Thank you so very much. I have also would like to say this. I'm Portuguese, and we have this very close fraternity with Go. So it's for me even a more special situation and honor to be collaborating and participating, contributing for this venture. So the second presentation is about tools of assessment, which kind of ties with the previous one. We have already spoken a little bit about some tools that we can use. And this is just to share this thought about what happens in terms of our confidence while learners is not exactly growing as our wisdom, our knowledge and experience in a specific competency. We can see that usually we can be very, and I still remember when I started operating cataracts, we come at a certain point that we feel that we, great feeling of accomplishment, and then the complications start, and then we just fall in the valley of despair. Wow, there's a little bit more or much more than I thought it was entailed for this, and then there's a slope of enlightenment growing a little bit more in tandem with the confidence and the wisdom till this plateau of sustainability. Why have I decided to start by this slide, which is called the Dunning-Kruger effect? Is that because sometimes we are not exactly, it's very good for us to develop reflection and self-assessment, but we should also we should also consult and have mentorship in terms of what we are doing to receive feedback and to give feedback to our learners as well in terms of their evolution as professionals. So the goal of this presentation is by the end of it, participants will be better able to summarize education tools that can make a learning moment out of an assessment and vice versa. And then again, a very emphasis on assessment as the engine for learning, and also to build this environment where there's clarity about what is expected for learners to demonstrate by the end of the learning experience, which is the rotation, the residency, the fellowship duration. But it is very important for them to know exactly, clearly, what is expected them to demonstrate by the end of that experience, and also for the mentors to guide as best as possible, as clear as possible, their mentees to achieve the best success. So the objectives that come associated to explain the tools, dual purpose, teaching and assessing. Assessing is very, very connected with teaching and learning, present examples, and elaborate how these tools can be most effective. So in terms of explaining the tools dual purpose, the tools that teach and assess, that are enabled for learners to learn as best as all educators good educators would like them to learn usually are based on a stage-wise models of skills as acquisition, as we have seen earlier, the Miller's pyramid assessment of competence as a clinical competence. So it's a stage demonstration of skills till the top of it, which is the professional identity development, and also in tandem with this stage, the tools for assessment, for teaching, for learning and assessment should also come in tandem, and these tools should be valid and reliable. So these are, I'm going to show you, for instance, the models of skills acquisition for the Japanese martial art models, the beginner, the journeyman, and the master. And as we have seen earlier, and Professor Pallis has shown, the Dreyfus model is based on 5 levels of performance, starting by the novice, advanced beginner, competent, proficient, and expert, going from the one who is learning the rules, considers everything, knows not, doesn't know exactly what he or she doesn't know because it's at just starting, to the toppest at using intuition, combined with the rules that are the main layer of learning, focus on prioritizing the focus, relevant focus, and also develop abilities of reflection. So, and these tools should also be valid. They should be, they should measure the degree to which an instrument assesses what is intended to be measured. This is the validity of the tool, and Professor Pallis has provided an example of that. I'm sorry, I would like to go backwards, but I am not seeing how I can do that, so I'll stop here. And also they should be reliable. They should be valid. They should be assessing what is intended to be assessed, and should be reliable. So they should be consistent in terms of the responses each participant will give us in various times of their participation, and also have a consistent inter-rater validity, so should be reliable, as Professor Pallis has presented earlier. The examples that I am going to show, and there are various examples that we could use, but for the sake of time, we don't have those, are logs and portfolios, checklists and rubrics, and the video and direct observation of procedural skills, which are so very important for ourselves when we wish so much to teach our best and our learners to learn our best ophthalmic surgery with the patient safety ascertained, and also with quality improvement in our healthcare systems. So this is a log. The log is kind of a grid, and this is a surgical log where we can document pre-op visual acuity of the patients, the surgical procedure, the IOL that was implanted, and the surgical complications that we have encountered. And this should be something that residents usually do, because they have to present their numbers and also elaborate on their curriculum at their final examinations to be an ophthalmologist. But we can also speak about portfolios, and portfolios are a little bit different from the curriculum vitae, which is based on the summary of qualifications and personal details. And the portfolio is a little bit something that is not the curriculum vitae and not the log, because it includes professional reflections. It should be kind of a journal, a journey, a journaling activity of the owner of the portfolio that should reflect the needs, the learning needs. It's the personal and the guided, because ideally the portfolio should be accessed and should be followed up by the mentor of the person who is the owner of the portfolio, reflecting the competencies required for practicing. And sometimes throughout our professional lives, these competencies can vary a little bit in accordance to our practice, to the place where we practice, to the patients that we assist, the plans that we take or our learners take, the activities that can improve their competencies and should be documented there, and finally their achievements. So a portfolio is something, it's a documentation of the reflection. It's kind of writing the reflection of the professional as the person as a professional, and should start very early as the residents. What will I learn in accordance to the needs that I have found in the clinical practice, or in terms of what is expected for me to present after my learning experience, in terms of what my educator and my faculty is presenting me as the residency curriculum. How will I learn? What activities should I do? In my specific case, what should I be developing more? The challenges, the struggles that I have, and I will discuss with my mentor, and also how well have I learned? So what should I improve more? How well am I in other aspects? This is a sample of a learning portfolio of ophthalmology following the ACGME competencies for residency. For instance, for patient care, the documentation of cases and procedures, also the numbers and comments on areas of strength, but also of concern, the surgical competence in medical knowledge, the conferences, courses, meetings attended. Probably this is the very strong component, for instance, for a law that is not for only for surgery. For practice-based learning and improvement, the publications, the case presentations, the research projects that I have been as a learner involved with, the interpersonal and communication skills, a summary of 360 evaluations, the professionalism. That, for instance, the projects that I have been involved, or my learners have been involved in terms of service community, medical education memberships and activities, and finally the systems-based practice for participation, for instance, on a hospital committee. So the success for portfolios, and portfolios can be very successful, but these authors have found that there should be an appropriate structure, follow an adequate assessment procedure, and also count on the adequate coaching and assessment faculty in terms of motivation and also numbers, and also provide new experiences so that all mentors and mentees can benefit from the use of portfolios, ultimately to provide better health care. This is an example that is free from the British Medical Journal. It's British Medical Journal portfolio. Anyone can use this. It's just for an example. Checklists and rubrics, we have seen them before. Rubrics are much more than a checklist, because it's not just ticking boxes, but also being very clear about the levels of performance in terms of the tasks that are defined for instance, a more complicated task, with breaking that competence in several phases, in several tasks, and then the descriptors for each behavior that should be demonstrated in accordance to levels of performance, and visual, direct and observation, but also sometimes, and especially, for instance, we can use the video submission for every at every space. It depends on the culture, but also sometimes could be the only way of utilizing this tool of assessment for remote regions. Here again, we have the pyramids, the Miller's pyramid of assessment, and the several stages. And let me show you how the direct and the video observation of procedural skills, and we immediately link this with for instance, cataract surgery or any ophthalmic surgery, but also we can use it for clinical examination, as we have seen before. We can do it directly with our observing directly, but we can also rate videos by being recorded in advance, and we will be at the top of this pyramid. So we will be either this observation, direct observation, can be directly done or by a video submission at the clinical environment, and we should be at the show how, and also can use it at the clinical practice, and we will have been translating this learning into the practice setting and should be assessing performance and should be at the does. Assessment should be formative, as we have seen before, to design deliberate practice and individual and contextualized plans for the future to appraise what is already being done very well, but also to develop other areas of concern that might be benefit from some development, and to ensure that the learner has attained an adequate level of competence. And this is, and I'm just finishing, this is almost the last slide, is to build this coaching culture, this mentoring culture. Coaching is very focused in terms of what we attain in terms of providing mentorship to our learners to use these direct video observational procedural skills that are so clear, using rubrics, using portfolio, so inaccurate reflection in this supporting environment, and nurture documentation, so using the portfolio, and also stress development over judgments, creating and building these relationships. And what we have seen is that we can use these tools in multiple ways, either a self-assessment, with our mentors, with peers for formative assessment and summative assessment as well. Thank you so very much for this opportunity. I am sending you a warm hug to everyone in Goa from Brussels, where I am right now. And these could be some lines for reflection after this presentation, is what you think if you are already probably using these tools, barriers that you can find and or foresee using them, and solutions that might be useful in applying them as effectively as we can. Thank you so very much again, and a warm embrace from Europe to you. Thank you.
Thank you, Dr. Elena. It was really a wonderful presentation. And I am sure listening to your talks, majority of us will start using those assessment tools. Is anybody using any assessment tools as she was quoting? Any experience? Dr. Shankar Gowda, yes, sir. Mike. I'm using it since 2012. Basically, it gives a feedback to the student, and student will also start self-learning. They come back to me and, sir, this time I was good at this. This is where I face problem. Each step you can monitor in that. So next time when they come prepared for that step, and even the consultant will be told to observe that step. What is the name of the assessment tool? That's Oscar, Tim. That's Oscar assessment tool. Okay. Any other assessment tools? Anybody has any experience with that?
We started trying it for undergraduates who came to us for elective. So we did the reflection part for them. And the electives are now so popular that I'm sure now the next set of students will choose more of ophthalmology than the other subjects. But their reflections were so nice that it was very encouraging for us. So the reflection tool, and for undergraduates, we found that we can use it now for postgraduates perhaps.
Yeah, Madam wanted to tell one point.
We have used mini CX, that is mini clinical evaluation exercise. And we have in fact submitted the article to DY Patil Journal, and it is accepted also. And I have presented this also in state level conferences.
Yeah, mini CX is one of the very popular assessment tools, which even I showed in my presentation.
Yes.
And even the UC Davis excerpts, they are also pretty much, there are a lot of tools available actually for assessment. And it's a good thing, madam. Yeah. Thank you. Any other point you wanted to make, madam?
I wanted to say that in this immediate feedback is given, and the time of assessment is 10 to 12 minutes, and 3 to 5 minutes is feedback. So immediate feedback is given, and it is a structured assessment.
Great. Yeah. Last comment from Dr. Shah.
I just wanted to say that we are having this e-portfolio system for our postgraduates. So after every teaching program, be it case presentation or seminar, they have to immediately write their reflections and we get back to them. So we have a ready portfolio for them for the current exam going PGs.
So after every lecture and this thing, they have to submit it, is it?
We have that. After every surgical procedure they do, after every seminar they present, after every case presentation, we have this exercise and we have a very nicely structured e-portfolio for them.
Fantastic. Madam, next panelist. Yeah, yes, sir.
Which of these tools would we like to use for assessing the problem solving ability of the candidates?
Dr. Helena, there is a question for you. Which of these tools is for the problem solving ability for the students?
Well, thank you so very much for the question. I think that you can hear me, right? I think so. So that would take us to the Miller's pyramid of clinical development. So for problem solving, you should probably use a rubric. You could use, for instance, direct observation. If you have the resident or the learner performing some action that you would like to assess, but you can also, I'm just thinking, for instance, you can also develop a scenario, kind of a vignette, and then if you would like, in terms of solving a problem, you can include the problem in the vignette, so a clinical case scenario, and if it is well built, you can ask the learner to solve that problem. You create the case, you give the tools for the learner to solve the case, and you can do that only by writing, especially if this is something that is more linked with the knowledge phase, with the cognitive phase, with the thinking phase. But supposedly, you would like, for instance, for the learner to demonstrate that he or she could solve a problem about, for instance, a capsorhexis that is escaping.
Okay.
You can do that again, but you would like to see them do that. And then you can ask him or her a video submission or observe and then provide feedback right away, for instance. So,
thank you. Thank you so much, Dr. Elena. Thank you once again. So now we move on to our next talk.
I take this opportunity to invite panelists to take their place. Dr. Ramesh Babu, Dr. Sunil, Dr. Vinay, Dr. Radhakrishnan, Dr. Anita, and Dr. Sheetal to come and take their place on the chairperson's table. And we shall now, without delay, go on to a very interesting talk by Dr. Santosh Hunawar, who is going to be telling us why publish in IGO.
And also a bit on Indian assessment. Yeah. Good afternoon. Research is always, the aim of research is to produce usable knowledge. If the knowledge that you produce is not used, then that research, at least for the purpose of utility, is redundant. Mismatch is good in fashion, but for publications, it is all that matters is finding the right match. If you don't find the right match, then the entire effort that you have put in your research and publication may go waste. You will never be barking up the wrong tree. Now, why IGO? There are many journals. You're spoiled for a choice. Why should Indian authors consider Indian Journal of Ophthalmology? Not because I'm the editor that I'm pushing it, but why we should consider our own national journals as a good choice before we think of international journals or low-ranked journals internationally. IGO is a reputed national journal. It is the official journal of All India Ophthalmological Society. Whenever a journal is an official journal of a professional organization, that means that it has credibility. About 25,000 AIOS members access it. That is just the AIOS members. But the hit per month is per year is 500,000. 500,000 means every 5 seconds somebody is accessing IGO from anywhere else in the world because it's free to access. There's no charge at all. That means it is an open access journal. You can download any article from IGO without any charge, right from 1956. That was the first issue that has been put to the last issue. Every issue is available online. High citation if the manuscript is good. Because it is open access, people get access to it. It is on PubMed. So citation is not a limitation. And your peer group reads it. People who you want it to read it. Residents also read it. These are some of the editors of Indian Journal of Ophthalmology. You can see that almost all of them are very eminent and academically very accomplished. From the time that I took over, we started making the cover page a little more interesting, because based on the cover, people may get interest in opening, and each issue should look different. Otherwise, you may get confused as to which one is new issue, which one is old issue. You have the same blue color. So each issue represents a theme, and the picture on the top is based on an article that is published in the same issue. So each issue will have a very interesting cover page. From some point on, this is actually Dr. Bruce Pivey, who you heard yesterday. He started featuring living legends in ophthalmology based on suggestions by the editorial board. Then we went on to even publish Dr. Harry as one of the living legends in ophthalmology. That's Dr. Jerry and Carol Sheets. These are some of the issues of IGO, each of which has a cover page which is unique. That Dr. Narsingha Rao, Dr. Palikaris. Some of the interesting issues were COVID issue. This particular issue published all the guidelines for ophthalmology practice during COVID times. And this was the very much cited diabetic retinopathy issue, which was the largest issue. And Indian living legends, Dr. Nagpal, SSB, G. Venkateswamy, etc. Now we have published articles on living legends and also tales of yore on people who are no longer with us but have accomplished a lot, like Professor L.P. Agarwal, I.S. Jain, and Women in Ophthalmology publishes or celebrates women who have accomplished a lot in ophthalmology and are probably forgotten. Dr. Kalavar was a pioneer in corneal surgery, keratoplasty in India, and she's forgotten. She's still living and she's very alert, but we need to celebrate such individuals. In fact, maximum number of COVID-related articles were published in IGO, and we received a lot of citations. This particular article was kind of set up in 2 weeks' time because the government of India requested data on mucormycosis, which was not available at that time. This came as a sudden surprise to us that patients with COVID-19 were developing mucormycosis. They wanted data. So all that we did was an online study where 2,826 from 100-odd centers were accumulated. Within 2 weeks' time, this data was analyzed and was put up as a publication. This was commended as one of the best studies of the year by American Academy of Ophthalmology. This was done in 2 weeks' time. So the power of internet and power of online resources is so good that you can collect thousands of patients in 2 weeks and publish it as well. This is the new website of IGO. This is now managed by Lippincott, and we have an app as well. This is the iOS app, and we have an Android app that is releasing sometime tomorrow. That's the IGO Case Reports website. Case Reports is a new, relatively new journal, and we are also on social media as is relevant, Instagram and Twitter, etc. That's the new submission portal for IGO. This is contemporary. This is an international submission portal. Earlier, we had our homegrown submission portal. This has all this kind of an information. There's the dashboard that we get on the submission portal, which is very easy for the author, reviewer, and also for the editors. So what has happened in the last 6 years is that this was a number of submissions from India, 575 in 2016. Now we have reached 2,785 in 2021. It's grown to about 3,000 last year, 2022. So which means that we have about 500% increase in the number of submissions from Indian authors, which is a very good sign because it means that they're trusting their own journal. That does not mean that international submissions have come down. We have an increased overall submissions from 1,000 odd to 3,823 in 2020. That's increased to about 4,000 now. About 400% jump in the number of overall submissions, and consequently increased number of publications as well because the number of submissions has increased. This is the number of submissions, and this is the number of publications over the years. You can see that the curve is rising, And this includes IGO case reports as well, which has a large number of submissions and large number of publications. So despite all the work that has increased because of the number of submissions, we have reduced the time to decision to 44 days from 58 that was earlier. And days to acceptance has been drastically reduced from 202 to about 2 months, which is actually good because the authors want their articles published, reviewed, and published rapidly. Increased reader interest, 500,000 hits a month, one in every 5 seconds. Consequently, citations have increased. This was last year. Now we have gone past 7,800 this year. That kind of citations would bring about a change in impact factor, definitely. Despite the number of increase in publications, you can see citations have really taken off from about 1,200 to 1,400 to about 7,800, which is a very healthy trend for any journal. And mirroring the citations, number of citations is the impact factor, which has risen to 2.969 from 0.835 when I started. And site score, which is by Elsevier, was 3.1 last month. Now it is 3.3. This actually mirrors the impact factor. So this year we expect a jump in impact factor to more than 3 from 2.969. So now what has that done to India as a country in terms of number of ophthalmology publications, cited ophthalmology publications? We were number 6, which was not bad at all. We were behind all developed countries, US, China, UK, Japan, and Germany. We were in a comfortable number 6 position with about 800 publications in 2016. But now we have gone past UK, Germany, and Japan. We are number 3, very close to China, which is easily beatable. But US is something that is difficult to beat. There are already 5,000 odd publications. So possibly we should be looking at getting to at least number 2 position in the next 2 or 3 years. And most of these have been contributed to by submissions in IGO. So number of submissions and publications have increased in IGO. That has pushed the country rank quite high to number 3. New initiatives have been IGO case reports. There's a good medium for a resident or a fellow or a new author to write. Otherwise, they would be hesitant in writing a large original article or a review article initially. This will give them a window of opportunity to get into the habit of publishing. It is not yet indexed. It's on a path of indexation. We have applied for indexation, but that takes about 18 to 24 months more, but then it is retroactive. So whatever that's already published will also be indexed. These are some of the covered pages of IGO case reports. What is interesting is that in the first year of publication, IGO case reports has authors from 24 countries. All these are peer-reviewed publications, so these are competitive, but then we have large number of authorship from different parts of the world. This is the latest edition, IGO videos. For a practitioner or a busy teacher who may not be able to write an article, do research and write an article, they can simply edit their surgical video or an instructional video or a teaching video to 8 minutes, give sound to it and submit it. The interesting part is that PubMed accepted to index it from the first issue onwards. So this comes as an abstract in PubMed with all this information. And then there is a video link that takes you to a YouTube channel which has the complete video. So it is PubMed indexed, it is searchable, it is citable. So your videos can now be cited. This has not happened in any other field of medicine except ophthalmology. Now about OCAT. This is the new initiative that I propose to AIOS. OCAT is Ophthalmology Knowledge Assessment Test. So this basically follows the question that can we have an India-centric online resident evaluation program for ophthalmology? Now, ICO exam has 3 components. Basic has 3 components: visual sciences, optics, refraction and instruments, and clinical ophthalmology, which is good. And then advanced component. Fees total to, at least for Indians, it's about 200,000, 2 lakh rupees. It depends on the country that you reside in. Higher the income level of the country, higher is the fee. So in India, it's about 2 lakh rupees or more, around that. But if you can't clear the exam, then you pay the same amount again. So there are multiple attempts. It's not that every student passes this exam, and the cumulative expense is about 4 lakh rupees for an average student, which is very expensive. What does that give you? This gives you a certification, fellow of ICO, and it also allows you to apply for fellowships, which you can apply even otherwise. It will also give you a kind of waiver for FRCS Part 1 and FRC Ophthalmology Part 1. So you can directly take Part 2 or Step 2 with this exam. Now, if you have an Indian OCAT, which can be Year 1 Basic Medical Sciences, like anatomy, physiology, microbiology, pathology, and pharmacology. Year 2, optics, refraction, and instruments. Year 3, clinical ophthalmology, which will give you a raw score and a composite percentile that's called the OCAT score, even if it is conducted on the same platform, Prometrics, which is used for GRE, TOEFL, and linguistic test, then the cost is less than 3,000 rupees. So you can save a lot of money by having an Indian assessment test ourselves. It's not a big deal to have a test, but we have to validate it, have kind of question bank, which is very uniform, reproducible, and all that has to be done. Background work is there, but it is definitely doable, and the cost is beneficial. Now, what it can do to us is that it can replace fellowship exams. Each institute conducts its own fellowship exam, and students are actually, in a situation where they have to go from city to city and give these exams, because most of these exams are not online. From Hyderabad, they travel to Madurai, Coimbatore, Chennai, and then give Bangalore, and they give these exams. It makes it demanding for them. But if all these fellowship courses have one single parameter with which they can call these students for interviews, then that will be good. So we can actually talk to each of these institutes and replace their individual fellowship exams with a standard measure for interviews. And collaboration with FRC-OFF and FRCS as entry exams is not difficult. We simply needs to give them a standardized protocol, and they would possibly be happy to accept it as an entry-level exam for FRCS and FRC ophthalmology. Certification from Ophthalmology Foundation can be requested, just like ICU. And we can have OCAT advanced after third year of residency. That could give the FACO, which is already being given. FACO is part of the AIOS already. Then OCAT subspecialty, for example, cornea, retina, etc., after their fellowship or senior residency, with an offline clinical exam can give them FACO subspecialty, which has already been given. So it's like a backward integration of FACO that we already have to have residency evaluation as part of the entire system. We have some components of it already. We need to develop some more components to kind of complete the circle. That is actually the proposal. If you have any feedback on this, please give it right now or later whenever you have time, and then we will take it to AIOS next. Thank you.
Thank you, sir. I think you have done a phenomenal work in IGO, and you have taken it to very great standards, and we all are very proud of you. And hopefully the IGO grows more and more in the coming years in future. So,
unlike ICO, this should also get an international standing, no? Like that, unless that comes, all these highly qualified fellows of ours, when they want to join abroad, they have
ICO does not give a qualification. It's just a certification, right?
That is sort
not recognized anywhere for job purposes. This is just a certification.
If I could make a quick comment as someone who has taken the OCAP a few times during the residency days, just to say that it is a remarkable idea. It's a great idea, and but it is going to require tremendous amount of work.
That's right.
Because and it's going to give every resident a percentile score as to where they stand in comparison with their peers. So I think it's a great idea. But if I remember, the feedback that we used to get after the OCAP was so detailed.
Right.
Every component that we didn't get the right answer as to why and how we need to rectify that.
Right.
So I'm just trying to say that it's going to be a lot of work, but definitely worth it.
Right. So the feedback currently is given by an AI tool.
That's right. It's an AI tool.
Yeah. So this is built into the system. Whenever they get a wrong answer, the score is given immediately. The moment they complete their 180 questions or 200 questions, within 30 seconds, they get the raw score. It takes about 5 days for them to get the percentile score, and about 30 days for them to, at least the current system, get the analysis. Analysis would mean that each question that they have answered, whatever they have answered correct is fine. Whatever that they have answered wrong, there is a background analysis by an AI tool which will tell them, this is what you should have written for this reason. So there is some theory background that is given to it, and then they get back by email. So you can actually go back to those questions and study more about it if they haven't done well in the first attempt. They can take multiple attempts and better the score each time.
thank you, sir. Thank you so much for that wonderful talk.
We go on to our next speaker. Can we have an Indian version? No, it's all about mentoring. On to you, Dr. Rolika Bansal. Yeah.
Finished her fellowship and now she's joined as a consultant at CFS Hyderabad. And then now I think she's.
Yeah, I'm not a consultant. You'll see my designation soon. So, I will be talking about, I can't see my screen. Yeah, thank you. So I will be talking upon the topic that is, it's all about mentoring, and my designation is here, and that is Forever Fellow. And the disclaimer is that I'm speaking in front of the wrong audience, because usually this topic I would dedicate to the mentees and not the mentors, because all of you right here, you already know everything about mentoring. So this is definitely my wrong audience. And I have absolutely no interest, but I wish I did. And so give point to another thought. So this is a survey that we have conducted at iFocus 2023. It was a very quick WhatsApp survey that I conducted, and would you like to pursue fellowship after postgrad? And you can say there was 100% yes for the same. And another question that I popped up was, who do you think makes the choice for selection for fellowship, a mentor or a mentee? Now there was a confusion, and that was 71% nearly said mentee, and 20% nearly said mentor. So I focus also, multiple students came across to me with multiple questions, and that is, when you apply for a fellowship, and which institute should they apply to, and which specialty should they take up, and which city should they go to? So these were the 4 questions that they had in mind. But nobody really asked me the main question, that is, which mentor should you go to? Which, according to me, is a very important question that should be asked. And if I were to ask all of you this question, who do you think makes the choice, the mentor or the mentee? All of you, anybody would like to answer that? While selecting a fellowship, right, in your fellowship, who do you think makes the choice, the mentor or the mentee? Well, the answer is the mentor. But who do you think is the first choice? The first choice is by the mentee. So the mentee should be smart enough to make sure that the mentee recognizes their own skills and potential, and where are they going forward to. So when I was asked that how do you choose the right mentor-mentee combination, I told them that attend conferences, webinars, you will be able to recognize the people who inspire you. Be active, overcome the inertia, go ahead, ask the questions, and I hope the people are asking you all several questions. Check out the surgical videos. Most of you happen to put up your surgical videos online, and the webinars and the surgeonars, they're quite innovative way of putting the information across to the future mentees. So by looking at the surgical videos itself, you can recognize, is this my potential? Is this the teacher that I would like to go to? And discuss with your professors. So my professors at my institute were also quite helpful. They guided me in how to go forward and who all I can approach, and express your interest to your mentor or the future mentor that you would like to go to. So in my first year of postgrad, somehow I was very clear in my head that I wanted to take up ocular oncology and oculoplasty. From day one, I decided that this is exactly what I want to go to. So then I went through all the mentors that are there available for the fellowships in ocular oncology and oculoplasty. And I squared down to Dr. Santosh Manawar. That was what was on my mind. And I went to him at IPEP, sorry, eye to eye in Whitley. And I went to sir and I asked that I would like to apply to the fellowship at your institute. He said, you right now in second year, you need to wait right now till your final exams. And he said that the year that you are applying to in your final exams, email me the December of that year. And I made sure that I do that. And I sat down on the 1st of December because I was asked for December. And this is exactly what popped up in my inbox. And there was an article by my mentor, which was written on mentoring as a serious business. Maybe this was a coincidence, and a glad coincidence, because I read across and I was like, exactly this is what I'm looking for. So it may be destiny. And my mentor had quoted that mentor stands for the one who motivates you, empowers and encourages you,
nurtures self-confidence, teaches by example, offers wise counsel, and raises the performance bar. I agree, but I have an answer for him as a mentee, and that is mentee is the one who learns to master the art that is taught by the mentor, the one who embraces the efforts and faith. It takes a lot of effort to train a mentee. It is not at all easy. You have to recognize your mentee, you have to recognize your mentee's potential, and it's really not an easy job. I'm sure mine absolutely has a tough time with me. And never fail to observe each and every single thing, even if it's an opening, even if it's in the OT. Make sure that you observe all the how the hand moves in the in surgery, and how the patient is counseled in OPD, each and everything. And be thankful and loyal. It's a thing that usually people end up forgetting, but it's very important thing on the mentee's behalf. To learn and evolve each and every day is important, and efficiency is always rewarded. Even if you don't know it, you are being rewarded. And things to remember about your mentor. I think many of you might agree with this, that it is important for your mentees to know these pointers, that you have chosen them for a reason. You want every single day to make sure that they maintain their focus. It takes a lot of effort on your part to maintain that. And you polish them effortlessly. And you teach and train them selflessly. And you are afraid of them not recognizing their potential. And you always land up trying to bring out the best in them, and you expect them to always excel. And these are things which mentees often forget. And things to remember as a mentee is that you have to trust your mentor's instincts and be loyal. I sometimes don't even understand why am I told a particular thing to do, but I just do it blind, with a blind faith that it's for a reason. I observe carefully that be dedicated and disciplined, never get discouraged, compete with only yourself. I do not recall competing with any single person, neither my senior nor my juniors. It's about me and only me every day. Okay, today if I've done this much, next day what am I supposed to do? If I'm making this presentation, is it better than my previous presentation or not? What were my shortcomings? Don't judge your mentor, it's not your place. Your mentor is a person because of their own journey, how they have met their mentors, it's their life. And you cannot be the judge of how your mentor is. Be creative and speak up and remember the lessons always and be generous to pass them on. And this is a difficult task because the mentee will also land up becoming a mentor someday. So, the mentor's contribution, the mentee can actually double up their own contributions. And the 5 important roles that a mentor plays for a successful mentor-mentee relation is make time and listen to them. As a mentee, I'm telling you that it's important that my mentor understands exactly what I'm thinking, exactly what I need. Sometimes I know that my mentor doesn't communicate with me much, but he understands each and everything that's on our mind. Like even when we go to the OPD and we have certain questions in our minds, he lands at clarifying each and everything there and then while talking to the patient. Have regular meetings, talk to them, assess their progress, promote the mentee, and celebrate the mentee's success. And you must remember your mentor's pattern, their comfort zone, their work. This is their work. These are their patients, not your own. Mentor's staff, rules, principles, and skills must not be forgotten and must be embraced. And this is a small thing to make it a little funny and entertaining, and that is a mentee should also understand and recognize the phases of a mentor. Okay, so every day, your mentor is not going to be in the same mood. Every day, something must have gone off, and every day, something must be very much right. Okay, I would like to call it the phases of a mentor. The moment I look at my mentor, I know something is either good or something is either bad, and I know exactly which place I have to put myself in. So this is the phase that my mentor has when he's trying to hone my skills. This is the phase when he knows that now she's about to make a mistake and I really need to teach her. And this is when he knows that I'm about to make a mistake. It's gone. It's about just slipping away. And this is when it's done. So this is when he knows that now you've made a mistake. I told you so. This is the phase of I told you so. And this is the way that comes after that. Like, I hope all of you mean what it means. And of course, the 5 follows. and the argument follows and the scolding follows. And I think that all of you have these faces, and I'm sure that your mentees also recognize them. And this is when your mentor is in inner peace mode. I feel they have not been able to give him inner peace in any time. I think I disturbed my mentor the most in this phase when he's trying to focus and I go up with the question which makes no sense. And this is the phase which I haven't seen till date, and I don't think I will be able to. And that is, this is the phase that they have, and they're really proud of you. But I have seen that face on his face for the other mentees that have been there in the past. I've heard the stories of how proud he is of his mentees, and this is the inner peace that he actually gets when they succeed in life. So the celebration of your mentee's success is what I have seen when he celebrates other people's success. So the extended world of mentors has been wonderful for me. So it's not just about your own mentor. You land up adding new mentors each and every day along with your original mentor. And that is how life goes on. And be thankful to your core mentees. They have taught you a lot. I had the luck to be associated with 7 of them, seniors and juniors, as I'm the forever fellow. And I don't know how, but he trusted me with putting me in the phase of trying to mentor 2 of them. And I'm actually quite proud of them, and they have come far. So this is the phase that I think that this is a team. It's a teamwork. The mentor-mentee relationship is absolutely a contribution of each and every person. And now I would like you to close your eyes and think about the 4 or 5 people that cross your mind that you can relate to the story, and you can be sure of that they as mentees would speak the same way for you. And that means that you have found the right flavor of M&M. That is the mentor and mentee relationship. So you all are already doing a great job because you all know the role of it's all about mentoring and nobody to tell you anything. Thank you so much.
This is the new generation. So, we need to understand and accept their thought processes and then, get better of what we already are. So that was quite a learning. It was a wonderful talk. So much of thought process, so much of care not to tread on anyone's toes, and at the same time not glorifying anybody. That was a wonderful talk.
Thank you.
God bless you.
Sorry. I told you I will never see that face.
Thank you, Rolika. That was a wonderful presentation. And as I said, that each and everyone of us should have a role model. A role model. Part is the mentoring, and the other part is the shadowing and picking you up, motivating, and many other things. I think is done by the mentor. And you, as a mentee, did a wonderful job. All the best. Any questions from the panelists, expert panel who are sitting here, Dr. Anita Maya, Dr. Ramesh, and Dr. Sheetal? Please feel free to ask. Or else we'll go ahead with the next talk, and then we can have.
Take the questions in the end about the Santosh hour onwards on those talks. We go on to our next speaker, Dr. Arvind who's going to talk about how to set up a new ophthalmology department. A to Z, and I'm sure he's the best person to tell us on that.
So he's the chief of AIMS BB Nagar, a very prolific surgeon and excellent teacher. And he always has the habit of winning many, many awards. And I think he has recently won the Star of, what's that award? The recent award.
Ophthalmic Star Award.
Yeah, Ophthalmic Star Award. So we are really proud of you, Dr. Arvind, and keep doing the good work. So I now request him to please speak on how to set up a new ophthalmology department from A to Z. And next, I request Dr. Alok Sen, sir, to please be ready with his presentation, and he'll be speaking on how to provide optimal training in the setting of the high volume surgeries. And after that, we are going to have a last session with a brief panel discussion, and then we all go for the beach. Till then, can we ask Dr. Alok sir to please carry on with his presentation?
Since it's taking time, Dr. Rolika, you showed us Master Shifu's face when he was a mentor. You didn't show your face when you were made to be a mentor. What were your faces when you were made to be a mentor for two of your?
And that has been a phase for the past 4-5 months only, but I've actually been able to, what I feel is that we'll end up reflecting our own mentor as well. So I think that plus some of my traits, I think they will be able to tell you better. So, but I'm proud of them.
If it's not getting connected, Rakesh, can we have Dr. Alok sir's presentation? It's there?
Yeah, it's there.
Oh. Can you please switch on to his slides? So I think you can start, sir. The slides will come on.
Yeah. So good afternoon, everyone. And thank you, Munawar sir, my very dear friend, Srinivas Joshi and Kudlu boss for giving me the opportunity. So I will be speaking on how to set up a new ophthalmology department, which I have done so many times at different institutes. I will try to sum up within 10 minutes. So I would like to start with a quote that vision without action is merely a dream, and action without vision just passes the time, and vision with action can change the whole world. So we need to have a clear vision after completing our MS or MD and after DNB or our fellowship, that whether we need to join an academic institution, and there are many center of excellence with national importance are coming up, 24 of them, and whether to join a state or private medical colleges, or to be a part of the big corporate hospitals or charity hospitals, or we want to get into some group practice or a solo surgeon practice. Then funding is the main thing. So best to keep a CA from the beginning for the financial planning. That is a very must, and exploring of funding options and partnering with potential like-minded ophthalmologists, because group practice is on the verge of the apical form of practice in the present scenario, and explore the city and the paying capacity in the market, and the keep break-even point in our mind always, because that is very important. And the government institute budget is sanctioned on yearly basis. So we need to push our director, the financial advisor, because they will always ask for the economical or the cost-effective instrument. But we need to push them. We need to push them hard that we need the best equipment to teach so that the PGs and the residents, they can learn the best, and the best outcomes are from the best equipment. And how to begin? With a bang, if ample funding is available. So all the latest and the advanced equipments and the super specialist team to garner a great publicity and footfall from the day of inception itself. And low risk model, start with a basic setup and scale up as finances becomes ample and flowing regularly. The biggest chain in India is ASG, and they started with a single hospital at Jodhpur. And the good training and surgical skills are a must, and never ever to compromise on the surgical outcomes and patient safety at any cost, like the sharing of OT with other departments, or if there is a CFU count is more in your OT, so we need to postpone the cases. Location, it should be well connected by public transport and approachable, ample visibility, not too overcrowded, sufficient parking area needs to be there, and friendly neighborhood area is an important factor. And well planned OT with a space for the future expansion. And the success depends on a great team. So initial phase, multitasker are needed, and they need to be well trained, which can hop up between the OPD work, OT, reception, and counseling of the patients. And not to do everything, but the consultant needs to supervise everything.
and built a team for a system that works in a systematic, organized, and a professional way. What does the system means from the word good? So we need to be proactive and modern from the word good, because later on resistance will be there in the staff. This was not there previously. Why you are saying now this needs to be incorporated in the system? So it needs to be initiated from the word good. And the cash flow system needs to be strict and very stringent. And computerized paperless EMR system with trained staff, it is beneficial in long run. And minor cases before starting major and complicated intraocular surgeries, fixing of responsibilities of each and every staff, and record and documentation of patients as well as of the academic work of the staff like their leave. And proper licensing and approval, because ignorance of law is no defense at all. Fire department, pollution control, human organ transplant act. So these licensing is a must, and the consultant needs to know the law like the labor law, registration, biomedical waste management, and the Consumer Protection Act, because litigation is a big issue right now. And most important, networking and marketing. It is a necessity in the private corporate world as well as for the government institutes, but the methods can vary. The government institutes, we can do good cases, very complicated cases, and it can be given to the newspapers for the publication. So the people know that this subspecialty is also there in this government institute. For the private sectors, they can use the media and the radio, the FM. So there can be interview regarding the different diseases. And web-based uploading of facilities available, and using the different applications at the digital media. And if you want to grow fast, networking is the only solution. We did surgery of a Pradhan at Tapale district, very near to Jodhpur, and we ended up doing more than 100 surgeries of that village people. So this happens, and in a very big joint family, we operated 70 cases. Mouth publicity, there are more than 150 methods of advertisement in this modern era. But mouth publicity is 200 times stronger than any mode of publicity or advertisement. And we can do awareness rally and activities in association with the NGOs and symbiotic relationship with the fellow ophthalmologists. If you are running a glaucoma center, then you can send the retina patient to your fellow colleague and he can send you the glaucoma patient. There are challenges to overcome, definitely, and getting the team out of the comfort zone. At the government institute, the nursing staff, the optometrist, and the faculty, they say this is not my work. This needs to be done by someone inferior to their post, but in a teamwork, they need to get out of their comfort zone to progress and understand the value of sense of urgency, because in the new setup, we need to work with a sense of energy so that we can grow faster and rapidly. We need to behave like a leader and not a boss. We need to lead from the front and do all the work and show them this is how it needs to be done. And development of the subspecialty services. So if we don't have faculty, so what you can do is weekly basis or monthly basis, the subspecialty consultant can come to your center and treat those patients. Or at government institute, we can depute the senior residents having fellowship in different subspecialty like the glaucoma or the VR or oculoplasty. And we need to know the handling of stress, because there is a lot of stress when we are developing a new setup. So we need to do yoga or meditation or keeping up our different hobbies. Customer satisfaction is a must and not a choice. Right from the parking area supervisor to the consultant, politeness and communication skill matters. Patient will be panicky, he will be agitated. So we need to calm their nerves at every level, right? Starting from the parking area supervisor. And that demigod, the image is no more for the doctors. ABC, availability and affability, behavior and competence is a must in the modern era. And smooth and hassle-free flow of patients in the OPD area, and anger de-escalation training of the staff and doctors, attentive and empathetic towards the patient. This is the main thing, main ingredient to grow faster. And avoid phone calls, tea breaks, and personal interaction in front of the patients because it gives a very wrong impression. And patient must feel special that they have been provided the best care possible. So the take-home message is feedback from multiple levels because there is always a chance for improvement. And Art of War, it is a book. So not learning from our own mistakes, but learn from others' mistakes and taste success. So smart work and consistency is a key. Average skills combined with excellent interpersonal relationships and management would score better than excellent skills with mediocrity in every other field. Duplicate excellency in everyone and everything for exponential growth. So finally, Ikigai. If I see surgeons, great surgeons like Pandav sir or Santosh Nahar sirs, they are so calm, so composed. So there is that inner peace is there. And that's why they are able to work for so long hours. Thank you so very much. And these are the different institutes, Tirthankar Mahavir Medical College, Maharaja Agrawal Medical College, AIMS Jodhpur, and the Health Procurement Committee, where I have worked. Thank you so very much. Jai Hind.
Thank you. Thank you for a wonderful talk. And if your institute is really running by all those metrics which you have discussed, then I'm sure you'll be going a long, long way. We go on to our last speaker of the session, how to provide optimal training in the setting of high volume surgeries. I'm sure all of us have heard a lot about the fantastic place from where Dr. Alok Sen comes from. And I'm going to leave it all to him to tell us the brilliant efficiency which they show, whether it is in the high special VIP patients or the general patients, all of them being treated equally and great job being done at Chitrakoot.
Good afternoon to you all. At the outset, I would like to thank Santosh sir and the team from Joshi Hospital for giving me this opportunity. It was a great learning experience since yesterday evening. I joined in a bit late, but I have learned a lot. I have been a PG teacher for not many years, just last 10 years. I have started, I have been guiding DNB students, and it was a huge learning experience for me, believe me. And I think I will go back with very good memories and not much more to do in my center. So the topic which was given to me was how to provide optimal training in a high volume setting. I don't think personally that there is any template for training programs. There are certain guidelines. We have been looking or listening to very eminent speakers about those, but we need to actually have our own ways or something that fits into your system. The training that fits into your system. So what in next 10 minutes, I would be sharing how we give the training to our fellows and our residents at Chitrakoot. So this is a general outline of my talk. So I will giving you some of you may not be knowing where I come from, what is SNC and what it is doing. And a brief overview of the training programs that we run. I will speak more specifically on cataract training because that is what majority of the residents they are looking for. The challenges that we face at Chitrakoot and the strengths of Chitrakoot as a training center. So we had a very humble start. This was in 1950, which was at that time Chitrakoot was basically a jungle. It's still, but it has grown a lot since then. And this was the first eye camp which took place in 1950, and that time 956 surgeries were done. So from 1950s to 2000, we were into more of care delivery mode. And since 2000, we started developing or evolving into a more of a training and teaching centers. Now, Sadhguru, the basic aim of Sadhguru is to provide high quality, high volume, affordable services and which is sustainable. That is the basic motto that we work for. And these are not just numbers, these are lives that we have touched over the past 5 decades or so. But since about a decade back, we started focusing on teaching, training, and we have now the students, we have long-term fellowship programs, and we are also a recognized center for ICU fellowships. And these are some of the numbers which show that how many doctors we have so far trained. Now we have two kind of fellowship programs. One is subspecialty program, and the other is a comprehensive fellowship program, which is for 3 years. The subspecialty programs are 2 and 3 years both. So you can go through the details of the program through our website, which is there, and you can ask some of your students who would be interested in joining fellowships to us to go through, and the application system is very simple. What is important is that in Chitrakoot, because it's a very small town, it's a challenge, but it's an opportunity also. We say that in Chitrakoot, we breathe, drink, sleep, ophthalmology. There is nothing else to do. But what we have tried to do is try to provide them with good facilities when they are at Chitrakoot. So the accommodation is within the campus. They stay together, they live together, they enjoy the festivities and other things together. And we have this lovely state-of-art recreation center, which most of the fellows, they enjoy a lot. So something to look forward to at Chitrakoot. So the goals of fellowship, so far we have been seeing or listening to the eminent speakers since yesterday that most of us have the similar sort of goals, what we want to teach our fellows. So it's clinical, it's academic and research, it involves soft skills, professionalism, administrative skills, and others. So in other words, we all want them to be good doctors. So that is the basic aim of our fellowship program as well. So in clinics, we do teach them how to see patients, how to do surgeries, but more important is OT management and cleaning and sterilization that we also want them. Of course, we don't have any way that we can assess their capacities as OT managers of when. So what interestingly what we see is that when they are nearing their fellowship, completion of the fellowship program, they want to go and learn these things because they want to go out and venture into private practice. And these things are never taught in medical school. So OT sterilization and other things are important part of our teaching program. The other is academic and research. And of late, we have started focusing heavily on this. We expect all our fellows to conduct at least 2 research projects during their stay. We do regular research methodology workshops. We ask them to take DNB classes, and we tell them that these publications will be of great help, even if you are going out for a private practice. The most important thing is that we have two of the most reputed teachers in our country who have been helping us in teaching or training our fellows. And you will agree that there is no better teacher than Professor Amod Gupta to do so. The other thing that we have all talked about is soft skill development. Ma'am spoke about communication skills. It's not just how you speak to your patients or your mentor. It's also important how you speak to your colleagues, your staff, and others. And that's where that is what is very important. And these cannot be taught as was suggested in previous section also, that these have to, the mentee or the students usually follow you. So you have to be at your toes to teach them these things. We also try to teach them some of the administrative skills like to conduct audits, manage our city clinics and other hospitals or vision centers that we have across UP and Madhya Pradesh. So I'll shift gears and I'll talk about the clinical training and more specifically about the cataract surgical training. In clinical training, the first 2 weeks of and the fellows usually spend their time in orientation through the protocols that we have. the workflow of the OPD and the OTs. And they also get some time to spend in our sterilization department, and as well as, and after the second month, they are posted in the OT. So the first thing that they go before they go to the OT, they are being given orientation regarding the OT protocols, how to observe, how to see cases of when the mentors are operating, how to be there, the OT etiquettes and all those that are taught to them. We also give them some didactic lectures so that they are oriented to what they are supposed to do. We have a wet lab, which we got through support of Elcon. And it's a state-of-art wet lab where we have all the advanced machines that the fellows will later on operate on human highs as well. Then it is a one-to-one training, because that is what we want, a mentor-mentee relationship to develop. So we allot one fellow, a mentor who would be training right throughout his fellowship specifically for cataract. So it's initially they undergo supervised training. They do supervised surgeries, at least 20 cases they do. And once the mentor feels that they are good enough to be left alone, only then they would be allowed to do independent cases. The training is always step by step, one step at a time. And once the mentor feels that the training is doing the steps properly, only then they go the next step. They have to maintain a logbook mandatorily. And for next 18 months or so, they would continue doing SICS and giving feedbacks to their mentors regarding their progress. And when they start doing independent surgeries, we tell them not to take up complex cases initially, seek help SOS from the mentors and not experiment, because when you are learning, you should not be innovating. Once you are expert, you can. And report all your complications, irrespective of how small it could be, to your mentor. So we regularly, the mentors, they do surgical assessment through video recordings that our fellows they do. And once they feel that they are good enough, then they are allowed to do cases in numbers. One thing that we regularly monitor, I'll just take a few minutes. This is our complication rate review. We tell our the fellows who have more complications to focus on the steps where they are getting those complications regularly. After 18 months, they go on to learn phaco emulsification, and again the process is repeated. Similar process is repeated where they undergo again one-to-one training in phaco emulsification. And in the final year, what we do is we train them for certain things like anterior vitrectomies or handling complex cases and other cases, or aphakia management like that. So in 3 years of time, they have done about 6,000 to 7,000 cataract surgeries, including 400 to 500 phacos. They are able to handle high volumes, handle all types of cases, and in fact, they can handle intraoperative complications of their juniors as well. There are a lot of challenges. One of the major challenges is that the faculty and engagement can at times at a high volume center be difficult, because the faculties are themselves so much occupied with clinical work that to engage them, and we want the top faculties to be training our fellows. So that is one of the major challenges that we face. Sometimes in the first year, I always tell my fellows that first year is the most challenging year of your fellowship program, when you are doing very little and you are seeing all the other fellows or your seniors or faculty doing a lot of work, and you get frustrated. And that's the time when you have to be patient. The strength of the fellowship program, there is one-to-one training, which is mentor-mentee, which Rolika was saying, stepwise training, good number of surgical exposure, and the competence to handle high volumes. So in summary, the training program at Sadhguru is more of a comprehensive training. We focus on basics, and as the competence improves, speed comes naturally. So we don't ask them to do surgeries fast. It is just natural that they, with increasing competence and number of surgeries, they they do the cases more efficiently. And as Rolika was saying that you, as mentee, you have to choose your mentors. And I was lucky that I didn't have to choose any one of them. I just got them by luck. My dad, Dr. B.K. Jain, without whom I would not have been a retina surgeon, and Professor Amod, whom I cannot thank more, because he is the one, without him, I would not have been standing here and talking to you all. Thank you so much.
Wonderful talk, Dr. Alexan. I was very lucky to hear a talk by Dr. B.K. Jain's Nilesh Jain, who spoke on the entire system of management of Chitrakoot Hospital. And it was like a 5-star place. You know, I myself not gone there, but I think it will be an experience for all of us to go and see how wonderfully they churn out I mean, it's like a corporate hospital, it's like a general hospital, it's all combined, and the kind of hard work they do is just amazing. Going right into the villages, what he told us is just something small, and the kind, I'm sure the kind of hard work they do from morning till evening is just mind-boggling. Very nice talk, Doctor. I would want our chairpersons to give their own thoughts about each of these talks, Dr. Santosh, Dr. Rolika, Dr. Arvind, and Alok Sen's talk. Any extra point to be added in their talks?
More than extra point. We want to point out that we are already half an hour late, and we were supposed to finish by 6. It doesn't appear so. So let's move ahead with the next one. My other colleagues don't have.
Okay. Okay. So there'll be a change of chairpersons now. Thank you very much, Dr. Ramesh, Dr. Anita, Dr. Sheetal. And we go on to our next set of chairpersons. Dr. Sheetal will continue to stay, I think. Dr. Sheetal. Oh, that's another Sheetal. Okay. Dr. V. Sheetal, Dr. Padma Malini, Dr. Omkar Telang, Dr. Manisha Sharma, and Dr. Sundar. And without delay, we go on to our first talk by Dr. S.S. Pandav, who needs absolutely no introduction, and he's the top man of PGI Chandigarh, and not only just heading the glaucoma department there, but also the president of the Glaucoma Society of India, and he is going to be talking of on theory what is ideal.
This is going to be the last session, and we would like to wind up pretty fast because one speaker is his flight has been delayed, so because of which she'll be arriving a little late. And yeah, so I request all the faculty to put coffees and please occupy the chairs so that we can start with our presentation from our Chief of PGI. HOD, the Department of Ophthalmology, Dr. S.S. Pandav, sir, who will be going through the theory. What is the ideal theory? And still we are yet to find out, sir. So if you can let us know what is the ideal theoretical part which students have to read and learn and pass, that would be really nice. And all these talks are being recorded and live telecasted through the YouTube link.
Good evening, everybody. And before I start, I must thank Dr. Srinivasan and Santosh for giving me this opportunity. I'm talking about the examination system theory, what is ideal. I think we have discussed a lot about various methods of evaluation, examination, and a lot of concepts are already actually cleared. What we are doing is now is basically going to a little bit more specifics that how we test the theory and some other traits. Theory exam is basically there are 3 components to 3 considerations. Basically, number 1 is what is to be tested. So whenever you design examination, whatever examination, the most important thing is what is it you're going to test there. What is the subject matter? And so obviously the question, the theory paper or the test instrument cannot be outside the syllabus. So, but even within that, you have to decide that what level of competency and what are the traits that you want to discuss. So that test, so that has to be important. Other important thing is what is being tested is the purpose of assessment. What is the purpose of assessments? And we have actually had a lot of discussion on formative as well as summit type of evaluations previously. So I think I'll just be touching up on these issues. And the third thing I would be elaborating a little bit more is that how to test and what is the test instrument that we use. So I think in this, the third point will be a little more discussed, and the first 2 points we have already had some discussion on them. So assessment should be aligned with the learning objectives. So that's very important. So when you are designing a test instrument, be clear that what you want to test, and also what competencies, what level of competencies we want to test. Important thing is that the instruction should be very clear to the students so that they don't get confused that how they're supposed to answer. So there should be no ambiguity in the questions. Avoid the too easy or too difficult questions. So basically, this is very important for examination which are used for certification. So if you have a question which everyone answers correctly, it doesn't have any value in discriminating between the high performers and low performers. Similarly, a question which is too difficult and cannot be answered by anybody, again loses its purpose of being a test instrument. So I think you have to grade they use the questions which are proportional or in line with their training experience or their learning experience. Give enough time for the students to do the questions, and there are a number of ways one can conduct a theory examination. So I'll just be talking some of them. But the important thing is to break down the individual competencies into learning objectives. And when we design a question, we design a question so that we want to test a particular competency. That is whether we are testing the knowledge part, or whether we are testing the skills, or we are testing the aptitude or the communication. So the questions can be designed in a way so that you test a particular competency in the students. The purpose of assessment, we have already discussed the formative and as well as summative part. The formative one basically is kind of a promote the learning. So this is on kind of day-to-day basis, you are making assessment about the students, whether they are up to their mark, whether they are learning adequately or not, are there any deficiencies in their knowledge, and they can be fulfilled. Now there you can use 1 point perceptorship or SNAP techniques, which have already been discussed. The idea basically is that you are just asking a very simple question. Okay, this is a patient. What do you think about this? There's a corneal neovascularization. What do you think is happening here? So these are very small questions, but they will actually force the student to think that what is the reason for that, and then the discussion goes on from there. And that's kind of a on the training assessment as well as learning. The summative assessment is important, but this is where you kind of pass and fail. In formative, there's no pass and fail. It's a kind of a normal process of learning. But in summative, you have to certify whether the students have reached a certain level of competence or not, or is pass or fail, or you want in a competitive examination the student is in or he's not in. Now there are a number of ways of doing it, but for logistical reasons, now there's something very important. Is that certain competencies like communication skill, teamwork, ethics, professionalism, and such traits which are very important for for a practice point of view, but they cannot be actually tested easily. And very often, summative examination, they actually are very not very good at testing these traits. So I think they usually left for the for the summative examination part because of the logistic reason. But I think we should not be leaving that there. They should be done on a day-to-day basis, and that should become a part of the overall assessment of the student. You have already, I think we have seen this triangle many times today, this Miller's pyramid basically, and this holds to when you're designing the theory test paper as well. Now in this pyramid, when you're testing the theoretical knowledge, we are actually operating at the last, to the bottom of the pyramid. We are testing whether the patient has sufficient information, has it converted into a knowledge, and whether that knowledge is getting applied. Now, these are 3-4 traits that we can actually test very effectively theoretically. But when we go to the psychomotor domain, testing a psychomotor domain on a theory paper is actually difficult. So So this works, the theory works well for the lower domains of learning, or the cognitive domain, basically. I should not say lower, but cognitive domains of learning. Then third important consideration is what test instrument you will like to use. So there are a number of test instruments you are already familiar with. You can have an essay type question, or a long answer type question, or short answer question, MCQs, short. Then you have short case studies and true, false, fill in the blanks, matching, etc. So you're all familiar with that. We all have been using these techniques, in different contexts. Important thing is that test instrument use should depend on the subject, learning objective, and the level of education that we want to test. So accordingly, we have to design the test instrument. The essay type questions are very commonly used, and they have many advantages because they allow the student to demonstrate in-depth knowledge, and they also help you assess the student's understanding of the complex issues, which also include like analysis, evaluation, and how to synthesize the information, as well as the critical thinking and some other traits which are they can be actually tested using a theoretical, using a long essay type question, because you are asking the student to actually think or plan the material, organize it in a particular manner, and they present it, and all those needs, activities need a higher level of skill. It also provides flexibility in terms of the type of the responses that can be accepted. Now, that's an advantage, and sometimes it could be a disadvantage, because the student may take a different line of thought, and which you didn't intend to do it. So if your question is very open-ended, then you should be prepared to have a very different kind of responses as well. So therefore, in general, it's not to keep the the questions very open-ended. For example, you can say write a short note or a long note or angle closure glaucoma for 10 marks. Now here the student has the liberty to write whatever he knows about the angle closure glaucoma, and as long as he has not written something which is not true, which is false, he would qualify for marks. But it's better to be a little more specific, and what you can do is that you can modify this to be more specific, like write note on a risk factors, mechanism, diagnosis, and management to acute angular closure glaucoma. So now you're giving a direction to the student that how you expect the matter to be organized, but within that he'll have to have formulate his questions. Essay type questions can be effective in addressing the students' accessing the knowledge, understanding, and also some higher level thinking skills as well as. But the problem is that they are very time consuming. Like if you have to give a 10 marks paper questions answer, then he will take at least 15-20 minutes for that, or depending on how many questions he has to answer. So within that time span, you can actually use much broader areas of competencies if you are using some other techniques rather than essay-based questions. And also the grading is very subjective. Now that's the major drawback of essay type questions, because the evaluation would vary from person to person, and even the same person, if is analyzing marking the paper in a second or third time, the differences could be, there could be differences in the marking. So short answer questions handle this to some extent because they are more specific, and they are also keep the flexibility of the answers remains there, and it needs less time. So to give an example, so if you are asking a management NLD block and a 1-year-old child, so you're asking a very specific question and you expect a very specific answer, and this also increases the objectivity of the evaluation system, of the marking system. It's better to, you can also build in like case scenarios within your essay type questions as well, or in the short answer questions as well. So which actually makes it a little more objective, and gives you a little more direction to the students what is expected. Next is the multiple choice questions, which are being used very frequently nowadays actually, because they are very versatile tool of assessing wide range of cognitive skills, especially, and these are especially useful when you are testing the learning-based object, the knowledge-based objective of the cognitive domain. They are not as good for the psychometry and other domains, but they certainly think so. So, however, it is important to carefully consider the design of the MCQ, because MCQs are very difficult to formulate, and typically MCQ would have a stem cell choices and distractors. So all these have to be balanced to have a effective MCQ. Now MCQs are making MCQs is a very specific skill. It means And the stems should be written very clearly, concise language, and there should not be any ambiguities. And distractors should act as distractors. That means they should be close and there should be plausible and close alternatives to the main answer, so that student can actually consider them as a valid answer. And MCQs are not, it's very easy to formulate them, but if a badly constructed MCQ actually doesn't do any good. So they're probably the worst kind of tool for assessment. So it's very important the MCQs are validated. So validity means they measure what they are intent to measure. They should be reliable. That is the score should be consistently the same when they apply to a different groups of the similar learning experience. Now here again, the similarity in the learning experience is very important, because if you have an MCQ which performs very well in the undergraduate, same MCQ will not perform at all in a postgraduate setting. So it has to be depending on the learner's experience or the learning. So the MCQ has to be matched with that particular group, and only then it will work. And all the MCQs before they actually given used as a testing instrument, they should be item analyzed. So what item analysis means is that they should be valid, they should be reliable, and we should know that how there's few indices which are associated with MCQs, like how effective they are in distinguishing the high performers versus the lower performers. That's called a discrimination index. And also, what is their difficulty level? Difficulty level means that and how many people in a group or what percentage of people they can actually get it right. So all these parameters should be worked out before you can give an MCQ, use MCQ as a tool. So typically this is done is that with MCQ has to be given to a test population or test sample before you can actually accept it as an MCQ in an exam. So what typically is done is that if you have a MCQ exam for a particular, branch, you have to, there are 100 MCQs, then you'll insert some, another 10 or 15 MCQs in that. And those MCQs will be just for the test purpose. They will not be affecting the score of the students. And after the exam, you take out those MCQs and see how, the students performed on those MCQs. And then you can use some statistical methods, statistical tools to get their validity, reliability, and the discrimination power or facility or difficulty indices. And once we have that, we can keep those then we can modify or keep those MCQs depending on their performance. So MCQs has many advantages, like is very objective. Assessment is very objective, is very efficient. It can be actually automated. They are time saving, very versatile. They can actually use multiple domains of cognitive skills. They're very easy to administer, and they can also reduce the guessing part, which can be done on theoretical or short case basis. But the important thing is that MCQs only work when you have a lot of them, because you are doing the exam repeatedly, and if you have a very small database of MCQs, after 2-3 cycles, people will know what the MCQs are and they will have the answers as well. So you need a very large data bank or question bank for these MCQs. I should have like 30,000-40,000. But that depends on the cycle, how frequently you're giving the exams and how many students are appearing the exams. But the best side is that there are now ways to kind of crack the exam. So it has become a kind of a professional thing. Okay, you will see a lot of advertising that how do you crack MCQs exams and other things. So that's the other side of it. So that means your data bank security is very important. Your items in the database has to be large, and also they have to be properly item analyzed and safely stored. So MCQs has some disadvantages, as well as they have a limited assessment as far as the creativity, originality, and critical thinking is concerned. But these traits are very difficult to assess on MCQs. Then if there's an ambiguity in the stem, then there would be an ambiguity in the answer as well. And, there will be kind of a, that affect the validity of the test itself. And there could be lack of contextual clues in the MCQs. So to summarize, there are a number of ways to test theoretical knowledge. Long answer questions, essays, they have their uses. Short answer questions, a little kind of improvement on that, and they take a little lesser time. But both of these are very effective tools. So in case of testing, the higher thinking levels and comprehension of the students, that how well the students understood the concept, and all case scenarios can be built into separately, or they can be part of the short answers. MCQs are very useful, and because they're very easy to implement and they're time saving. The question is, what is the ideal, way of theory? So there's no one method is best for all domains of learning and all levels of learning. The test tools should be used appropriate to the being tested, and generally the combination of test method is better. So MCQs have an advantage in testing larger samples or wider domains, but they have a limitation because they are best suited for the summative kind of a assessment, but the formative kind of assessment, the other tools are perhaps better. So I think you have to choose what type of examination is involved and what domains of learning you are going to test. I think you have to choose the best tool accordingly. Thank you very much once again.
Thank you very much, Dr. Pandey, for a wonderful talk. While Dr. Sujata Rathod gets her presentation ready, one question to Dr. Padma Malini or Dr. Omkar, whoever could answer. Do you think that there is any role of asking our students to go read up on the previous year's questions and prepare their answers and read in that manner? Or does it now make sense going forward that teachers encourage students to read based on the clinical cases which they see each day, go back and read about them, and then enhance their overall theoretical knowledge rather than becoming, structured in a very narrow manner?
I think emphasis on the problem-based learning, basically. So I think that approach has a lot of merits. When you are seeing a problem and then you want to solve that problem, so your efforts, your kind of a neural effort involved in that is much higher, and that using that technique, the retention time is also much higher. Retention is also much higher. So I think that definitely is very useful. But having said that, the knowledge of the basics is also required, like the basic facts, the information part, those are also required. So you can't go to a higher level unless your lower levels are well sorted out. So if you have right information, you can use that information to solve the problem. But if you don't have any information, you will not be able to solve the problem.
Do we go still ask our students to read the previous year's questions and write their answers and read up like that? Or day-to-day clinical cases, go back and read about it and be more thorough about it?
I think from exam point of view, students will always go back to the previous question and see how to answer them. So that kind of give them a practice.
What Dr. Chitra is saying makes a lot of sense. That's the best way to make them really have a good memory of the case. And if you teach them to go back and put down in their own writing, starting from the definition till the recent advances about every case they've seen. I think that's the most ideal way of
teaching. Maybe we should modify our teaching patterns also nowadays. Yes. Thank you very much, Dr. Pandav. And now we have our very eminent Dr. Sujata Rathod, who's going to be talking on clinical examination and what is ideal. And Dr. We would be most obliged if you stick to 10 minutes and give us all the very salient points which is necessary in clinical examination. And again, we all know she's the director of the Regional Institute of Ophthalmology, Minto Ophthalmic Hospital, which is huge and that doesn't look like a government hospital. It's as majestic and grand inside as it is outside. And that's run in a beautiful fashion, and I had the pride of visiting that place too. Thank you.
Thank you, Dr. Chitra. And at the outset, I would like to thank Dr. Srinivas, Dr. Santosh Honavar, and Dr. Kudlu for having me here to speak on this topic. And I
Dr. Krishna Prasad.
Dr. Krishna Prasad
from Joshi.
Yeah. Well, greetings from this 127-year-old institute. It's the second oldest institute after the Chennai Institute, RIO Chennai. And the reflection, what you're seeing is the new super specialty block, which we have after 125 years, that houses all the subspecialty.
Well, to talk on clinical examination in this regional institute, I would like to say that we have MBBS students about 250, MS about 26, and fellowships in various subspecialties, about 12 students. And also training goes on in all the paramedical subjects to the nurses, things. So yes, as teachers, we all realize the importance of history taking in any clinical examination. As William Osler rightly said, listen to your patient. He is telling you the diagnosis, and this fact has been overemphasized by all our earlier speakers as well. So, a good history taking remains the first step in ideal clinical examination. Again, it was one of the founding fathers of modern medicine, William Osler, who said that it is extremely important to observe, record, tabulate, communicate, and use all your senses. And then alone, by practice, you can become an expert. And so, by the knowledge we get from the books, by the observation we do on our patients, if we record and tabulate and communicate and keep practicing this good habit of identifying every of these pathological conditions, will we be able to make our students good enough to go out in the society and treat the patients rightfully. So a thorough eye examination, both anterior segment and posterior segment, is to be taught from the day one. And it is not that that would be a way to go about clinical examination, which is ideal just for the examination pattern. What happens with most of our students is they're learning, be it for theory or for practical, is to just pass the whole examination of the course, the masters, and it should not be of short memory and should not remain for that day. What they learn in the 3 years in the right clinical examination way should be what they should take out and use it on their patients. So, in a comprehensive eye examination, you need to understand that eye and ophthalmology being an extremely unique medical science, we do not have only one generalized way of examination. We need much more specialized way of testing too. But under the general examination, we'll have the visual acuity testing, a torchlight examination, the slit lamp examination, which is the standard of the day, and the posterior segment evaluation. We do have various guidelines by the preferred practice management techniques, which are the documents which give us a recommended framework for how to practice on our patients rather than prescriptive care of a patient. As Hutchison said, observe the patient as he walks in, and that's where we have to look at the patient as a whole. And many general examination findings are related to the eye, especially as you can see in the other picture, the typical thyroid stone. These are few of the other things where eye is always involved. So generalized examination is of extreme importance. Visual acuity, again, most of our students are taught to do the unilateral evaluation in one eye, but they forget to present or understand the usefulness of pinhole examination. So it's important that we tell them that pinhole improvement is to be examined and the best corrected visual acuity after subjective and objective refractions. Near visual acuity is to be tested. The color vision, contrast sensitivity, and confrontation test should be the way a bedside clinical examination to know about the patient's visual field to be conducted. Going on, it's important that every head posture is to be seen and understood, whether it's the head tilt, the chin elevation or chin depression, because each of this is going to tell you where the condition is leading to. Hirschberg's test cannot be oversimplified. It's the most important test to tell you about the ocular posture, and just evaluation of this in the right way would be helpful to make our students realize the importance of each of these conditions and thereby go on to more detailed evaluation. One of the titratory methods of test is the Roplast test, where on pressure on the sac is going to give you indication of the involvement of the sac, and the various impressions by the lacrimal syringing test. This, if taught well and if done rightly, they'll be able to identify and managed in the right way. Examination observation is the most important thing. So a systemic examination, be it from the eyelids, where so many tails have already been easily noted, to details of the adult or junior childhood ptosis, congenital conditions, examination of the conjunctiva. The whole concept is that no part should be missed, and you need to go about very systematically from the eyelids till the more posterior part of the eye. So examination of conjunctiva, looking at the bulbar, palpebral, fornicel, double eversion technique. And here you could make out all the various things, including the telltale, the fish scales scaling in the detox spots of the patient. Slit lamp examination has become the standard of evaluation, and this with its various types, either by direct illumination and various types of evaluation, you will be going into the specific structure, and the specific details will be identified. Sclera, one needs to identify whether it's normal, discolored, has features of inflammation or staphyloma. Cornea, of course, all the things about what a normal cornea should be, the size, shape, surface, the sheens, the metrics associated with it should not be missed, which they should be taught to identify this. You can see the coloboma, the Munson sign, and the various degrees of corneal opacity, be it of iatrogenic trauma or post-keratoplasty. The slit lamp scan or the image is to be taught very clearly, and what our students now lack is their ability to write it down. They all go by the digital images, and they have forgotten the art of actually drawing the conditions with the rightful color coding. I think that is one thing that we see that our students maintain. Of course, the corneal sensations and the interpretation by a good drawing is extremely important. Yeah, this I have specifically put to say that this skill is lost with our students, because they always just go with the digital pictures. But unless we teach them that their color coding and the writing of the diffuse examination and the slit lamp examination, they will be losing out the whole concept of identifying these things in the right way. Anterior chamber is tested with either by the pen torch, the Von Herring's test, the various more advanced tests of split limbal technique, the Smith technique. All these we routinely teach our students, and they should not be missing any of this in the short time that is given during the examination. So content again, then going to the iris and its various normal patterns and abnormal patterns. Examination of the pupil, looking at the general pupillary examination, the light reflectors, the swinging flash test, which should not be missed at all, and the near reflex test. All this becomes a part of teaching in the 3 years of their course, and not just on the day of examination. I think it's important that they identify that this anisocoria should be looked both in the bright light and the dim light. And the swinging flash test, flashlight test in the dim room illumination. Near reflex should not be missed, and this should be, we do not use a flashlight here. Looking to the next structure, that is a lens with regard to its transparency, position, and shape, and the various abnormalities associated with this. So if I have to run through, yeah, definitely, this is again extraocular movements is one of the most important thing. And the ocular motility examination, be the version, the duction, and the vergence has to be taught, and how to interpret this when it is a unilateral presentation, and when both eyes are being presented, we have to see that they comment on both the two muscles which are responsible for these extraocular movements. This, the Goldman applanation tonometry, is the standard of examination that has to be taught, not to miss the angle structures. And coming to the most posterior part, the fundus examination, be it from the direct ophthalmoscopy or the indirect ophthalmoscopy. All this have to be emphasized, especially about the indirect ophthalmoscopy, where we have to teach them to keep the vitreoretinal drawing chart inverted on the supine patient. This again, drawing on the Amplis chart is to be stressed upon, and hence an ideal clinical examination would be able to summarize the history, recreate the history, and identify the summarize at the history level as to what could be your working diagnosis. Then, with the clinical diagnosis, a working diagnosis, have a clear-cut differentials for each of the conditions, and then plan for the management, including the investigations. To end it all, absolutely there's no shortcut in looking at the clinical examination. It has to be ideal, and there should be no shortcut in learning or teaching. Thank you very much, Dr. Sujata, for a wonderful talk, and which will have to be forcefully completed in 10 minutes. While our next speaker, Dr. Rajendra Chauhan, gets ready with his OSCE and what is ideal, I would want to ask Dr. Padma Malini one question. Don't you think that in the process of doing a complete IE examination, which our students are doing, are we instilling into our students that when they walk in, they should evaluate them systemically, keeping in mind, are we telling them that there could be 2-3 pathologies coexist in the eye? I picked you up because in uvea, whether it's uvea or retina, it's invariably just not that ocular examination which helps you come to a diagnosis. So how it is necessary that our ophthalmology students do a thorough evaluation? Yes.
Many times when the patient walks into the clinic, we observe them, and that gives most of the systemic clue what they have. And complete ocular examination, dilated fundus examination with scleral indentation. It's important to come to the ocular, and we mesh based on the ocular findings and the systemic findings what they have. Based on that, we put a probable differential diagnosis. It will help us to cleanse the appropriate associated systemic disease.
Hello. Respected chairpersons, Dr.
No, most importantly, I need to add a word about you. We have Dr. Rajendra Chauhan here, who is, I think, very well known to me for so many years. And he is to present as senior professor and head of the Regional Institute of Ophthalmology at PGIMS Rohtak. And I'm sure he is the best person to talk on this particular topic. However, he has to work his magic in the next 10 minutes. Thank you.
Thank you, Dr. Chitra. Respected chairperson, Dr. Chitra, Dr. Srinivas Joshi, and Dr. Sundar and other friends and dignitaries of the dais. About short, I'm thankful to Dr. Srinivas and Dr. Honavar for inviting me in front of such a galaxy of stars. And my topic is OSCE. What is ideal? Or what is ideal OSCE? OSCE is what it is, by definition, it is objective. Every student gets the same patients or same chance. And it is structured. Several skills are tested at one go, and each skill is tested in a separate station. And it is clinical, testing the skills of students, manual skills like examination of the interchamber of the eye, communication skills like taking patient's history, and examination. The examiner have got the checklist for doing marking. And it is a multidimensional practical examination of the clinical skill as a tool for assessing clinical competence. And OSCE is assessing multiple competency within the same encounter. Knowledge, skill, professionalism, and communication can be tested by a single well-designed OSCE station. It is a modern examination to test clinical skill performance and competence in skill such as communication, clinical examination, medical procedures, prescription writing, manipulation techniques, and interpretation of the results. What are the attributes of OSCE? Actually, this would be validity, reliability, and feasibility. Validity is the ability to take history, physical examination of the patient, reaching a probable diagnosis, and interpreting the reports and recommend a treatment. Reliability, all the students examine the same patients and mark on a predetermined checklist. And the feasibility, like multiple stations, like 8 to 10 stations with a fixed time frame, like 5 minutes each with different tasks. All students can be rotated and it is feasible. Now, how to design the OSCE stations? There are two types of stations. One is procedure station and one is question station. Procedure station is when which takes care of the doing part. The students should know how to do a particular thing. And it should be observed or unobserved. Observed means when the examiner is looking at the student, how he's taking the history, how he's doing the physical examination, how he's doing the slit lamp examination procedure, even air tonometry and indirect ophthalmoscopy. I tell you many times when I go to conduct MS examination, I specifically ask them how you are performing air tonometry. Just tell me step by step. So this is, they should know that it is not, if we just ask a question, what is the pressure and the percentage that pressure is so millimeter of mercury by 8% tonometry, it is just the knowledge. But whether he has actually done it, whether it is he is doing in the right manner, that is the purpose of OSCE. And the question part, unobserved is, you don't need to observe, but like HFA printout, OCT printout, Pentacam, he will read the printout and then he will write the interpretation of that. And then there should be question stations. The what part, they should know knowledge and question answer. So the example of 10 station OSCE is like observe and unobserved. Observe is history taking. We are specifically talking about the ophthalmic examination now. History taking is also very, very important. Whether they are specifically asking questions related to the particular disease of ophthalmic importance and going into the details of the patients. He's specifically asking about the age because some of the diseases are like some of the diseases are in a particular age. And performing the slit lamp examination. The moment student sits on the slit lamp examination and how he performs the slit lamp examination, moves the rotating drum. So it tells you the whole story, whether he has seen that slit lamp, because one of the college I went for inspection and I was told that we have the wet lab and we have to go to slit lamp. I just switched on the light and it was not working. So the students were not using the slit lamp. And there are only 3 slit lamps were being used by the consultant, and the students were not able to see the slit lamp. So it is very, very disturbing situation. So that's what the moment they sit on the slit lamp, ask the patient to sit on the slit lamp and then clean the everything and then start rotating. That is the good part where you must see that. 90-degree examination, you immediately put out the 90-degree lens and put in front of the eye. The moment the way he puts the lens, you know that he knows the subject and the procedure. And the awareness tonometry, some people they will see through the microscope with the both eyes and will proceed toward the patient without feeling that it will touch and damage the cornea and put the pressure. That means they do not know how to perform the tonometry. And same is true with the indirect ophthalmoscopy. They are sitting in the chair and without asking the patient, without in the lying down position or without in the putting the patient in a proper position, they are going ahead. So that is how we have to examine the student in OSCE. And unobserved like HFA printout, OCTs and Pentacam. So there should be another stations and instrument stations like instrument. We can always keep on asking questions. So if they have to pick up the instrument, then they'll have to tell about the instrument, then how that instrument is used. X-ray, CT, MRI with questions, of course. So in a particular manner, we can have 10 stations. Each station is testing different ability of the students and observed and unobserved, and fixed time frame like 5 minutes or 7 minutes on each station, and the student will keep on rotating. So we can finish all the 10 students or 10 students or 5 students, whatever, in 1 hour or 2 hours, depending upon the length of the question you want to ask. You can keep the buzzer at 5 minutes or 10 minutes or 20 minutes, depending upon the time frame we have. Now, the virtual OSCE, it has regained popularity recently because of the significant part of the practical examination. because pandemic made it difficult to hold exams with the actual patient. And it removes the subjective bias and fair way to examine candidate virtually. Actually, type of OSCE question in virtual clinical examination is clinical case scenario, image-based questions, video-based questions, biostatistic, recent advances, and investigative modalities and instrument. And tip to prepare OSCE, the image can be taken from the atlas. Surgical video we can cut and paste surgical video, review of stats and complications, clinical trials and acronyms, refraction, of course, because somebody told that these days the students are unable to perform refraction because they are not posted in refraction, and everybody is dependent upon auto-refractometer or optometrist for refraction purpose. I think that is very, very important to do refraction. And because of paucity of time, I am not able to tell some of the examples. And clinical procedure like pupillary examination in a video form and bar diagrams and other data display. Currently in India, only the DND includes OSCE as a part of practical examination. However, many international bodies like ICO and Royal College, they are incorporating OSCE in their exam. There are during the guidelines, they have a big question bank, and they are asking all the faculty around the India to prepare the question bank. 5 questions are to be prepared from each faculty, and they should carry 5 marks. Each question should be allotted 4 minutes, and there should be descriptive material for 300 to 500 words in each question. MCQ format is not allowed in OSCE, and balance. Some are easy, some are moderate, and some are hard. Some of the example I'm showing you. This is one of the example where is the description has been given, then there is a photograph, then there are 4 questions, and these are the expected answers. So these answers are for the examiners, and the students are asked to write the answer after going through this. This is another OSCE question where the picture is there, and then the 4 answers are there. There is a small history and expected answer. They're small answers, so they can finish these answers in 5 minutes. If many of you must have conducted DNB examination, there is the OSCE, first 1 hour is for OSCE. This is another example of bar diagrams, and then there are 3 to 4 questions. Another example, like identify the device, where it is placed in the eye, how many such devices are placed in one eye. So this is another picture, so that it gives the clinical scenario. It is not only like they see the picture, they recognize this thing, and then they write on the piece of paper. It is subjective and it is reliable. And then some of the picture of OCT, they have to answer the OCT questions. And some of the videos, this is one of the screenshot of the video. I hope the video will go. Can you start the video? No. I don't know how to start the video, but anyway, this is a, can you start? It is only 10-second video. Yes. So this is the video, like the video shown to the student, and then after seeing only half minute video, the student has to explain what is the diagnosis and something like that. And this is another procedure where there is another video, and will you start this video also? Yes. So the video is the real photograph taken from the OSCE of the DNB, where I was the examiner to train our residents, because we have not incorporated OSCE in MS examination, but I plan to incorporate these OSCE in our MS examination. And sorry, the carry home message 10 minutes only. So OSCE should be incorporated in MS examination also. It is valid, reliable, and feasible. 10 OSCE stations may be designed to cover the clinical and practical objectives. Whereas they should be examined periodically so that they know their deficiencies, and the feedback mechanism should be instituted in the students. Thank you very much.
Wonderful talk, and everything said in 10 minutes. We have a panel discussion in the end to cover up all these topics. So we go on to our next speaker, who's going to be talking on Viva OC, what is ideal. Dr. Smita Patel, she's there?
Yes, I'm very much here. Thank you for this opportunity. I'm just going to share my screen.
Dr. Smita, can you please share your screen?
I'm just in the process, just a minute.
Do we have our next speaker, Dr. Rajiv Kumar Gupta, sir, to be ready? So you will be presenting next, sir.
Yeah, am I
Yes, yes.
audible and are my slides visible now?
Yes, yes, madam.
Yes, the online lectures are the modern sciences. So sorry, I have to ask those questions. Yeah, so I am Dr. Smita Praveen, and I have been associated with Shankara Nethralaya since the 90s. For over 3 decades, I worked in the community wing, interacting with students, teaching them surgery and clinical ophthalmology. And we've all seen from the lectures today and yesterday that all of us, from completely unstructured and free styles of teaching, are now moving towards a structured format, both in curriculum and methods of teaching and learning. The term viva voce derives from Latin of the Middle Ages and translates literally as with the living voice, but most often translated as by word of mouth. So it may refer to an oral exam, a thesis defense, or even a voice vote. It is, in fact, the earliest form of assessment of medical and other apprentices and can trace its roots to antiquity, be it ancient Rome or Indian Nalanda. Plato went so far as to state that the spoken word was superior to the written. Candidates were deemed worthy of certification only after they had satisfied a panel of more than one learned assessor who tested the candidate's scope and depth of knowledge on various topics within a specified time frame. So nothing much has changed over millennia. In the context of medical education, viva voce is a form of oral assessment. Now, many of my students feel that in the Indian scenario, examinations test memory power and not knowledge. But I feel a well-devised viva can change that notion. Being a complete maverick, I believe a lot of teaching, and I'm sure many of you will agree, happens on bedside rounds and in clinics, and not necessarily in an auditorium or classroom. There can be free speech and a chance for students to express themselves competently and clearly on brisk questioning on rounds with a rapid-fire change in topics. This helps them with vivas going forward. But before discussing what makes a viva ideal and how we can get there, let's have a look at the good and the bad aspects of oral examinations. First, the advantages. 1. These assessments examine a significant part of the syllabus and test the student's capacity for factual recall. 2. The interactive dialogue between student and examiner can showcase the extent of in-depth learning, applied knowledge in various scenarios, and also allow students to think on their feet. 3. Vivas demonstrate the student's ability to synthesize information, reflect, and think critically in real time. And 4. Oral assessments showcase their communication skills. An often overlooked advantage from the teacher's perspective is that these assessments allow us to diagnose limitations and weaknesses and let us take corrective action. While this method allows examiners to get a first-hand eyeball-to-eyeball feel of the candidate's grasp of the subject and verbal skills, it also lends itself to a lot of subjectivity. The examiners can be judgmental. This works against modern principles of a perfectly objective examination. Another limitation is a lack of standardization and personal biases, poor inter-examiner reliability, and sometimes undue influences of irrelevant factors such as cultural background and individual differences. It also works more in favor of students who are quick thinkers and respond immediately to questions, rather than those who are slow, hesitant, or even deep thinkers. Students who believe in the maxim, if you can't convince, confuse, have a slight advantage here. Oral tests can also be stressful to many students. Now, we do not live in an ideal world, but we could get close to an ideal or nearly ideal viva voce. And here's how we can do that. My terminology is going to be very basic and fundamental. So, structured viva voce is a better assessment tool as compared to traditional viva voce, as it is more objective, brings uniformity, and prevents bias and variability on part of the examiner. The aim of the Viva should be to test cognition, interpretation, and decision-making skills with adequate clinical reasoning. A structured Viva tests each of the key elements involved in case management, including data acquisition and diagnostic development. A grading rubric that describes the expectations and performance criteria of the exam enhances examiner marking reliability. It is important to prepare the examiners too prior to the actual Viva so that they can discuss requirements, expectations, and approach to questioning. We must ensure that all examiners have had the chance to review and discuss the case reports of the day. When developing questions, the focus of each question must be aligned with content and learning outcomes. Consider asking open-ended questions that encourage answers requiring significant communication and explanation rather than being limited to monosyllabic yes or no replies. The questions themselves must be short and to the point to avoid confusing the student and also allowing the student to do most of the talking. There should be a few questions that are common to all that can act as a benchmark for comparing answers. The Viva must cover a range of different but relevant issues to avoid the results being skewed by selection of a topic with which the student is either very well versed or has absolutely no knowledge. Viva voce has been referred to in literature as a rite of passage that is inherently unreliable and anxiety-inducing for many students. Reasons for this anxiety vary from endpoint uncertainty, ambiguity about nature of questions, and marking systems. When anxiety levels are high, we all know that assessment of knowledge, understanding, or capacity to think critically can be limited. Now, we can support student success by better preparation, including role plays and mock vivas in our clinics. Regular case presentations during ward rounds or in clinics will help build confidence and the ability to communicate crisply. I'm a huge fan of feedback, so I would suggest that the ideal Viva should end with a debrief with the students and examiners with plans for better improved future performances. Gathering student feedback on the process of Viva can help ascertain its value as an assessment tool. Now, education and healthcare are two sectors that are most resistant to change and also are the slowest to change. We, as educators in the medical field, straddle both sectors and are in a position to change the status quo. But first, we need to acknowledge the limitations of traditional Viva voce methods. We must start by training examiners in ideal effective techniques for conducting Vivas. This can be incorporated by introducing benchmarks and teaching them best practices as part of faculty development programs. Structured Viva voces can bring about uniformity and a certain level of validity to the system. And finally, use feedback both from examiners and students as a means of continuous improvement. Thank you for your time and attention.
Thank you very much, Dr. Smita, for being so precise and very crisp in your talk. But before you are able to hear me, Dr. Smita, can you hear us? Dr. Smita, can you hear us?
Yes, I can, ma'am.
Okay, no.
Murphy's not happening here, So.
Talk was very nice, but I would just like to us all to think differently. So I wanted one of your statements said that. Don't you think that as examiners, the responsibility is so huge that there has to be a preparation by the examiners how to ask these questions, and how do you think would be the ideal way to improve it in just brief words? How to improve?
I think somehow the Western examiners, like the FRC of those exams, they already have a briefing session in the morning of the exam. So they are taught, these are the points, this is the way you point, give marks, these are the questions that are to be asked, have some benchmarks, and that's how we go about it.
And do you think that instead of clobbering a student in one day, in having 4 days, could it be that on that particular day the student could not have done very well? Could the system be such that while the examination is conducted in 3 days for all the students, it could exam in one day and part in the other so that they are able to make up for what they've lost on the first day?
It might work, but it also will contribute to examiner fatigue. So I think the examiners will get tired if they have to be asking questions 3 days in a row. So I think we have to find a middle point there.
Yeah. Thank you. Thank you, Dr. I think when we were conducting the I2I program from MM Joshua Institute from 2006, and every year we keep changing it. The only what we used to get from the postgraduate is please cut down the theoretical lectures and increase the Viva voce.
because students want to face different examiners. In MS, we know that who will be the examiners, at least we'll have a clue. But in North goes to the South and East goes to the West.
Right.
We are really scared. So I have seen most of the interest in the Viva OC, especially they say that, sir, we just want to attend Viva OC because all the theoretical lectures, one or the other, will be available in the webinar or seminar or in the books or the Google. But different examiners, especially the DNB, sometimes the MS examiner comes. And there are two different schools of thoughts between the MS methodology and the DNB methodology. And we have seen that even the DNB students face the MS examiners. So their technique would be probably slightly different. So I think YOC is one very interesting thing which our postgraduates would love to learn. And that's the feedback what we got from most of the.
Yes. And I think this should happen continuously over the year. It cannot happen just a day or a week before the exam. So,
Exactly.
yes, the onus is with us, the teachers.
Thank you.
Thank you.
Smita, really wonderful talk. Thank you very much. So next we move on to.
Our next speaker is going to be Dr. Rajiv Kumar Gupta, who is going to be talking on attributes of an ideal PG examiner. I think that's a very difficult talk. And
after that, we have Dr. Deepti and Dr. Usha. Madam, please be ready. Last two talks.
Good evening.
Screen.
First of all, I would like to thank Dr. Santosh Sunawar sir, Dr. Srinivas, and Dr. Krishna Prasad for giving me the opportunity to share my view with all of you. Sir, you have provided a platform where learned ophthalmologists, ophthalmic teachers all over India have gathered and interact with themselves. So it is a very unique experience. So my talk is what should be an attribute of an ideal PG examiner. The training and evaluation of postgraduate student is very crucial, not only for providing quality eye care to the population, but also for the future of the Indian ophthalmology. A good and proper evaluation is required to make a resident a complete ophthalmologist who can take ophthalmic problems independently and play an important role in elimination of blindness. So what should be the goal of an examiner? What should be the goal of an examiner? To produce competent ophthalmologist who possesses necessary clinical judgment and surgical skills so that he can independently manage patients in a manner that is scientifically appropriate. The postgraduate training in India starts by taking admission in a postgraduate course either in a medical college, whether it is government or private, or a national board of examination accredited hospitals. The selection and admission of candidate is done through a common entrance examination, NEET, and seat is allotted on merit cum choice basis. In government or private medical college, courses offered are MS Ophthalmology and DO, MS 3-year duration, DO 2 years duration, and DNB accredited hospital, primary DNB and secondary DNB of 3 and 2 years duration. Having an experience of more than 20 years as a PG teacher, examiner, and NMC assessor, an ideal PG examiner should consider parameters: prior information, taking examination itself, feedback, and the guest lecture. A PG examiner must have thorough knowledge of all the subspecialty of the subject. He must be updated with recent advances in ophthalmology through latest journal, attending seminars, CME, and conferences. He must have prior information a detailed information about the medical college or hospital where he is going to take examination. Also assess the teaching curriculum, training schedule, and infrastructure, equipment and instrument which exist in the hospital or medical college where you have gone as an examiner. As there is not any informality in teaching and training provided by postgraduate teaching institutes, so same yardstick should not be applied in examining the student. So you have to be flexible and accommodative. So what should be criteria for evaluation of a PG student? It should be based on his clinical knowledge, clinical judgment, handling of the instrument, interpretation of the investigative reports, and his surgical skill. Coming to the qualities of an ideal PG examiner, questions should be asked in such a manner that students should understand it clearly. Be a good listener, be submissive and friendly, never become agitated. Do not encourage favoritism, never try to impose your knowledge. Help the student in all possible ways to come to an answer. Few same set or pattern of questions should be asked from every examiner, which will help in judging a student in order of merit. Give reasonable time for answering the question. Never become prejudiced either to a student and or institute where you have gone as an examiner. Never try to demoralize the student. Examiner should be a proactive person and not intimidatory. As per NMC guideline, it is mandatory for every postgraduate institute to organize guest lecture. So head of the department should take this advantage of the presence of the examiner or professor by arranging guest lecture so that students should get benefit by interacting with the experienced clinician. Now, feedback before leaving the institute, interact with the student and give your feedback to each and every student regarding his status of knowledge and training in that particular field. Also provide suggestions to overcome the shortcomings and method to improve. It is also recommended to give your assessment regarding the institute so that standard of teaching can be improved. Thank you.
Thank you very much for being so crisp and precise. We shall now go on to our next speaker. Some of the questions of these topics will be taken up in the panel discussion. Second last speaker is Dr. Tripti Joshi, who decided to change her topic, and she's going to talk on do-it-yourself wet lab, go vegan. So let's see how she's going to make a vegetarian wet lab.
I request.
So in under 20 minutes, we are going to have a group photograph. So please call up your friends who have gone to the beach. They can come in the beach wear also. No worries. So they can be put at the back and we will stand in the front. So no worries. Please inform them that we shall have a group photograph and then we all can live together. And 7:30, the banquet starts and 10 o'clock it ends because of course the food and the fellowship continues till 11:30, but because of the restrictions in Goa, we have to close the music by 10 o'clock. So we should start sharp by 7:30.
So good evening, everyone. So from morning, we have had multiple talks as to how to set up the wet lab. But then, I think. So from morning, we have had multiple talks as to how to set up the wet lab. There have been multiple talks as to about the simulators. But then coming to the actual thought process, can all the institutions, can all the medical colleges offer, can we afford the simulators? Can we send our postgraduates where the simulators are present already? What will we do about the shortage? What happens? These are some practical questions which had come up during that of the lunch break. So that's when we decided, let us just change the topic. This is a small topic which I had presented elsewhere. So we know that ophthalmology has multiple surgeries, intraocular procedures, extraocular procedures, be it retinal procedures or squint procedures. Our postgraduates, as Dr. Ragini ma'am had mentioned in the morning, they want to do is they learn surgeries. Cataractology is what she mentioned. Ophthalmology has become a cataractology. There are two ways in which we can teach them surgeries, either by using simulators, or the second one was the one which has been highlighted always by video is not playing.
Click on that.
Main video or by using hybrid eye, where we incorporated the human nucleus into that of a goat's eye, and this is a very common way in which the teaching was done previously in the wet lab. Corona brought a lot of change in our institution. There were dearth of SICS, dearth of camp surgeries, dearth of human nucleus. And that is when the thought process came to us. How will we teach our postgraduate surgery? What will be those 2 years of post-graduation surgical training? And that is where we came up with the new way, do-it-yourself wet lab for surgical training of residents. And that is going vegan way. So the video is not playing here. Let me just go there. ऑडियो 1 मिनट वहां पे गई सर वो ऑडियो ऑडियो okay, I'll give the audio to this video.
Until you set it. Resources parents and searching independent type of surgical training that we have separately this is very fun, which is available on the show for the the reality is that subsequently rights which will many of this non-incision complex surgery. Scenario is
centuries of production across the world. Facing this paradox, should be judging improve governance. And making the practice within the site and the service and growth and steps of the church or chapel and the easy to practice the service of Features which are done in the Sriva can be practiced on the school. Single command can also be used plans. This is plans and the stable words can work at such a story. Short, there are also different things of use for not Searchable, this is one of the earliest that is compatible with the symbols. Traditional associated words includes the switching. The social practice and the somewhat different things also need proper language. This later should be social. When it shows that and use that analysis practice. There's a common word for surgeons or
We have to actually teach them the surgery, but this is just their baby steps. Before they go in and practice on our patients, on the humans' eyes, actually, if we just give them the first 3 months of these training, they do get a good hand-eye coordination. bidextrous learning. They do learn how to handle the instruments. So these some of the baby step way in which we can do their wet lab training, even if we don't have any other source of huge investment, can still help them to do perform surgery later in the human eyes. Thank you.
Brilliant presentation, Dipti. Nothing less was expected from you.
Thank you, ma'am.
Now I got to know why the vegetables and fruits from her house were found missing, because she was probably using it to train her postgraduates. In fact, I had personally not seen this video, and now I got the answer for the missing articles at home. So thank you very much, Dr. Deepti. It was really a wonderful presentation. And then now we come to our last presentation of today. Is none other than Dr. Usha Johari, madam. And she'll be speaking on safe vision in developmental disabilities. And after that, we are going to have a quick group photograph. So I request everybody to please stay for a few more minutes and then we can depart.
Very good evening. At the outset, I would like to thank Dr. Srinivas Joshi, Dr. Krishna Prasad, and of course, Dr. Santosh Munawar for giving me this opportunity to be here. My topic is little different here. So I am fascinated with this topic, which is safe vision in developmental disability. We all know that this is the most burning topic, and it's a niche where nobody takes a great interest. We as ophthalmologists also don't take much interest on this problem. So, and you'll agree with me that the pediatric eye care services in India are not all that great. So why are we, what's happening is that this problem is grossly neglected. It is ignored and missed by all of us. The main thing here is the human navigation, perception, and interpretation of the visual scene requires an interaction between the visual system, the motor system, and the parts of the brain, which serves for attention, perception, and cognition. So obviously, damage to the visual brain can result in impaired visual function, including perceptual and cognitive dysfunction. Now, the aim of this study is to have a standardized format for the vision professionals, that is the optometrist, and mainly the visual rehabilitation professionals, and provide training for using simple questionnaires in cortical visual impairment for special educators, occupational therapists, and other workers, and guidance. The main thing is the guidance to the family members and the parents, where most of we as professionals and other professionals say that nothing much can be done. So the aim here is to have a uniform practice guidelines in our country and to provide assessment, early intervention, and rehabilitation. And here, having so many stalwarts who are the head of the institutes and professors, I felt that this is the right platform to go about. So we all know that the poet says that eye is a window to soul. In my opinion, eye is a portal to brain. It's also a window and the tail of the brain. The brain connectivity and the visual acuity, is so well connected with each other that it is surprising to know that the 60% of the human brain is related to visual acuity. And way back in 2012, Nakayama mentioned that 40% of the brain is used for processing and supporting vision. So in my opinion, the vision loss is not just eye related, it is also brain related. So let's understand few facts, which of course you all know, that 80% of all the learning in the first 12 years is through vision. Only 1/3 of the children have an eye examination before entering the school. 60% of the students with learning difficulties have undetected visual problems, and only 11.5 teens have undetected or untreated problems. 1 in 4 school-age children have vision problems. Now, the object here is to detect ocular anomaly, record the visual acuity, treat the visual problems which are neglected, overcome visual handicap in time, and facilitate overall rehabilitation. And this is the statement which is so important, that the visual disorders are number 1 in childhood disability, and mentally and disabled children are twice as likely to have the vision problems. How early can the eye problems be detected? Intrauterine? Maybe yes, I don't know. Pediatricians detect these problems at the age of 18 months. We as ophthalmologists, we know that the eye fixation, the binocular single vision, fusion, and psoriasis takes place at 7 years of age. And you'll all agree with me that the visual system in an infant and children is dynamic and sensitive. So I have classified this basically into reversible problems, which you all can treat. For example, the refractive error, squint cataract, partially reversible like amblyopia, ROPs, and postural abnormalities. So almost 100% correction is what we as ophthalmologists can do. But there are some irreversible eye problems where our visual rehabilitation specialists can help us. So it is the late detection, or it is either ignored or overlooked. Now, incidence of visual loss in cerebral palsy, it was Peter Black who carried out a study and mentioned that 80% of the children with cerebral palsy have eye problems, and only 20% of the children have normal eyes. Our study, which we carried out on 154 children, we found out that 91% of the children had eye problems. So my question here is, how can this be incidental? Can we make a difference to the lives of many children and families and maximize their visual potential? Another interesting thing that I noted was that the children had multiple eye problems. It was not just refractive error or squint. Every child had, many children had multiple eye problems. Spectral therapy, we all know, imagine a child having impaired mobility, impaired communication. Over and above that, the child has a refractive error which can easily be corrected. And let's not forget annual checkup for these children. And early identification is so important, but the child himself or herself will realize that they can see the parents well, they can see the surrounding better. So this is so important, that which we can do. And there's a best visual outcome if it's known at an early stage. Now, the next thing is the refractive cycle. We have noticed that the hyperopia, which increases, which reduces with in a normal child, is retained in a child with cerebral palsy. Astigmatism is retained. Accommodation disorders are very, very huge in our children with cerebral palsy. So the high prevalence of refractive error is what we can treat it. Accommodative disorders are not only because of the problem within the ciliary muscle, it could be within and beyond the eye. And we need to give special attention to the accommodative disorders and astigmatism, because accommodation is an automatic, reflective, complex neuropathway, which we all know. And the child needs to use reading glasses. Strabismus in cerebral palsy, another important aspect. In general population, strabismus is only 3%. But see here, the children with cerebral palsy have 46% of squint, which is studied by Picasso and Alboy, Peter Black. And our study also, shows 49% of the children having squints. And the squint is not only related to the muscles of the eye, it is related to the subcortical, oculomotor, and cerebral area. And the severity of the squint is proportionate to the cortical visual impairment. And the treatment aspect we all know. So it's not always because of the refractive error on the muscles, it is because of the subcortical, oculomotor, and the cerebral area. Postural abnormalities, somebody also mentioned this morning that postural abnormalities are so important, and there's a deficient postural control, and there is a retrochiasmatic damage of the visual system giving rise to visual dysfunction. Irreversible problems, of course, we all know: nystagmus, optic atrophy, birth defects, ROP, retinitis pigmentosa, and fixation loss. And CVI is not a new terminology. In way back, it was, in 1990, this terminology has been used. And this is the place where our visual rehabilitation can do a lot of help for us. They play such an important role in assessing the extent of functional vision impairment. And we can make the best use of the remaining vision, which is often neglected. Because there's no point in telling every time if the child has CVI that nothing can be done. A lot can be done if you have a good vision rehabilitation specialist. This, of course, is a tree of vision, the functional vision map, which we all know very well. These are the two roots, that's the two eyes, and the visual pathway extends from the trunk to the occipital lobe. There's the dorsal and the ventral system, which are the two branches, and the clusters of visual difficulties you're seeing, which are the branches of the tree. And the vision part of the system, that's the visual brain, has the dorsal system and the ventral system. The function of our dorsal system is to help us to move in space, and the function of the ventral system is to help. So these are the difficulties which they have. So when the child is having cortical visual impairment, these are the problems that they face. And the anterior segment is normal. All the findings are normal. There's a fall of vision. So there's a breakdown in the connection between the eye brain and the eyes. So the child has the difficulty in processing and interpreting vision. So my opinion is that this is a multidisciplinary specialty, and that's the reason why I'm here. Is it, there are so many specialists involved in this, including, gynecologists, dentists, and of course, the main important things are the parents and the teachers. So let me conclude saying that we alone cannot do anything much. There are a lot of future study which can go on. So the take home message is awareness of visual disability is nil. Awareness of the associated ocular problems in the developmental disability with the help of visual rehabilitation specialists can go a long way. Detailed ocular examination is mandatory. Visual problems can be treated early to prevent visual disability. And awareness is like a sun. When it shines on things, they're transferred. So we need to catch them early, catch them young, and thank you for your attention.
That was a brilliant talk, Dr. Usha, and the best today, which I heard. Very nice. Really, I think you took a lot of pains to put together something, and there was a lot of message for all of us in this. The panelists can maybe just shift to the front. We have given 7 minutes to have a panel discussion. So the panelists are Dr. Jigdisha Sharma, Dr. Nikhil, Dr. Anupama Mahant, Dr. Palim Krishna Prasad, Dr. Madhvi Gupta, Dr. Rajshri Reddy, and Dr. Ramya Seetam Raju. If you all could come a little.
Yeah, they will be setting up the stage for the photograph. So until then, we need to have a panel discussion for 10 minutes. And we have a quick 3-minute presentation by Dr. Poonam Rohila from Sun Pharma. They are launching a new product. Over to Dr. Poonam Rohila.
Thank you, organizers, for giving us this time today. So I am Poonam from the medical team at Sun Pharma. Recently, we have introduced a brand Sequa, which is a cyclosporine 0.09%, but this is little different from the conventional cyclosporines that you are currently using. The TIFOS guidelines do mention about use of cyclosporine in the dry eye, and they also mention about use of non-preserved eye drops. But currently, the cyclosporine which is available has certain limitations. Briefly, we are aware that cyclosporine is a hydrophobic molecule and it has a low aqueous solubility. So therefore, it has to be developed in an oil and water emulsion. However, we are aware that an oil and water emulsion has its own limitations. For example, it can cause blurring of vision. It has to be shaken to resuspend the particles. And because it's oil and water suspension, the cyclosporine cannot easily penetrate the ocular surfaces. That's the cornea and the conjunctiva, where it has to act on the ocular surface disease problem. Therefore, this can possibly impact its onset of action. To overcome this, Sun has introduced cyclosporine, which has an N-cell technology. Briefly, the conventional cyclosporines are formulated in oil and water, as I said, and the oil size is about 100 nanometer in diameter. However, Sequa technology, the N-cell technology, has been prepared using nanomicelles, which has a size of 10 to 14 nanometers, so almost about 1/10 the size. The slide may not be clear, but this conventional cyclosporine is a milky white appearance. However, Sequa is a transparent solution because it is an aqueous based. So because of which it overcomes the problems of blurring of vision. Second, because it is having nanomicelles of 12 to 14 nanometer, it has better partitioning of cyclosporine through the ocular surface, which has a better ocular bioavailability and therefore a faster onset of action. This is briefly about the nanomicellar technology. As you can see here, these are the micelles. These are the micelles. It has a hydrophilic end on the outside, lipophilic end on the inside, in which cyclosporine is encapsulated. Here in the conventional cyclosporine, the cyclosporine doesn't enter the ocular surface easily. But in the nanomicellar technology, cyclosporine easily enters the ocular surface where the inflammation exists in the dry eye, and therefore it brings about its effect. This is a clinical study which was done to see the concentrations of cyclosporine present in the ocular tissues compared to Restasis and the Sequa technology product. So red is Restasis. This is conjunctiva, cornea, sclera, aqueous humor, and iris ciliary body. The green and the purple bars represent the Sequa technology products. So you will see compared to Restasis, the red bars, more concentration of cyclosporine is produced in these ocular tissues as seen in the green and the purple colored bars, which indicates that the sequa technology helps the cyclosporine penetrate deeply into the ocular tissues. This is briefly the clinical trial program of sequa. There is a phase 2B study, there is a phase 3 study, and there is a long-term extension study. This is a very busy slide, but I will simplify it for you. It was a phase 2B3 study conducted in almost around 500 patients across 29 sites. It was a randomized trial, 1:1:1. There was a placebo arm, and there were two arms of sequa technology products, one with 0.05 and 0.09. As any other study, the study was designed to have its primary and secondary efficacy endpoints. So briefly, the study did meet its primary and secondary endpoints, and therefore it was taken up for further development in the phase 3. This is just a slide to summarize the findings of the phase 2 study. As you will see, the Schirmer's improvement, which was seen with sequa 0.09, there was a 3.5 mm increase in Schirmer's compared to the post-hoc analysis showed that almost 17 to 18% of the patients had a Schirmer's more than 10, which is something we really need in our clinical practice. Phase 3 design, 750 patients at 45 sites. Again, the study met its primary and secondary endpoints. Briefly, 17% in the sequa arm had Schirmer's more than 10, which indicates confirmation of the phase 2 findings. These are the secondary endpoints which were also met. Safety, there is instillation site pain reported, which is very typical of sequa. However, this was mild in intensity and did not lead to discontinuations. This is an open label extension study of the same phase 3 for 52 months. The patients were and it was well tolerated and safety findings consistent to the previous 12-week study. Briefly, the conventional cyclosporine produces its effects at 6 months in terms of improvement of corneal staining, and only 15% have Schirmer responders at 6 months. However, sequa produces onset of action as early as 1 month, and the patients start responding as early as 3 months when it comes to Schirmer's improvement. And blurring of vision, as I mentioned, it's an aqueous solution, so no blurring of vision was seen. So thank you so much for your time today. And I have the pleasure of having my guru in front of me, Dr. Lahane and Dr. Rashmi. So thank you, sir. It's an honor to stand before you and present.
Thank you so much, Dr. Purnima. Thank you very much. Then we have the 1-minute video from Ajanta. And
And in case anybody of you is interested, we have
Video.
the sequa booklets behind. Thank you so much.
Nee, adhan hachcho, adhan hachcho. Hachapa. Okay. So just one question, few questions until they set it up. The panel discussion, is the examination system what we are having in India? Is it the ideal system? Malini madam, quickly we can answer that until they set up the stage for the photograph.
It depends what system in which the students, the MS has a different pattern and DNB has a different pattern.
Louder.
Need to speak louder, they are saying, madam.
No, I think I'll ask this. Do you think our present examiners should have 6 monthly, some kind of a training program to become better examiners? Since all the examiners are sitting here, we are not going to keep talking about how to improve the students, how to improve ourselves so we become better. And even if this thought process is discussed now, it will take us forward at a later point.
No, not necessary to go for any training or anything. If he is a good teacher, definitely he is a good examiner. So no point of.
No, not that way. Sometimes what happens, you become complacent and the latest things are not brought out. Now, like in a DNB, especially, there are very latest questions and all are asked. So, the pattern of examination, pattern of questions are all changing, always evolving.
Hello.
So if we could have not an exam, some kind of a refresher course kind of thing, it will be so useful for all of us is what I thought.
See, whatever may be the examination, whatever the latest comes, as a teacher, you should update on its own. It's a must. So no, there's no point of secondary training or whatever the thing. Otherwise, he is not a teacher at all. As a teacher, always he is going on updating his knowledge. Then only he can manage to have the postgraduate students.
Yeah.
No answer.
I have to comment on this because I am DNB examiner as MS examiner, and I had been going all around India now. And to me, it appears that most of the institutions, it depends upon the internal. Some of the institutions, they start exam at 9 o'clock and they finish by 3 o'clock and then they will have lunch. And in some of the places, they will start the exam at 11:30. So it should be objectively structured examination. The students should be given sufficient time and then there should be objective method. Now for that, the examiner, yes, I know that you want to say your opinion is old school of thought that I am the examiner, I know everything. No, sorry, sir, you are very senior. But the younger generation is that they want to assess properly. And I have seen that the determination has gone. The students are not up to the mark. And the examiner, they feel that, okay, all the students are like that. Some of the students are very good, but then they are not assessed because it is not structured exam. In some of the institute, it is like all the examiners are sitting on the table and the student is coming and then everybody is putting marks and only the marks of the external are taken care of. In some of the places, there are two tables, one is two pair are there. One is internal, one is external, one is internal, one is external. In some places, there are 4 tables. It all depends upon, because there is no universalization in India. Some of the institute, they will have some different kind of exam. For that matter, I think BNB has a proper structured examination pattern. And the examination should start sharp at 9 and should not finish before 5 or 6 o'clock. So that the ample time is given to the student to explain and to prove himself. Because we are just examining what he knows. We do not know everything. Actually, there is no internal assessment system. There has to be internal assessment system on 3-year postgraduate training, but there is no internal assessment.
Like the DNB, they have those FAT exams, internal exams, which they have. If we could have a system where we could collate those marks also, so that even that is added up to the final. I mean, there are so many ways. I think we are engineering ourselves in technology and techniques and so many things. So if there could be ways of engineering.
Just to expand on that further, ma'am.
it's an MS course is a 3-year course and you are just getting assessed, like sir was saying, sometimes it's only 11:30 to 3 o'clock. It's not really a fair assessment. Probably having, in fact, an ideal scenario would be wherein we are talking about super specialty training now, wherein you actually have modules where each of these are assessed. You could be basic sciences in the first year, and you could be, the other important topics on maybe a quarterly or a biannually basis, wherein those marks are added on to the final totals. That's a very ideal thing to do.
Yeah.
You want to make a comment?
Dr. Patel, Dr. Alok Singh, Dr. Ramesh Babu.
Anybody wants to make?
Dr. Ramesh Babu wants to add. Anybody else who wants to think how we could further improve the system?
Ma'am, from yesterday, one question which everybody keeps harping on. Why are DNB students being failed? That is the first question. So for that, they are trying to find answers. Most of the faculty here are also DNB examiners. Just like no doctors goes to kill a patient, no examiner goes to fail a candidate. So the question is about, are the assessment which have been done, are those test elements testing what it is supposed to do? In fact, we always say that compared to MS examination, DNB has a more relevant pattern, having specific elements being examined. Now the question is, why that elements are not also being used as assessment tools during the training? If you use it during the training, ask is if they are able to crack easily, I don't think they will fail in practical exams at all. So the solution possibly lies in implementing all the test elements which are being examined at the summative exam during your routine monthly assessments or quarterly assessments. You do that, it should really be well.
So in DNB,
I always say it is a much better system than the MS examination pattern, where you have a standard one essay type. Why should there be one essay? You don't know one essay, you're gone. If you have 10 questions, one of the common inequalities is every university is not following the same pattern. Some universities have 10 questions, 4 papers. There are many places where there are 2 25-mark questions or 20-mark questions, and then there are 5-mark questions. So if you do not know one, you are lost your paper.
Yes, Dr. Pandal, you want to add something, Doctor? So these controversial things were brought up not to question ourselves, it's just so that how to make it so standard and perfect and different that our students gain maximally from the exam and go very happy. That was the thought. So that I wanted to just fill all our minds to think of ways to improve these things.
I think a lot of points have already been brought out and highlighted, and rightly so, because our examination system is not uniform at all, because every institution have their own way of doing it. And that's why I think DNB was mentioned, that DNB is, I think there's a standardized, some uniformity is there in DNB, I think. So that's why it's more uniform. And whether they're failing or passing, I mean, that's a different issue. But I think they're following a good system, I would say, and the MS examination definitely is very, very variable. Having said that, I think all the points that we have discussed today, in assessment and how to make an assessment in the end or during the course, I think all those are to be basically implemented. Is only because we are not implementing all of those concepts. That's why there's a change, and there's a discrepancy. But once we are aware through this kind of programs, once we know what needs to be done, I think gradually this will come into practice, and it should come into practice. Thank you.
The only thing is regarding the DNBs, as I was telling regarding the Viva OC, the MS students are always a little bit privileged because the examination is usually conducted in their own medical colleges. They know their internals, and there's little bit of tipping or any mistakes being happening and all, they are being prompted. But in DNB, I think it doesn't happen like that. They go from the different colleges where they don't know anything, they have to settle there. And sometimes they fumble doing the refraction or whatever it is because of too much of tension which some students take. I think a little bit of the uniformity in the pattern is very much required. If we can stop traveling these kids from No, I'm not telling in that way. No.
DNB is better.
I'm trying to bring out the advantages and disadvantages of both the system.
Both the system, so that we
Both the systems have advantages and disadvantages. MS has its own advantages.
Yes.
DNB has its own advantages. But the only thing is the DNB is the practical facing things, which I have seen literally. And they take 1 month extra leaves, or I have not prepared. I don't know who will be my examiner. I have to do that. And all these things we keep seeing in there. So a little bit of uniformity, if it is there. And yesterday, a few of the examiners were telling that the DNB, even after giving the difficult exams or whatever it is, still they are not being recognized in the medical colleges, which we still have to agree with that. So even being a competent ophthalmologist, giving the theory exam, giving the practical exams and all those things, and still they want to join a medical colleges and they are not being recognized, is a little bit disheartening.
Yes. There is a lot of, just like in every system, changes have to come in. I think it's some more standardizations, and we come to a system where the Indian system is the best. That's what we want. That's all.
Like one of the presenters telling about the feedback at the end of examination to the students.
Yeah.
Actually, it should not be very informative. Sorry, summative. Like you can tell about the better performing students better, and so they will immediately know the results. So it not be in summative, maybe informative, as in case happening in DNB, it may be okay, not in other exams.
The formative assessment is really good, and it's periodically
evaluating the
students, and they get to do the even formative. They go to the other institutes, not in the same institute, and they interact with the other students, so they know what are they lacking, and in that way they can improve on the weaknesses.
Yes, as I was saying,
I think yes.
One more thing, like the sir has told, the exams conducted between 11 to 3 o'clock. Sometimes the exam are coming under pressurizing the internals. I want to go by my flight is 4 o'clock, 5 o'clock. In that situation, the internal now have control over that externals.
So one more thing is, actually, after every year, if you conduct the exam, that would be more better, because this is a 3-year course. So that would be more. Theory can be split into 2, means 4 papers in the first year.
Like a semester kind of system could
Yes.
be. Actually, I'm just sharing what we are following right now. See, the thing is, nobody prevents us from conducting a formative assessment. And we are doing that at the end of each year. So at the end of first year, they have a centralized formative assessment, theory and practicals. At the end of second year, they have. At the end of final year, also mock exams, mock prelims. And what we also do is we invite examiners from neighboring colleges. So we sort of give them an experience of, how to deal with examiners who are not new. And we also follow this system, whatever the objective way of assessing them. We are already following where in Viva OC or practicals, we judge each aspect of the case, and we also time the cases so that each candidate gets 15 minutes per examiner. We're trying to do that to bring in objectivity. So it's left to us also how we can make it uniform and fair.
I think we need to go on to taking the photographs so that all of you enjoy a little bit of Goa.
Center, because now that our students are coming to us, they are little more complacent. So the same thing that we do there.
And last but not the least, we have a training the trainers program at AISC Kochi. It is on Thursday for 8.5 hours. And it is a different angle of looking at it. Like these 3 days for you all has been different and amazing and food for thought. I would, on behalf of ARC, I would be most obliged if you all are there at ARC Kochi, please do come for the program. The speakers are very good, and there would be something different and something more, and we would learn from you and you would learn from us. So please, would be very obliged that you are there.
Thank you, Chitra Madam, for moderating it so well. Thank you, expert panel. I request Santosh sir to please come up and give his final comments, and request all the seniors, the HODs, to please be seated.
And all the juniors, we will stand at the back. Lane sir. Hey, आप शुरू कीजिए. Madam, Pandav sir. Sir, all requesting all for the group photograph. I think they have planned it in 3 layers.
As we are ending, I just want to thank you all for sparing your time. Enjoy the rest of the time in Goa. Thank you so much.
So we don't want you to miss out the sunset at the beach side. So we'll have a quick photograph, then go for the sunset, and then we'll come back for the banquet.
Teachers can become teachers now.
What is this? Hey, Srinivas. Everybody has to go to the beach. Smile, smile. All of you smile. No, smile. Thank you. And before you all move away, I have one final 3 sentences to ask you or tell you all. I would want all of us to remember Dr. Santosh Honawar, who is standing for the Honorary Secretary, and he's been doing a consistently great job. I want all of us to remember Dr. Srinivas Joshi, who's standing for second term for member ARC, and he was a true gem and a great help and support to me. And I would be finally obliged with all of you all, if you think that in the last 3 years I have given my life and soul to ARC, then I would want you to, with folded hands, I want you to remember me favorably for this course. Thank you very much.